So a very good morning to everybody here. Hopefully some of you were able to see the sessions happened yesterday. We had Super Day 3 session. My name is Amal Ibrahim. I would like to welcome you all to the American Healthcare Summit, Nursing and Patient Safety. And we will now begin the Day 4 sessions for the online sessions. So let's start with our first speaker for today. I would like to introduce our first speaker of Day 4, Dr. Muhammad Al-Mubarak from KSA, consultant physician, accreditation consultant, CPHQ, CPHRM, CPPPS, Lean Six Sigma, Master Black Belt, Patient Experience Professional. Dr. Muhammad, the stage is yours.
Good morning, everybody.
Hello, good morning, Dr. Muhammad.
Yes. I am about 80,000 miles far from you. We are now evening time at 7.
It's our pleasure to have you with us today.
First of all, I start to thank the organizing team for inviting me to this conference. And special thanks to Amal, because she's always cooperative, and I thank her for her assistance.
You are always welcome, Doctor. It's our pleasure, really.
And I start with hats off to nurses.
Mm-hmm.
My advice to nursing: without foundation of caring, your skill will not benefit you.
Mm-hmm.
Caring for yourself and caring for others. We have today two presentations,
mm-hmm.
And this is the first time that I participate
mm-hmm.
with Zoom, because I would like to see the people and to have eye contact for better communication. But anyway, I am happy to speak to you. I hope that you can benefit or you get some more information or reminder from my two lectures. We start with risky business. This is our business as healthcare, which is a risky business. We will have some introduction, some statistics and categories of hazards, workplace violence, and we have summary and conclusion. Let us start with the introduction. Healthcare workers face wide range of hazards on the job, including sharp injuries, chemical and drug exposure.
Mm-hmm.
Back injuries is very important actually for nursing population. Latex allergies, violence, stress. Although it's possible to prevent or reduce these hazards, healthcare workers continue to experience injuries and illness at work. Look at these nice pictures. While hospitals are designed to be places of treatment and healing for patients, they present a significant number of occupational hazards to healthcare workers. I don't want to shock you with statistics, but numbers always better for better understanding. According to National Institute for Occupational Safety and Health, NIOSH, about 600,000 to 800,000 percutaneous injuries occur annually to healthcare workers in the States. Nurses sustain the majority of these injuries. In particular, nurses working in perioperative area due to prolonged exposure to open surgical sites. Healthcare workers are exposed to many safety and health hazards, including violence in the workplace. And according to previous estimate of BLS, Bureau for Labor Statistics, about 2,600 assaults on hospital workers occurred in 1 year at a rate of 8.3%, 8.3 per 10,000 workers. Look, this is the healthcare industry, but in other industry, it is only 2 per 10,000. There is a huge difference. The most dangerous industry actually is the healthcare industry. Healthcare workers are 41% more likely to need time off due to injury or illness than employees in other industries. Time off, that means more expenses for the institution and more loss. Look at this nice picture. Actually, we can make one presentation only with this one slide. It explains a lot, actually, particularly for nurses. You will see falls, prevent suicide, patient identification, improve communication, hospital infection. All these aspects we can talk from now till tomorrow on one slide. Occupational hazard to which healthcare worker may be exposed can be classified into 5 broad categories: biological, chemical, physical, ergonomic, psychosocial. Exposure to blood-borne pathogens from percutaneous injuries, exposure to infectious microorganisms, exposure to biological components of surgical smoke from use of lasers and electrosurgical units, exposure to allergies, particularly in latex gloves, potential high-risk group of healthcare workers for acquiring blood-borne transmission pathogen is laboratory personnel, surgery personnel, others like dentists and public health people. Blood-borne pathogen, exposure to blood-borne pathogen, including HIV, hepatitis B and C, and other potential infectious materials, put healthcare workers at risk when handling sharp devices. The pathogen of major concern are HIV, hepatitis B, and hepatitis C. But we should know that neither hepatitis viruses or HIV can be transmitted by casual contact. Needle stick injury, it is a problem in every hospital, everywhere. Needle stick injuries are a common event in the healthcare environment. But fortunately, most needle stick do not result in exposure to infectious disease. According to hospital studies, needle stick injuries occur most frequently in patient rooms, and as many as 1/3 of all reported sharp injuries are related to disposal process. We are seeing that every day, disposal process. Some example like hepatitis B carries the greatest risk of transmission by about 37% of exposed workers. But when it comes to hepatitis C, it shows much less transmission rate by 1.8, and recent surveys have shown only 0.5% transmission rate. HIV transmission rate is 3 per 1,000. That means 0.3% and less than 1 in 1,000 following mucocutaneous exposure, and has never been recorded following contact with HIV blood with intact skin. Further data shows in an average healthcare worker incurs approximately 30 needle stick injuries per 100 beds per year. Unsafe handling of sharps is the leading cause of injury. Unsafe handling. That's what I told before. We are seeing that daily in hospitals. What is the recommendation for that? Actually, we see it is in our hand. Hepatitis B immunization is mandatory. Compliance with standard precaution. Healthcare worker must be trained to use the various devices. Do not bend, recap, or remove contaminated needles. Use of needle containers to discard contaminated needles. Container must be closable, puncture resistant, and leak proof on sides and bottom. Containers must be colored red or labeled with biohazard symbol. Use of capillary tubes that are not made of glass. Use of needleless connector system with IV setups. We come now to airborne transmission of pathogens. One of the most hazardous risks in hospital is the airborne transmission of infectious organisms, such as TB, influenza, avian flu, H1N1, and COVID-19. The most effective ways to control respiratory hazard is to follow correct work practices and suitable masks. Latex allergy. Healthcare workers are at significant risk of developing latex allergy from exposure to latex products. Where we find latex product, as we said in the gloves, examination, surgical gloves, blood pressure cuffs, stethoscope, airway, IV tubing, and such. They will develop nasal and eye or sinus irritation, hives, shortness of breath, coughing, or wheezing. Recommendation again here, healthcare facilities should stock appropriate gloves for latex-sensitive employees, because our employees, they are precious to us. Ensure appropriate PPE. Do not use latex gloves when there is no risk to exposure to blood and infectious disease. That means we don't want also to overestimate situation. Now we come to chemical hazards. Chemicals found in hospitals can be in the form of dust, vapor, gases, or liquids. A chemical can enter the body in 3 ways. It can be breathed, it can go through skin, it can be swallowed. Many chemicals can cause serious illness. Are you hearing me, Ms. Amal?
Yes, I'm hearing you, Dr. Mubarak.
Chemical hazard. Hospitals are required to provide staff with information regarding hazardous materials. We should have the MSDS, the Material Safety Data Sheet, that we can know how to clean up, spill, how to protect ourselves. Ask always, when you come new to a place, when a nurse's station, where is your MSDS? Example of agent, chemical hazard, acetone, alcohol, ethyl, isopropyl, methyl, xylene, formaldehyde, cleaning material, ethylene oxide. Anesthetic gases, nitrous oxide, halothane. Waste gases result from poor work practices during supplying to the patient, improper maintenance of the anesthesia machines, etc. Compressed gases are used in laboratories ammonia, carbon dioxide, and nitrogen, antineoplastic drugs such as vincristine, dacarbazine, arabinozide, and fluorouracil. Ergonomics, we come to ergonomics. This is a very important. Everything is important, but really is you have to pay attention to the ergonomics because we are practicing that even at home. Is the application of scientific knowledge to design of environment, tools, workstation, and the content of work to suit the mental and physical capabilities. That means adapting the environment to the person in order to avoid musculoskeletal disorder. Adapting the environment to the person, not the person to the environment. One of the most common severe hospital injuries is musculoskeletal injuries, particularly low back. People of nursing occupation sustain 53% of these injuries and even more. Healthcare workers lift more weight than they are supposed to. We are doing that even at home. We have to watch that actually. We have to, maybe we'll think it will cost a lot of money to rearrange places. It does not cost a lot of money. Of course it costs money, but the absenteeism of employees costs more money and loss for the institution. Physical hazards, ionizing and non-ionizing radiation, electricity, noise, heat are examples of physical hazards found in hospitals. Ionizing radiation used in diagnostic procedures such as X-ray, fluoroscopy, angiography. Non-ionizing radiation includes microwaves, magnetic field, and laser. Excessive noise and heat, commonly found in kitchens, laundry, boiler room. Cold and heat and sunlight are hazardous for ground and building maintenance personnel. But when it comes to noise, WHO recommends between 30 or 35 to 40 decibel in hospitals. But as an example, in ICU, patients suffer from sleep deprivation from noise coming from nursing interventions and ambient noise. According to research, the noise intensity is more than 60 decibel in hospitals. That means double the recommendation of WHO. Psychosocial hazards, many factors in the hospital environment can affect psychological and social well-being of healthcare workers. Excessive job demand, role ambiguity. We have to educate the people to teach them really their role, what is job description. They should know it. We are giving the nurses tasks where they shouldn't do it. Inadequate resources, shift work. Of course, this is the biological clock of the person, of the human being. Yani, combative patients, terminally ill patients, and co-workers or managers are also stressful. Violence in health care has been a problem for a long time and has become a topic of concern. I don't want to shock you with this estimate, but an estimated number of 106 healthcare providers were killed at work over a decade, including pharmacists, 27, physicians, 26, nurses, 18, nurse aides, 17, and others, 18. It is shocking. Several studies indicate that violence can often takes place during times of high activity. Let us watch that. Mealtime, this because of the contact, visiting hours, patient transportation, when service is denied, involuntary admission, when healthcare worker attempts to set limits for eating and drinking and smoking. Who is at risk? Although anyone working in the hospital may become a victim of violence, nurses are at higher risk because of the patient contact. That's why hat off for nurses. Where may violence occur? Violence may occur anywhere in the hospital, but it is most frequent in psychiatric wards, emergency rooms, waiting areas. Emergency room and waiting areas are overcrowded, geriatric units. Safety tips for that, you have to watch for signal that may associated with impending violence, like what? Verbally expressed anger and frustration, body language, signs of drug or alcohol use, presence of weapon. What to do? Maintain behavior that helps diffuse anger. Maybe it's not easy, but we have to do it. Smile, caring attitude, be alert. According to a survey of registered nurses by the American Nurses Association, stress, overwork, disability, back injuries, and contracting blood-borne diseases are the top 3 health safety concerns. Of particular concern to an aging nursing population are ergonomic-related injuries, as we mentioned before. In summary, what should we do? Infectious disease can be caused by coming into contact with germs when handling patients, hepatitis B, C, HIV, etc. What to do? Provide policy and procedures, ensure availability of gloves and other PPE, establish SHARP program, establish immunization program for all healthcare workers. What can you do as an employee? Wash hands frequently, properly, follow policy and procedures. Back injuries are the most frequent injuries in hospitals. Heavy lifting, bending, twisting. What can employer do? Train staff on proper lifting and technique. Stop as much as possible manual lifting. Use mechanical devices. For you, what you have to do as a nurse or healthcare worker, get help for lifting. Don't do it alone if you cannot. Use proper lifting technique. Shift work. Changing shifts and working only at night disrupts your body natural rhythm. It can cause sleep problem and makes family life difficult. What to do? What can the employer do actually? Avoid permanent night shift. Limit the number of nights worked in a row. Give 2 days off to a nurses. Keep schedule regular. What can you do? Ask your doctor's advice before becoming a shift worker. If you have diabetes mellitus, if you have asthma, if you have epilepsy, avoid caffeine and smoking and sleeping pills. Chemicals, again, what to do? We have the material safety data sheet for the policy and procedures. Remember, hand washing is the most important infection control measure. The least expensive infection control measure and the most ignored infection control measure. Really. This is from my experience. I have been about 29 years in working in hospital, 15 of them in a leading position. I climbed from OPD manager to medical director to CEO of the hospital with 3,000 people. Remember also coughing and sneezing etiquette. A sneeze can travel over 100 miles per hour, project out 5,000 droplets containing around 10,000 bacteria, and can move up to 12 feet. Don't be shocked. Only coughing etiquette. Conclusion, maintaining hospital safety is a shared responsibility between all healthcare workers, staff, students, volunteers. Prevention, the best cure. The 4 steps system: spot the hazard, assess the hazard, fix the problem, evaluate the results. Thank you for listening to me. I hope I did not shock you, and I hope that I could add something to your knowledge. And inshallah, if there's any question, or we can see you in the next presentation. We have a very interesting topic, ethics. We have a lot of questions maybe.
Inshallah. Thank you, Dr. Muhammad, for your great and informative topic. If anyone have a question, just raise your hand or type it in the chat box, please, before I will start my questions. Or if you have any comments, it's the time for your comments on your questions.
Don't be shocked.
Okay, Dr. Muhammad, let's start with my questions because I have 4 questions for you. The first questions that, in your opinion, how we can reduce the violence in the workplace for the healthcare workers, especially for the nurses, because they are the most violent healthcare professionals in the health industry?
Yes, first of all, actually, it comes to my mind, first of all, the shortage of nurses. If we have enough nurses, they will have time to interact with the people there in the world. But if they are shortage, they have a lot of things to do, and that's why it comes that the patient will feel neglected. Secondly, we have to have really a very clear policy and procedures. We have to have our security guard everywhere, particularly during visiting hours. And we have to teach our staff to see the signals of impending violence.
Great. Okay, regarding your topic, healthcare workers are exposed to many safety and health hazards, including violence in the workplace. Occupational hazards can be classified into 5 broad categories. Can you briefly mention the 5 broad categories?
This is what we mentioned before.
Yes.
Yes, it's the chemical hazard, violence in the workplace, ergonomics, and the other 2, let me remember. The other 2, they are, well, maybe you can help me, I forget maybe. Let me remember.
The economical, the chemical, and the occupational. Okay, also we said okay. In your opinion, what's the most risky factors of those 5, and why, or all of them?
Can you repeat, because the voice was not clear?
Okay, we have 5 broad categories for the occupational hazards. In your opinion and in your point of view, which one of them are the most risky for the healthcare worker life, and why?
Wallahi, you see that they are all risky, because it is difficult. Maybe it is different from place to place. If you're working in psychiatric hospital, it will be different. If you are working general ward, it will be a little bit different.
Yes.
You're busy a research facility, it will be different. That's why. But the main group is actually biological and chemical.
Yes. Okay. Is there a relationship between the working long hours, shift nights, with the Patient safety and nurses violence. Is there any relationship?
You mean violence from side of the nurses
Yes.
themselves?
No. Violence from the patient's family, according to the healthcare workers,
okay.
the nurses.
If in the night shift, if the night shift, of course it is. If the as I told you before, if the nurse is tired, because we know we see some distribution sometimes, we have really only 2 nurses running there and there during the night, and this is very actually it's a huge burden of the nurse with a 30-bed ward, and you see 2-3 nurses running there and there. Of course, this will increase the possibility of violence, because the patient will feel neglected. Here comes the administration, the leadership.
Great. And my final question is, what's your advice for the nurses to take care of regarding the violence and occupational hazards during the pandemic?
The pandemic, we have to stick to policy and procedure. Actually, if the policy and procedure are clear, and it will be less. We have less problem for the staff, but the problem, our staff, they don't ask. Do you know why? Because of the fear. They are shy or a fear. You know, fear is actually destruction of the institution. That's why policy and procedures should be clear and simple, not in a style, complicated style. I don't want a lecturer to write for me policy and procedure. I want to be practical and simple and short policy and procedure.
Yes, great. We have a small comment from Ms. Anit from Saudi Arabia. She is speaking about, or write a comment, we forgot the effect of noise in critical care. And yes, I am agreeing with her. Ms. Anit, if you are with us, can you explain more about your comments, please?
Amal, can you hear
my
me?
dear.
Hi, how are you?
I'm fine, thank you.
Good. You know, there is a term that I call alarm fatigue or noise fatigue. Imagine that's the whole day what you hear is alarms. If it's not the ventilator, it's the monitor. It's the monitor, it's somebody screaming, or it's the whole time noise. And that also causes a lot of stress on staff. And sometimes if they fatigue of all the noise in the beginning, everybody that they get anxious and they will answer the alarm immediately. But most of the times later on, they ignore it. And that is also not very good. That is where also patients will say, oh, they don't come and listen to me. They don't hear what I need and everything. But imagine you are in a critical care unit. You've got ventilated patients. You are 2 people on the floor. You've got maybe 5 patients. It's very, very hard. And then it's alarms, and it's the patient needs, and it's also what's needed from you. And this is the truth, you know, the alarm fatigue and the noise fatigue is very huge in critical care.
Yes, thank you for your lovely comment. Dr. Muhammad, do you want to add any more with her comments?
No, actually, it's very fine, actually. And as I told you, it is really, it is noisy in critical care. It's noisy, but how can we avoid it? It is maybe in the future there will be better technology, but believe me, every technology will bring another problem with itself.
That's true, yes. Is there any more questions or comments? Just type it in the chat box or unmute your microphone. Thank you, Dr.
I think-
Muhammad, for your, yes, Doctor.
No, I want only to, for our nurses, really, communication is the best. You know, that's the second patient safety goal. Communication, improve communication.
Yes, of course.
Communication is very important. And really, they have to watch body language. Body language explain more. It is, we can explain with body language more than spoken words. They have to watch that. Maybe we have to give our nurses also education, some lessons or some training in body language to understand it actually better. What is impending violence? How to watch it? How to see it really in live, or we can share them with videos or something like that.
Absolutely, absolutely. Thank you, Dr. Muhammad, for your first informative and important speech. I would like to ask you to stay with us for your next presentation. And as we have a lot of speakers today with great and informative topics, let's continue with our next speaker, Ms. Colonel Robin Phoenix Johnson from the USA, regarding she has a last-minute emergency case she won't be able to present, and we will play her recorded video. Her speech will be about on heal areas, applying humor to your whole health, wellness, and strategy. So give me 1 second, please.
Good morning, happy Friday, or Friday, as I like to say. I'm Robin Phoenix, and I will be presenting on Hilarious, the power of humor. Laughter is the best medicine. It's an old adage, I know, but it is very powerful and it works. I'm going to share with you about a pilot program I'm doing with veterans struggling with PTSD, severe anxiety and depression, and how that's going and some lessons learned. So first, a little bit about me. Trying to move this presentation right along. I am a 26-year Army veteran. I served from the ranks of private up through Lieutenant Colonel, retiring in 2020. I'm also an Army wife. My husband was an Apache pilot for over 20 years. He's also now retired. During my time in service, I served through 5 tours in Afghanistan and Iraq. So you can imagine that I have a lot of comedic material and stories from those experiences. I'm also very blessed to be the mother of 2 children, which I would argue raising children is so much harder than deploying and going to war. They're like my biggest battle. I was talking to a lady last night and she has dogs, but not kids. So she's a dog mom. And she tried to tell me that she understood. I was like, no, ma'am, dog moms are like the vegan chicken nuggets of motherhood. It is not the same. But this is my family, and like I said, serving in the Army for me was just a wonderful experience, but also very challenging. I suffer from PTSD and depression myself, which brings me to Robin Phoenix, which is my stage name. I realized when I left the military that I could do really whatever I wanted at that point. I had served a distinguished career, and I could do anything. And so I decided to pursue comedy. I'd always been a consumer of comedy. I love stand-up. I love making people laugh. And I thought at first I would just do it for myself, my own mental health, kind of like taking a yoga or a Tai Chi class, just something to bring me peace and deal with some of my anxiety and PTSD. Once I got started in it and realized how amazing the benefits were and how much our veteran community could benefit from humor, I joined the Association for Applied and Therapeutic Humor, got to meet Dr. Shidama, which you heard from the other day, and really get connected with a whole group of professionals that also saw the value in humor and how we could apply it in so many ways in a medical or clinical setting. So now I am a speaker and I produce comedy shows, I perform at comedy shows, I'm on tour. So you can look up my website, bestmedicinebrigade.com, to see where I might be performing. I'm actually performing in Norfolk tonight. So if you're in the 757 area code, come on out. A little shameless plug for that show. But I live in Charleston, South Carolina, so I'm based in what they call the Low Country, so the coastal eastern coast of the U.S. So a few hours ahead of you guys over in Pacific time. But that is what I'm doing now, and so let me get on with Best Medicine Brigade. This is something that I founded, which our mission is to be hilarious, to heal people, organizations, and communities through humor. Produce top quality comedy showcases. We do boot camps, motivational speaking about the applied and therapeutic use of humor. The thing that I'm most proud of is that we also facilitate humor groups for veterans. I do this with a team of 17 other comedians. They're all professionally trained comedians. They're also all veterans or military spouses. So we are very excited to do this. Currently, our work is mostly volunteer. I do this just because I know that it does make a difference. However, we are working with the VA to get some funding so that we can really scale this beyond the 3 facilities that we're currently at. So I'm excited to share with you some lessons learned. Well, first, I think it's probably not rocket science to all of you who are in the medical field and understand really the value and the science behind humor, which is it facilitates digestion, right? It increases your antibodies, it improves your memory, it reduces pain and aids in the healing process. It kicks your immune system into high gear. And you can see here that it's really, really important for reducing vascular inflammation. Which is great, by the way, because I am very sore. I am 46, and I had decided that I was going to drop it like it's hot at a friend's birthday party, which when you're 46, you cannot drop it like it's hot. You can drop it like it's lukewarm, You cannot drop it like it's hot. And I accept responsibility for that. I tore my hamstring. It was very painful. But I have to blame the DJ a little bit. I feel like DJs should share some of this responsibility. If you see a group of 40, 50-year-old women come into the dance floor, you can't just go to the booty shaking music right from the beginning, right? You've got to ease us into it. You need to give us an electric slide warm up. We need you to ask us for 1 hop, 2 hops before you ask us to drop it like it's hot. That's all I'm saying. When I continue on with the science behind humor, as I digress telling you my story, I love infusing jokes and stories throughout my presentations. So I hope that this will make your Friday morning a little bit more cheerful and fun. We know that laughter increases the heart and respiratory rates, as well as oxygen consumption over a short period. 15 minutes of laughter may burn 10 to 40 calories, which, hello, I don't know about you, but I love that because I'm like 140 pounds. I mean, the scale says 160. I identify as 140 pounds, so I love the fact that it helps burn calories. It also revs up the sympathetic nervous system without increasing blood pressure. It lowers the levels of cortisol, which is the stress hormone. It activates the mesolimbic, and I can never say that right, dopamine reward system. It makes you happy. Dopamine, love dopamine, favorite drug of choice. And it raises the levels of beta endorphins. Those are the feel-good chemicals of the body. And of course, increases the human growth hormone production. So what we do in the hospital setting, under the supervision of mental health providers, we engage with the veterans and ask them, how recently have you laughed? How can you find humor? How many times did you have a good laugh? Is it enough? And really help them take some of their stress and their trauma and turn it into something funny. We have a series of exercises that we do with them. Sometimes we perform for them, and sometimes we facilitate comedy bingo. Comedy bingo is a hybrid of performance and interaction. This is particularly helpful with some of our traumatic brain injury patients and our dementia and Alzheimer's patients. With the help usually of a nurse or an assistant, we slow down our delivery some. We have comedians that come in, they tell their set like they normally would, and the words to the set are on bingo cards, and they get to listen for the words as the performance is happening. And we do this both online and we do it in person. And in most cases, it's a hybrid where we're presenting in person and then there are people joining us virtually. So it's been really effective, and it's been one of the most well-attended groups for the VA hospital. And I'm proud to say, a little humble brag, that my humor group that I lead on the Charleston VA Hospital right now is one of the most consistently and well-attended groups of all of their offerings. So it makes me feel good to make that kind of impact. I do work with both outpatient and inpatient veterans. The inpatient is extremely challenging. As you can imagine, they have much more severe diagnoses, and also mostly they are not there by will. They're usually admitted against their will, and so they're not especially happy to be in the inpatient ward. They're also probably they are more likely to heckle and to try to disrupt the performance. But I look at it as an opportunity for me to engage with them in a different way and to bring some smiles to faces. And the harder it is, the better I do in the comedy clubs with hecklers and in other scenarios. So it's really like a tough workout for me as a comedian. And here are some resources. I mentioned already the Association for Applied and Therapeutic Humor, AATH.org. They have so many resources. There's books, there's papers, research, all kinds of things there. So I really want to direct you to that website if you want to do further research. I was trained in comedy through the Armed Services Arts Partnership. It's a nonprofit that offers comedy, storytelling, a variety of creative arts classes for veterans. It's really not so much to train us to have a skill and to become working comics. It was their idea was to create a sense of community, but some of us do go on to pursue it in a more professional and serious nature. And then lastly, my website, that's medicinebrigade.com. That's how you can reach me if you have questions, or maybe if you want to facilitate or start something similar in your hospital or your clinic. I'd be happy to give a more in-depth share of some of our exercises, what we're doing, and just help you get that started. So I know this was a bit brief. I think I was supposed to present for 25 minutes, but hopefully this will give you time to connect with each other, those of you that are in person at the conference, and maybe it'll give you some time to just scroll through something funny, get on your phone for a minute, take a sip of coffee, and find something humorous. I tend to really like the Golden Girls clips. I tend to go back to those. Will and Grace is one of my favorite TV shows from back not that far ago, but a little while ago. And just take a moment this morning as you end your week to find something funny, and just watch it and allow yourself to laugh, allow yourself to decompress. But thank you again for the opportunity to present. I'm so sorry that I had to record this, but flight travels precluded me from being able to log on. I wish you all the best. Again, you can reach out to me at robin@bestmedicinebrigade.com.
So really, it was a great short presentation. I will open the stage if there is any comments or discussion about this great topic before we will continue with to our next speaker. If you have any comment or if you want to discuss anything, just raise your hand or type your comment in the chat box, please. Okay, I will start with my first question to you, to our lovely participants, regarding the title of her speech, Applying Humor to Your Whole Health Wellness Strategy. I would like from each of one of you to give me one or two examples about the whole health wellness strategy that you will deal with daily. And I will read your comments in the chat box. Or if you want, you can unmute your mic. Okay, Miss Claudia said the use of humor and laughter. Can you please discuss more about your idea, please? You can unmute your mic.
Hello, everybody.
Hi.
I just want to piggyback off what the presenter, she mentioned going through post-traumatic stress disorder and her whole experience in the military and how that has really shaped her. And also how her family plays a very, very important role in her life to kind of overcome that PTSD. And we all know when it comes to babies, they bring out the best in us. So that, which really tells me about humor and laughter as a coping mechanism.
So, okay, yes, my dear Anit, the stage of yours. You can unmute your mic.
Amal, I'm working in a pediatric ICU. So for me, it is because of my personality, I'm a extrovert and I'm dancing and everything. Now remember, I'm working in Saudi Arabia. And sometimes the families don't understand because they don't understand what you say, but I laugh, I play with the babies while you're doing very hurtful procedures. And I must say that it works. If you are with a family for a long time, for a whole day, what they do is they cling to you and they actually cope with your energy and your humor and everything. Even sometimes if they don't understand you, and sometimes you don't know what they say, because nobody knows how many dialects in Saudi is there.
Mhm.
So it's difficult, but for me, humor helps. And I talk the whole time to my patients. I talk to the family. And for me, that lessens my stress because I get the buy-in for the family. I get the buy-in and I dance. I sing for them. There's only one song that I know in Arabic and I
Yes.
sing it to them because they didn't teach me.
Yeah,
They
great.
didn't teach me. And you know what? They say it's not rochi. It's that other word, ro. I can't say that age. But it's amazing if you do humor, how lighter your day is. We are so serious. You know, life is tough.
Yes.
Especially if you are an expat, life is very tough. You don't see your family. You don't talk to your family every time. You can't visit because there's other people also need to go. You
Mhm.
need to make something. And to laugh and to joke and to play. It's very important to go through your day. And
Yes. Mhm.
humor helps.
So, are you believe that love is the best medicine and is the best treatment way for the
Yeah.
patients?
It works for
Mhm.
me, and I can see how the patients and the parents actually cling to me.
Mhm.
If I look at because I'm Piku, you know they've got lines and all those things, and you play and you do things. When they see you later in the ward, they actually hold their hands, and so you can pick them up. So for me is it let me feel better,
Mhm.
but it also helped me with my relationship with the patient and their families, because it's hard if you cannot speak a person language. And I get it right with my body language,
Mhm.
with how I portray myself and everything. And of course, I laugh. I make jokes and things like that. And I tell them I'm going to take them to Africa
Mhm.
so they can be with the lions.
They
You know,
feel
things.
they will live the wild life. Can you imagine that? Currently, during my working in Palestine, in our projects, they teach us that when we do a training for the nurses, how to teach them to do the CPR, we can educate them by using the music.
Yeah,
Yes. So music.
music. If you sing with them and you dance with them,
Yes.
imagine. Here, I get away with it. You know, people will say, "No, Annette, no, it's Saudi Arabia." So what? So what? It's people, it's human beings. They scared. When if you talk about aggressive parents, aggressive patients, sometimes you must think they are scared. Use humor, use laughter with them, and you can see how they change.
So you believe that love and the music is the best treatment for the medicine. So thank you, my
Yeah.
lovely Anit, for your great comments. And I will open the stage for Dr. Muhammad to say his comment in this topic. Dr. Muhammad?
Yes.
Yes, yes, please.
First, thank you for Lieutenant Colonel Robin. Really, it was a very, very nice presentation.
Mhm.
And if we think about, Amal, if we think about emotional intelligence,
Yes,
the laughter is the shortest way to communicate with people.
I agree with you.
Among teams, laughter is the shortest way. we have to know that the brain of the people, we have open loop system. And also this understanding the emotion of the others, it will help also nurses to cope up with their
Yes, it will motivate them, yes, to do their best.
That was only my comment.
Thank you, Dr. Muhammad. Is there any comments before we will go to the next speaker? Just raise your hand or type your comments in the chat box. Anit, do you want to add any comments?
Amal,
Yes.
I tried to get the hand off. I don't know how to.
Ah, okay.
I see it's still there, and I'm seeing if I can take it off.
No,
Because I'm
okay.
on my phone and I.
No problem. I will write to you how to remove it in the chat box. Okay, thank you for
Okay,
all of you
cool.
for your lovely comments. Let's move to our next speaker is Dr. Najla Muhammad Saeed from the UAE. I am passing her the stage to deliver the speech on prevalence of abdominal aortic enlargement among adults in Abu Dhabi, UAE. Dr. Najla, the stage is yours, please.
Hi, Miss Amal, how are you? Hi, every team, all
Hello,
of you.
Dr. Najla. صباح الخير يا هلا. Good morning. And good
For
afternoon.
us, it's good evening.
Yes.
And good morning to you also.
You are more than welcome, dear. Please, can you share your screen?
Okay, I will do now.
Okay. You just press the share screen, the green icon.
Then Amal, is it my turn, Amal?
No, now it's Dr. Najla, then you will be the next speaker after her.
Hi, Amal. You can see the screen?
Yes, I can see the screen.
Okay, thank you. So,
but can you display the first one because it's so small?
okay, this is the first slide. Actually, now? No. It's okay now?
Yes, we will.
Yes.
Yes, you can go ahead, please.
Okay, so brief introduction about myself. I'm Najla Mustafa Muhammad Saeed, nurse manager in education and research department. And I'm the supervisor for my research. It was Dr. Shukri Adam from the University of Ras Al Khaimah in UAE. So my research topic today is talking about the prevalence, aortic aneurysm, and prevalence of. You can hear my voice? It's clear?
Yes,
Hello?
it's already. Yeah, it's already clear. We can hear you.
Okay. So the background information about my research is the report from the developed country showed that the abdominal aortic aneurysm and is the 12th to 15th cause of death among the American and British and other European countries. And the total number of deaths with the aortic abdominal aneurysm is highly among treated and untreated patients compared to the general population. And there was a 1.71% treated patient with the leading contributing factors and atherosclerosis, common cardiovascular disease. So in UAE, the mortality rate from disease of cardiovascular was consist of 16.8 per 10,000 population in 2016 per WHO in 2009 to 2018. In UAE, 18 years old and above and 21.1% has high blood pressure by WHO. And in 2015, 22.9% of the total population was smoking. It started as early as 15 years old. And out of the 22.9%, and 29% were a male, and only 0.7 were the females by WHO in 2018. My research objectives is to assess the prevalence of abdominal aortic aneurysm among adults and is a selected center in Abu Dhabi in United Arab Emirates, and to find the association between selected demographic and clinical data for an aortic aneurysm among the adult in selected center in Abu Dhabi, United Arab Emirates. So my conceptual framework, we use the frame based on Dr. Merrill, and the framework is talking about antecedent of the uncertainty and appraisal of the uncertainty. So we focus on the acute disease and chronic disease, and we screen in the center in Abu Dhabi, and for two things, the demographic variable and clinical variable. So the demographic variable was the age, gender, nationality, and age of the diagnosis. And the clinical variable was smoking histories, family medical histories, and patient medical history, and previous abdominal trauma, and some of other symptoms. So we need to have in that, we have high and low prevalence of abdominal aortic aneurysm. And we have in the appraisal of uncertainty, the danger and the opportunities, and coping mechanism that you use the adaptation, the patient how to adapt to deal with the systems. So the previous of literature, they're saying dividing into two following section. We have the prevalence and the risk factor of the abdominal aortic aneurysm, and the clinical feature and association of the abdominal aortic aneurysm, and the benefit of early screening and treatment. Our methodology, we use the research design, a cross-section quantitative approach, retrospective chart review from 2016 to 2019. In the setting, it was in two centers. We have a Saha Ambulatory Center and Tawam Polyclinic. The population, it was the adult, male and female, from the age of 18 to 77 years old, who were diagnosed with aortic abdominal aneurysm. And the sample, it was the adult, both male and female patient, who were fulfilled the inclusion criteria that were selected for the study, and the purposeful non-probability sampling technique, and the sample size at the confidence level of 95%, a margin of error of 5%, and the calculated sample size was 130. Sample technique was a non-probability purpose sampling technique. Sample size calculation. This is the sample size calculation. We have the margin of the error. Can you accept is 5% is common choice. It's 5%. And what confidence level do you need? The typical choice are 90% to 95% or 99%. So what we get is 95%. And what is the population size? If you don't know, from the 2000s, it's 195. And what is the response and distribution? It was 50%. So the total recommendation sample is 130 patients. So our inclusion criteria, previously we diagnosed with abdominal aortic aneurysm and the surgical treated, male and female between 18 and 77 years old, and within Saha facility with electronic medical record numbers. The exclusion criteria was no confirmed diagnosed with aortic aneurysm within who are still under investigation, patients who were already expired. So the instrument that we use, the tool we use for the research study were the following: a database of a health information system from Saha ambulatory and the clinical area in Tawam Hospital, where detail of the sample can be electronically obtained and compliant with the use of the data collection tools and using the demographic data and the clinical data. We use the procedure of the data collection. The selected participants were selected via the database of Saha after approval from Iraq University and the approval of the research committee. The ethical approval obtained ethical approval from Iraq University and from Tawam Hospital and a Human Research Ethical Committee in Abu Dhabi. The data analysis is collected was analyzed using SSP version 25. The different statistic was used to describe the demographic and the clinical data. Chi-square test was used to assess the associated between the selected the demographic and the clinical variable with the prevalence of abdominal aortic aneurysm. Our analysis for the research, it was about 35.4% of the participants belong the age group 68 and 77 years old, and about 58.5% were a male. The prevalence of the abdominal aortic aneurysm is slightly increased among the 65 years old men at 2.6%, and among 71 years old women were at 0.9%. As you see in the graph distribution, we have most of the 30% of the participants were Emirati national, whereas the rest of the participants were from the Western and Arab and Asian countries. The distribution based on smoking, the number of the sample, it was 130. So the majority, the 68.46% of the participants was not smoking. And smoking is one of the common risk factors in developing aortic aneurysm. And the frequency of the abdominal aortic aneurysm was higher in the smokers compared to the non-smokers. The smoking destroyed the blood vessels wall that later develop aneurysm. So this is the distribution. So the distribution based on the family history among the 130 sample, the majority, 75% of the participants was not having medical family history. The first degree family member with abdominal aortic aneurysm have higher tendency to develop the aneurysm. An association and the higher incident or rupture with the positive family history, it's higher. The distribution on a family medical condition among the sample size, the hypertension, it's 84.8% was the most medical disease affected in the participant family. The identified risk factor include coronary artery disease, atherosclerosis, hypercholesteremia, and hypertension were found to be mild clinical implication. The distribution based on the existing and the previous health condition, as you see, the majority is 59.2 were hypertensive, and about 61% of the participants were having a cardiac history or problem. Finally, there is 37.7 having a previous trauma in the abdomen. So the distribution of the participant based on the manifested symptoms among the 130 sample. So the abdominal pain is 39.2%, weakness and 29.2%. They complain of the nausea and vomiting, and 22.3% difficulty of breathing, and 18.5% and a chest pain, 16.9% were the most symptoms reported by. The prevalence of abdominal aortic aneurysm among the adults, as you see, there is a significant in the sample is low prevalence of the abdominal aortic aneurysm and among young adults aged between 18 to 51. Hence, there the p-value is lesser than the level of the confidence. Okay. The H1 is accepted that the p-value is less than 0.05 level of the significant and satisfactory difference. The prevalence of the abdominal aortic aneurysm among young adults found that have low indication. The association between the prevalence and the pattern of the abdominal aortic aneurysm with the selected demographic and clinical data of the young adults as showing below in the graph. Sorry, I will make it just bigger. So if we are following the chi-square as the age specific year of 99.78 is showing we have only 7, and the significant result is showing 0.01, and the gender is by chi-square we have 3.723. We have only 1, it's showing the 0.54. And the nationality we have 124, it's 11% involved, it's 0.00. And the people who's having the history like hypertension, they have hypertension is 42.123. We have only 1, which is 0.00. And the cardiovascular history, they are 429, which is more higher. And we have a 48.3. And the previous trauma in abdomen, we have 7.877, which is 0.005, which is giving that the significant difference at B value is 0.05 levels. In the discussion, this study is showing that in UAE, about 35.4% of the participants belong to the age group of 68 to 77 years, and about 58.5 were a male. The prevalence of abdominal aortic aneurysm affected older, causing the male, and is 3.5 times more common in the causing men than in African and American men. So the abdominal aortic aneurysm is uncommonly individual of the African and the American and Asian and hypotonic hemorrhage, and the sudden and severe abdominal and lower back pain that usually suggested in rupture of the abdominal aortic aneurysm. The common manifested included abdominal pain is pain in the flank area, groin and buttocks and legs, according to the CDC 2017. The prevalence rate of the abdominal aortic aneurysm as negligible before the age of 50 to 60 years old, and after that the prevalence rates vary between 1.3% and over 5%. The nature of abdominal aortic aneurysm is symptomatic, which the remarkable and dangerous condition mostly affect a person above 50 years old, and the rupture of the abdominal aortic aneurysm is left untreated and has 100% mortality rate. This is the rate is the considerable even the treated patient with the rupture aneurysm regarding from the 20 to 60%. The probability of getting and the chi-square of the size of the null hypothesis is the regarding the association of age of the selected clinical profiles. The p-value is less than 0.05. The hypothesis 2 is accepted that there is a significant association between the demographic profile and selected clinical profile and prevalence of the abdominal aortic aneurysm among the young adult. The risk factor of the aneurysms is include male sex, smoking, older age, ethnicity, and atherosclerosis, hypertension, and family history. Aortic aneurysm as a formation were found more frequent in the white race than the black people. The smoking is relation in aortic aneurysm. There was evidence of the non-linearity of the cigarettes per day, and the back of years they are not found for those who's quite smoking. many population, the high risk developing abdominal aortic aneurysm, the higher prevalence, such as a smoking person with family history and a person with disease such as a coronary heart disease, hyperlipidemia, hypertension, and the chronic obstructive pulmonary disease. Also, an injury or the people who have an injury or trauma to the abdomen may suffer of a medical catastrophes in a situation such as a rupture, and after the aneurysm, they will have a traumatic injury. So in conclusion, there is a prevalence of the abdominal aortic aneurysm in Abu Dhabi, UAE. The finding of the study will highlight the needs of the decrease of the mortality rate among the patients with the abdominal aortic aneurysm. The early screening among the risk group of the population is highly essential to prevent the untimely rupture, complicated surgery intervention, and the untimely death. The assessment of the prevalence of the abdominal aortic aneurysm is an essential part of the nursing practice. The change of the physiological and the psychological function among the affected patient would guide a nurse to the historical approach. Emphasizing the holistic approach is the competent intervention among the nurses, participation in screening and managing the existing symptoms. Thank you, Amal. Thank you for all the audience. I came to the end. Open the floor for discussion or questions. Amal, you hear me?
Yes, yes. Thank you, Dr. Najla, for your
Most
great
welcome.
and lovely topic. If there is anyone have a question or comments, just raise your hand or write your comments in the chat box, because we will open the discussion. It seems look like there is no questions. Dr. Najla, I have a small question. The title of your speech is about prevalence of abdominal aortic and okay, am I
Aneurysm.
yes, in Abu Dhabi. I would like to
Yes.
ask if there is a national study about your topic, or is there any another topic related to your study done in Arabic countries or in Gulf region? Dr. Najla, can you hear me?
Okay, can you repeat your question, because I think you are
I will
muted.
repeat my question. Briefly, is there any national study regarding to your topic, or is there any study done in Gulf region related to your topic?
Okay, my topic is running to enhance the nursing, to do the screening before we have to reduce the mortality rate. But yes, there is a previous study, but new. This is, I think my study is the first study in UAE for the aortic abdominal aneurysm for screening and reducing the mortality rate.
Okay, we have a comment from Anit in the chat box. I will read it now. I see that you include young people. Normally people with AA is in their 30s. Anit, can you please explain more about your comments? Now in the Arab countries, we see very young people who are hypertensive and has thoughts comorbidities. Okay, the speech is yours.
Yes.
You know, in my country, the most of the people with AA is actually in their 30s.
Yes.
And a lot of time it's females, and then but most are males. But when I started working in Saudi Arabia, I see young people of 17, 18, 19 years old on 2 antihypertensives. And you can see the comorbidities are much more. If I look at young people these days, they're not eating well.
Yes.
And then also with the marriages and things like that, you can see their comorbidities are much more than I'm used to. And
yes, they are not using a healthy lifestyle, even they don't do physical activities. Yes.
The physical activities I can understand, because in summer nobody can walk, but there is gyms.
Yes.
There is that type of things. But if I look at the young people now, I'm even talking about young children.
Yes.
They're sitting, they're in front of the TV, and everybody from very small has or an iPad or a telephone, and this is what they do. And we can see these things where I'm used to in their 30 years. Now you want to say to me, you see patients who are 19 years old? That's very, very young.
Yeah, and
yes, I agree with you, my dear. Yes, because the lifestyle is.
Yes, Dr. Najla, go ahead.
The lifestyle is playing a big role in this disease, and they are coming with diabetes, most of them now, because the obesity is playing a big role. And also the family history, and don't forget also there are families here that are getting married from each other, so the family history still is traveling with all this generation. And now we are enforcing for all the newly married people to do the screening, family screening history before they will get married, to make sure that the DNA, they will not have problem with the babies they will have from if they are planning to have a kids, they will not have any problem laterly for these family history things. And we are supporting them supporting them with all the education before they will getting married. The second thing is the lifestyle, the eating habits, the malnutrition, and the smoking. The young generation, 15, 16 years old, they are highly smoking. And some of them, they are coming recently, not only in abdominal aneurysm, they are coming with stroke.
Yes, and heart attack.
Exactly.
Yes, the electronic cigarettes and shisha.
Exactly.
Also.
Exactly. So the education is most important. The community, we need to educate and enhance the community continuously repeating ourselves, and disseminate all the knowledge to all the level of population that we have. Yes, Amal.
Yes, is there any comments for Dr. Najla? Okay, Dr. Najla, I would like to ask if in your hospital, is there any kind of capacity building for the health care workers among your topic, and or if you have done previously any health awareness for the patients to educate them and aware them about this kind of topics?
Okay, recently after my topics, after I present my research, we start to implement this education in the clinic to all the level of age who come with the signs and symptoms, or who having all the family history. We do the screening for them to prevent to have this aneurysm, because they're coming in the young age, and even the people who's in the older age, they were coming with all the complication and the comorbidities. Yes, we are doing in our facilities. The screening.
Najla, tell me, what screening are you doing?
Okay, the screening we are doing in the older level, we have among the demographic data and the family history, and especially the people who have families who have the aneurysm from before. We following them, and we continue having like all the coagulations, and we try to give them education regarding the smoking and to change the lifestyle about the what that food that they have to avoid, what exercise they have to do in their lives, and to how to have the good lifestyle or like role model lifestyle for them. We are focusing on those people, but the number now is increasing, and the population from all the levels we have, the comorbidity is increasing. And we are receiving nowadays cases of the stroke, cardiovascular stroke, brain stroke, for the people who's having this family history, and among to that, the lifestyle.
Yeah.
I hope I answer your question.
Yes, thank you, Dr. Najla, for your great topics, and thank you, my dear Anit, for your comments. Let's now continue to our next speaker, Dr. Muhammad Al-Mubarak, again from KSA. I'm passing him the stage to deliver the speech on ethics and modern healthcare conflicts arise where often there. Dr. Muhammad, the stage is yours, please.
Thank you, Amal.
Thank you, you're more than welcome.
Good morning again.
Good morning.
From 8,000 miles far. And let us start with very interesting topic. I mean, there's something, an issue actually in the healthcare or in also other professions. And from the start, actually, I don't have all the answer for these issues, but it is a training for us. Let us think about it. We are facing that, and maybe we'll face more in the future. We'll talk about what is our goals, ethical operational framework, culture of safety, rationale, bad behavior, ethics versus morals, ethics in healthcare, and very short brainstorming for you and me. Let us start. Ethics is a very large and complex field of study with many branches. It is part of how many groups define themselves, and thus part of the identity of the individual members. Let us start with the Hippocratic Oath. This is in Latin. Primum non nocere. That means first do no harm. For a healthcare professional, when you are approaching patient, the first thing we have to do, you have to think, first do no harm. It is one of the earliest documents in medical ethics, 15th century BC. First, do no harm. Primum non nocere. Traditionally, all doctors recite this oath at swearing in. It is considered sacred for its religious foundation. Principle of healthcare ethics is do no harm, non-maleficence. Above all, do no harm. Make sure that the procedure does not harm the patient or others in society. Principle of medical ethics, the double effect. When an intervention undertaken by physician create a positive outcome while also potentially doing harm sometimes. Like the use of morphine in the dying patient eases pain and suffering while hastening the demise. Why? Through suppression of the respiratory drive. The goal of ethics is practicing responsibility to the profession, our profession, practicing responsibility to those we serve, avoiding conflict of interest, focusing on the reason why an action right or wrong. Ethical framework, this is it is very important for institutions going for accreditation, and there are many accreditation bodies. I quote here the Joint Commission. It's one of the famous accreditation bodies in the world. And also during my working in the hospital as CEO, my hospital could achieve the GCI accreditation
Great.
for years, several years ago.
Mhm.
The GCI GLD, that means governance and leadership, includes hospital leadership has a professional and legal responsibility to create and promote environmental and culture that operate within an ethical framework. The ethical framework must apply to both the hospitals, business, and clinical activities alike. Disclose ownership and any conflict of interest, protect confidentiality. This is very important. Confidentiality is really suffering sometimes in hospitals. Provide clear admission and transfer discharge policies. Be accurately for the services and ensure that for financial incentive arrangements do not compromise patient care. Establish mechanism by which healthcare practitioners and other staff may report clinical errors and raise ethical concern without impunity, without fear. As I told you before, fear is destruction for an institution. Ensure that non-discrimination in employment practices and provision of patient care in the context of the cultural and regulatory norms of the country. Ethical framework and culture of safety that examines behavior, non-intimidation, education, confidentiality, policy and procedure govern every aspect of our work, transparency, reporting of error without fear, no discrimination in employment, assessment of culture of safety, etc. We have here an excerpt from Universal Declaration of Human Rights, United Nations. Article 1, all human beings are born free and equal in dignity and right. Everyone has the right to work to free choice of employment. 626, everyone has the right to education. I quote only few examples. From the World Medical Association Declaration of Geneva, at the time of being admitted as a member of the healthcare or the medical profession, these points apply. I solemnly pledge to consecrate my life to the service of humanity. I will give to my teachers the respect and gratitude that they're due. I will practice my profession with consciousness and dignity. I will respect the secrets that are confined in me. I will maintain the utmost respect for human life, etc. And then from the Declaration of Helsinki, the well-being of human subjects should take precedence over the interest of science and society. Consent should be in writing. Use caution if participant is independent relationship with researcher. Rationale and ethical behavior, there are 4 reasons. We ask ourselves if we want to rationalize that for ourselves, always we will ask this question. What I am doing is not really illegal. My behavior is in everyone's best interest. Nobody will ever find out what I have done. The organization will protect me. These 4 reasons you are towards that. That means there's something here fishy. And the 4 views of the ethical behavior: individualism, utilitarian, justice, and moral rights. Spotlight question, ethic training, highlight the risk of public exposure of one's action. If you are taking a decision, you should ask yourself, how would I feel if my family found out about my decision? Ask yourself. How would I feel if the local newspaper printed my decision? If it is right, of course, I will not be concerned about that. But why? I have to ask myself these questions that I can. It is like a compass for me. We are coming now to some red flags. And I think these red flags we should keep really in mind and then consider them. It is the heart of this presentation. If you hear someone, those are the red flags. If you hear someone say any of these, you can expect something unethical is about to happen. Something fishy is there. First, well, maybe just this once. I do it only this time. No one will ever know. It sounds too good to be true. Everyone does it. Hey, come on. Shred that document. We hear that often. We can hide it. No one will get hurt. What is in it for me? I don't want to know about it. Let me do it. Let's have somebody else do it, but I don't want to know about it. Those are red flags. When you hear them, that you know something unethical is about to happen. And ethics versus moral. Ethics and moral relate to right and wrong conduct. They are sometimes used interchangeably, but they are different actually. Let us see some difference, which maybe highlight. It is, we should only, sometimes we cannot really separate 100%. Ethics and morals. Ethics, rules provided by external source, like religion, code of conduct in workplace. Doctors, they have code of conduct, lawyers. What is moral? In the other side, moral, individual's own principle regarding right and wrong, your personal compass. Sometimes it has nothing to do with ethics. Ethics, why we do ethics? Because religion, laws, or society say it is the right thing to do. And moral, why we do it? Because we believe in something being right or wrong. Of course, there is a gray area. A person strictly following ethical principle may not have any morals. Likewise, one could violate ethical principle in order to maintain moral integrity. Let us say, example, abortion, euthanasia, or mercy killing. We have some ethical dilemma. One of the most common ethical occurs when companies' culture conflict with an employee's personal ethics. One professional example is the work of defense attorney. I don't want to upset attorney, but it is as an example. Lawyers' morals may tell that the the murders should be punished. But ethics as professional lawyer require him to defend the client, even if she is, he knows that the client is wrong. But this is the code of conduct. And here it comes, and ask yourself, it is not easy. Another example can be found in medical field, euthanasia, as I told you, the mercy killing. Further example, should a parent have a right to refuse immunization for his or her child? Does public safety supersede an individual right? I don't have the answer for all these questions. It is only I'm asking you and myself. Genetic and prenatal defect, what to do? Should children with serious birth defects be kept alive? Should a woman be allowed an abortion for any reason? Should a criminal be tortured to gain information that could possibly save lives? Should healthcare workers be required to receive vaccination, say flu vaccination, influenza vaccination? You cannot force people to take vaccination sometimes. Either you have to have a law there, it should be clear for everybody before starting the job. Who should get the finite number of organs for transplantation? Example, old versus young. I have no answer. Now, the ethical principle, as everybody knows from you, in healthcare, is the autonomy, beneficence, non-maleficence, justice. We come to advanced directives. Some of the ethical issues in advanced directives. I think everyone should know about it, and it should be practiced in the hospital according to law and policy and procedures. It is a method to make decision known to healthcare provider, a living will or durable power of attorney, in which a person states his or her wishes regarding medical treatment in the event of mental incompetency or inability to communicate. There is an instruction. If I cannot communicate with you when I am so sick, please do this and don't do this. And it will make it easier for the medical staff. Encourage patients to consider the option of preparing an advanced directive. It is not a must. Policy and procedure should be developed to address patients' right to refuse treatment and to execute an advanced directive in accordance with the laws. Documentation of advanced directive in medical record. It should be specify what to do, what to include and exclude, such as intubation, mechanical ventilator, antibiotics, blood transfusion, dialysis, artificial nutrition, hydration. It should be specified what not to do. Patient can change mind at any time, of course. Risk management should be there. There is an implication to develop, implement, and monitor compliance with policy and procedure. We come to do not resuscitate. This is in every hospital. It requires a physician order. We should know that it requires a physician order. It requires clear policy and procedure. Education of patient, family, and staff. Withholding and withdrawing treatment. Life-sustaining treatment is an in treatment that serves to prolong life without reversing the medical condition. Clear policy and procedure that outlines what life-sustaining treatment entails and what criteria, parameters, withholding, withdrawing of care can occur. Example, intubation, as we said before, mechanical ventilation, renal dialysis, artificial nutrition, blood products, antibiotics. We come to the euthanasia, assisted suicide, allowed in some other countries, but not allowed in Islamic countries. It's rendering of assistance to person who wants to die, to end his life. But it is not able, that person is not able to do it himself. In some countries, when healthcare provider does it, it's considered murder. In other countries, legalized procedures, also known as euthanasia. What to consider here? Does the diagnosis make difference? Does the amount and suffering of pain make difference? Quality of life? Company research, I think, as everybody knows, includes the identification of risks and benefits of that research to the subject individual who is participating in the research. It is always for the sake and benefits of people, not financial profit. Informed consent, everybody, I think, here knows about informed consent. I don't need to talk about it. It serves as a legal document. Capacity, and mental ability to make a rational decision, which include the ability to perceive and appreciate all relevant facts. Who should determine that? Normally determined by a physician, preferably by psychiatrist, who can define the capacity of this patient, of this individual. Surrogate of patient, the individual who is legally authorized to make all these things, ethical issue you have to watch when you're working there and developing policy and procedures. The individual, the surrogated patient is the individual who is legally authorized to make healthcare decision on behalf of the patient who is unable to make or communicate. The next of kin, according to the law, establish and advance directives such as durable power of attorney. We come to futile care. It is again another big subject. The quality of care is defined by the patient's values, not by the surrogate or caregivers. Physicians do not have an obligation to deliver care that in their best judgment will not have a reasonable chance of benefiting the patient. Some people want to have antibiotics. If the physician sees that there is no need for that, he is not actually obliged to give the patient. Physicians are not required to violate their own ethical or religious beliefs, but do not abandon the patient. Have appropriate policy and procedures. Be sure decisions are based on medical issues, not age, social status, or be financially driven. Negotiate with patient surrogate. You should also have ethics committee in your facility. Now we come this brainstorming what I told you. Possible ethical issues that might become common in the future. Gene editing, genome editing, or genome engineering is a type of genetic engineering which DNA is inserted, deleted, modified, or replaced in the genome of a living organism. Any change in the germ cell can be potentially passed down to the next generation, essentially introducing those changes into human population. Human cloning. Did you ask yourself about human cloning? You know, human cloning, you have two different. We have the reproductive human cloning, and we have the other one, the therapeutic. Maybe the therapeutic we can explain. Yani, it is for the treatment of other patients and so. But cloning as a complete human being, what is this actually? It is because we are taking a somatic cell. What is this clone? Is he my twin brother, but came late? Or he is me, is my progeny? Is he my son? Ask yourself. It is not easy. That's why these things are really very, very, we've taken it cautiously, because it's a big issue in the society, and it's not such tampering there and there with research. Our conclusion: 5 ethical challenges in healthcare: avoiding conflict of interest. Doctors and nurses are often prime targets for pharmaceutical and medical device and equipment companies. That is why more hospitals are now banning free meal presentation, pens and other items, free sample, travel expenses. Balancing profit with serving patient. Example, I'm giving you an example to make it easier. Should the organization invest scarce resources in profit-making areas that are likely to serve a relatively small number of patients, or in areas that will provide basic care to a large number of patients? We have to ask ourselves. According to Berlinger, who teaches healthcare ethics at Yale University School of Nursing, wrestling with equal treatment versus VIP treatment. Example, we are facing that every day. Shorter waiting times for the VIP, longer physician consultation, administrative drops by to make sure that the VIP have no problems, etc., etc. Managing pediatric patients, this is the 4th point, managing pediatric and geriatric patients who may not have decision-making capacity. Does really the surrogate decide based on the patient's known preferences or best interests? Difficult situation. Addressing nurses' moral distress, providing care with minimal benefits. Nurses may feel they are hurting people rather than helping them. It bothers nurses that others go without care due to lack of funding. They are telling we are robbing Peter to pay Paul. Take-home message: Joint Commission requires each accredited hospital to have ethics committee that helps staff to deal with ethical dilemmas. Core principle of healthcare ethics: autonomy, to honor the patient's right to make own decision. Beneficence, to do good and protect from harm. Non-maleficence, to do no harm. Justice, to be fair and treat like cases alike. At the end, we have to tell you, first, do no harm. Thank you for listening to me.
Thank you, Dr. Muhammad, for this amazing and informative topic. If there is any question for Dr. Muhammad, just raise your hand, or if there is any comments, you can write it in the chat box. Yes, Anit.
Amal.
Yes.
You know what I found in Saudi, especially where I am. You've got a lot of, especially children with genetic diseases, and really, it's bad. But what I found in my circumstances is that there's always a multidisciplinary team meeting after the team meeting, it's also the multidisciplinary team who speaks to the parents. And that makes it much easier because whatever they decide, it's written. And every like 3 months, the discussions will happen again. Then the family must sign again, or the patient. For us, it works, but it's very hard if you work with children who is in a DNR.
Mhm.
If it's an older person, a geriatric person who had their lives and also had all the comorbidities, it's easier because you know that they are sicker and everything. But when it's children, it's hard. You can see how they suffer. You can see how the family suffer, but you give whatever you can.
Mhm.
But the ethical committee is very, very valuable because it takes the stress and the decision making of the nurses and the direct doctors, because there's other people who help with the decision making.
Mhm.
And then in our hospital, there's social workers, there is psychologists, there's everybody who can assist in this care for the patient, care
Mhm.
for the family, and help. But yeah, ethical things is not easy because it's your own values, your own morals, who is also there. That is this really correct to do, or are we prolonging a person's life and it's actually wrong? Nobody knows. Nobody knows the answer, but we try our best.
Thank you, Dr. Muhammad. Do you want to add any comments about her?
Yes,
comments?
to the ethics committee, it is really very important to know we have the selection of the ethics committee members. It's very, very, very important and very crucial. And they should not be all from the hospital. At least 2 from the community. Because our opinion as doctors and nurses will be different from the people outside.
Yes.
That's why it should be at least 2 from the community to at least have as possible a fair decision.
Yes.
And then I forgot actually to tell you another problem. It is the commercial surrogacy and fertility tourism. I don't want to name the country, but it exists. And there are really a lot of cases where we have 3 mothers for 1 baby. Who should take the baby? The surrogate mother, the mother who donated the eggs, the anonymous, or the gestational mother. Yani there are a lot of difficult issues actually.
Okay, Annie, do you want to add any more comments, or should I start my question? Okay, I will start my questions.
Yeah.
Thank you, my dear, and keep it on. Dr. Muhammad, I have 2 questions for you. The first one is about according to your point of view, is there a relationship between ethics in work and religion? And if it's there a relationship, if it's a correlation, a relationship, or what?
As I told you, it's interchangeable, but it is not. There is a difference actually, but that's why I said we cannot force the healthcare worker to go against his religious beliefs. If he doesn't want to do these things, somebody else maybe might do it. That's why there is not sometimes, there is a lot of differences between ethics and the moral issue, the religious issue also.
Yes. Okay. My second question, why are ethics in healthcare is important?
Because actually it's because of the patient. For the sake of the patient, for the sake of the staff itself, actually. And if we are going to work without ethics, where we end up, With what?
Yes, it's a great answer. Thank you, Dr. Muhammad, for your two informative and great presentations. I will ask you to staying with us because our other speakers will speak about great and informative topics. Thank you for your time, and let's move to our next speaker is Miss Claudia from the USA. So I say the name right? I
Yes.
said it, yes. I'm passing her the stage to deliver the speech on how to manage nurse shortages in healthcare facilities and hospitals by empowering certified nursing assistants. My dear, the stage is yours.
Okay. Thank you. Oops. Sorry about that. Thank you, Doctor. Thank you for this opportunity. And thanks to all the great speakers that have spoken before me. It's been very informative. I have learned so much that I cannot wait to share with my staff and colleagues. So as we all know, we've been dealing with we've had this nurse shortage in healthcare. It's been an ongoing issue, and I will be presenting on how to bridge the gap by leveraging and empowering our CNAs. So the key question is, how do we manage a nurse shortage in healthcare facilities and hospitals by empowering our CNAs? And our CNAs are certified nursing assistants. But first, what is the role of a nurse in healthcare? As we all know, nurses, they make up the largest population in the healthcare team. They ensure that quality care has been provided and spend that direct patient care and help to reduce hospitalization rates in both hospitals and other healthcare facilities for us, like nursing homes and skilled nursing facilities. And as we all know, the quality of care received by patients and residents is highly related to the level of efficiency of the nursing staff and also the interdisciplinary team members. And as we all know, before the pandemic, we were already aware of the nurse shortages that we've had, and which resulted to excessive burnout from being understaffed in facilities, working too many hours. We also have in our aging nurses that retire from the workforce, and we're faced with this constant recruitment and retention problem. And after coming out of the pandemic, it's been very, very prominent about how we're really short of staff, not only in the hospitals, in nursing facilities, in schools, in homes, and also in our community. Now more than ever, it's very crucial that we bridge this gap to meet up with the ongoing baby boomers generation to prevent poor patient outcome, and also to ensure quality care, and also cut back on any errors with patient care. The quick fix that we've had with our nurse shortage, the pros and cons is whenever we are short of staff, we always will hire our temporary nurses, which are our traveling nurses, to make up with the shortage of nurses that we have both in the hospitals and facilities. However, we run into a problem of lack of consistency, right? And most of the time, because I work as a traveling nurse, most of the time we run into a situation where a traveling nurse is working with a permanent nurse. A traveling nurse has more flexibility with her hours, making enough money, versus a permanent nurse who's being overworked. Now, when they start sharing their experience in the long run, that permanent nurse starts considering becoming a traveling nurse to explore that opportunity. And then the facility runs into a situation where they're short of staff, right? So you have this quick fix pro, and then you have this con where you get to, you have that lack of consistency, and also you get to lose a permanent staff. However, what's the long-term solution that we can have by leveraging our CNAs? So CNAs, for most of you who's not familiar with the CNAs, they assist our patients with both our patients in the hospitals and our residents in facilities with their ADLs, like their activities of daily living. They help bathe them, clothe them, make sure they're being fed. And most of our facilities, they have very reliable CNAs. They're very hardworking, very compassionate, very passionate about what they do. They serve our patients and residents, very well with their skills. And most of the time, the CNAs, they collaborate with the registered nurses. They spend more time in that direct contact with the patient. And they're very resourceful with reporting any abnormal changes to the nurse. And some of the CNAs, they start their careers to becoming a registered nurse as a CNA. So they're always constantly looking for a place for a career growth. It could be in a hospital or a facility. So how do we bridge this gap of nurse shortage in healthcare? So my first point will be for hospitals and facilities to take advantage of apprenticeship programs. Apprenticeship programs is more, the Department of Labor here in the United States, they offer apprenticeship programs where you get to train most of your employees on the job. So CNAs can be trained while they're on the job to becoming nurses. The next will be providing incentives for CNAs who pursue on-the-job training to becoming a nurse, right? And hospitals should also provide a roadmap with a career pathway opportunity for CNAs who want to become nurses. A good example would be if you're in a hospital or skilled nursing facility, once you have a CNA who comes on, you can provide this roadmap saying, if you stick with us for a year, we can sponsor you to becoming an LPN or RN in the next year or two. Guess what? That CNA she has it at the back of their mind that they have a place of growth, right? And you also want to navigate this process of this career pathway with them. Most of the CNAs that work in the same environment for years will require less resources during orientation and also to review all the facility protocols. So let's say you've had the CNA that has been with you for a year and you're about to sponsor them to becoming an LVN or RN. An LVN could take about 1.5 years. So you had someone who's worked with you for a year. They're still working with the company for a year while they're becoming LVN, which takes about 1.5 years. So if you want to do the math, they've been with you for about 2.5 years, right? And you let them know, hey, now you're LVN, you've been with us for 2.5 years, you've been very committed. We're going to sponsor you to a 3-year RN program. Guess what? You have a loyal staff that will be with you for a good 5 years. 1 year as a CNA, 2.5 LVN, and then 3 years of becoming a nurse. Once they graduate, they're already going to be working with a nurse because they know they're very loyal to you for investing in them and sponsoring them throughout the program. And in the long run, if you do the math, you've had one loyal employee that has been with your company for a good 8-year mark, right? And once they've gotten to that RN status, it's at that point, when you want to compare enrolling a new RN versus someone who's already been in the company, you're spending less time and less money going through a lengthy orientation process because they've already gone through the whole, they've been with you for years, so they know the whole policies and procedures, and you will run into less, they're more familiar with the protocols of the unit. And also with this addition in the staff, we're going to have more, you're going to have more help on the unit. And also hospitals and facilities should hire more CNAs and encourage flexible work schedules where they have time to maybe, pursue a career. And also this will enable them to have a place of work where they feel empowered and less likely to, be burned out. Okay. And pretty much that's my little brief presentation on nurse shortage in healthcare and how we can leverage CNAs. I am open to any questions or concerns.
Thank you, Miss Claudia, for this informative and amazing and excited topics. Okay, we have one comment from Miss Anit. She's raising her hand. Yes, Anit, unmute your mic, please.
In Saudi, where I come from, we used to the nursing assistants, and they are very valuable. The only thing that sometimes is not right is that they can get misused. Also, they tend to get so comfortable that they do things out of their scope of practice. But this is the people that you can teach and motivate to go further, especially if they're young. So now in Saudi, suddenly we've got also these students that are in our hospital for 3 months. We teach them everything. Now it puts more burden on us because we need to teach them from practical and we must evaluate them. And this is a little bit more of a burden on us. But if you instill them and motivate them, you've got good nursing assistants at your back. It helps a lot if they can just answer the call bell, if they can just give water, take the patient to the bathroom, or sometimes they just answer the call bell and then they come back to you and say what the patient wants. At least you are sometimes busy with another patient or busy with something urgent, and they are valuable. But at this moment, if I look in Saudi Arabia, it's new. It's a new concept and everything. And now they want us to teach them and also do everything. It is a lot of burden for us, but at the long run, it will be very valuable. And we need to embrace these people. A lot of them are very young. They are very young, but they are so willing and they want to learn. They're hungry for any education, for any knowledge, for any skills. And we need to embrace them.
Thank you, Doc.
Thank you, Miss Claudia, for this great topic. If there is any questions or comments, the lady is open to answer it. Okay, it seems there is no more questions. Thank you, my dear. I will ask you to keep staying with us to learn more from our great speakers.
All righty. Thank you, everybody.
Thank you and have a wonderful day.
You too.
So let's complete and move to our next speaker is Dr. Mary from the USA. We will present her recorded video about holistic mental health using well-reached supplements.
Friends, colleagues, it is an absolute privilege to be with you today. This is a critically important time. We're going to hit the world by storm with around the globe. 6.5 million people died. And the question is, what do we need to do as providers to pick up the pieces? I'm an introductionary setting. Psychiatrist, 35 years with training in integrative psychiatry and I have an executive MBA in healthcare with an emphasis on public health. I have asked myself this question many, many times. The truth is, at the peak of COVID, we did not hear a lot about lifestyle. We had a clue from the Lancet. The Lancet published an article that said, basically, COVID blindsided us because we live in a globe with 30 years of processed food and toxins in the air and the water. And now it is time for us to raise the awareness and pick up the pieces. We are not at all minimizing any efforts to improve antiviral therapy. That's not what this is about at all. Is any pandemic, whether it be bacterial, viral, fungal, whatever it is, our lifestyles can make a huge difference. And to educate and empower those that we are working with to fine-tune their lifestyles. Now you might ask, well, what's the problem? Look every morning at where people are getting a lot of their food. Look at the fast food restaurants, look at the drive-thrus, look at the gas stations and the convenient marts. Those convenient marts are exploding in popularity. But are we aware that there are many people that live in food deserts? These convenient marts are the only place people have access to fresh and quality food. And there is very little there in the convenient market. It's not a criticism, it just is what it is. And how about the issue of eating organic? You know as well as I, many organic farms are polluted by non-organic farms, and it is getting harder and harder, more expensive to eat pure organic food. Yet that is what we need to do. So what can we do? We can talk to the people that we're working with. There are local farms that really can't afford to grow organic. They grow organic, but they can't afford the certification, or they're in process. But when you get to know them, you see they are selling pure quality food. Let's support them. There is a whole movement on regenerative agriculture that focuses on pure quality soil. We look at the quality of the soil. And sadly, today, our soil in the US gets a failing grade. All these decades of industrialized agriculture, when we look at the quality of the soil, it's dust. It's dust. How are we getting nutrient-rich food for our people? These are issues that we in healthcare need to become very aware of and tackle, because these nutrient-depleted foods are affecting the health of our people, of our children, of our families, of our populations. Now, one thing we can do is we'll raise awareness, and again, all this is expensive. Guess what? There are inexpensive ways that people in apartments can grow their own food, and getting children involved. It doesn't have to be acres and acres of crops, but teaching children, getting them involved, of course, not using pesticides. Now let's talk about that for a second. What is the biggest risk of these pesticides? Well, if they're killing bugs, what are they doing for us? Now, glyphosate, which is the most common pesticide used here in the U.S., literally runs from anything it touches. It pulls the nutrients out, leaving them void of any quality nutrition. At the time, there were two lifestyle tips we could do to really help move COVID and really infuse our population with health, wellness, and healing. Number one, it would be improve the nutrient density of our food day in and day out. Nutrition should not be an afterthought. And we all know there are a lot of popular foods that literally have no nutrition. Think about all the food in the wrappers and very cleverly marketed, the beautiful colors and the ads on TV. They appeal to children. But how nutritious are they? Vegetables, pure vegetables without pesticides are probably where we are deficient the most. They say the average American is about 9% of people that really eat the recommended daily dose, the daily amount of vegetables. We can do so much better, so much better. So there's a reason I'm passionate about this. I've learned, like I said, I've been in psychiatry for a long time and thought a lot about how do we help educate people, improving their lifestyle. I would have kids come in 7 o'clock at night and they'd be munching very unhealthy snacks and drinking large bottles of Mountain Dew. And I'm thinking, why am I being asked to prescribe medication? Let's get the diets. Let's get the nutrients back in the children's diet. So I was privileged, maybe about 15 years ago, to participate in research with children with significant mental health conditions. And we were donated very high quality nutrients. It was a big commitment by the families because a lot of times the kids did not want to either take the pill, but we gave powders to sprinkle on their breakfast, on their, try to be creative to get the kids to really take the nutrient. Now, the result, I expected decent results. I did not expect the results that we got. The take-home message. Now, the children with significant mental health conditions were on psychotropic medication. And there's a lot of controversy about those medications. I'm the first one to tell you that. However, what we saw, it was a population, it started with 20 and ended up with 18 children who were diagnosed with significant bipolar disorder. These children had all been hospitalized, at least one. A lot of aggression, really significantly impairing their ability to function in day-to-day life. Well, lo and behold, after 6 months, and then it was continued, the progress was continued when we did the total in 9 months, they had virtually no side effects from their medication. These children came into the study. They looked groggy. They looked drugged. They were not, their discontrol was incredible. They had no ability to sit quietly, kicking, jumping on banisters, and just You had to keep objects away from them because the risk would be that they would throw it. Now, in 6 months, to see that level, it is improved. And the parents are very clear. Please don't touch the medicines. It's taken this year to get them stable on their medication. We don't want them to have to go back in the hospital. But with the nutrients, these children did amazing things. So what's needed, I'll be honest with you, 15 years ago, we approached universities to, can we raise money for larger studies? It seems to be very promising, that the children would do so much better with high quality nutrition. The interest simply was not there. The money was not there. I learned, it was a very sobering lesson for me, that if you want large studies, unfortunately, got to come with a large. I'm very sorry to tell you that, but I'm what I consider myself a little clinician. I'm out with the people. I've worked with people for 35 years, and but it takes millions of dollars for this type of research. But to be very honest with you, I feel the time is long overdue that we do, as a society, embark on this level of research. And it's not about any one supplement. You'd love to see it be double-blind, placebo control. And when we did our research, I will tell you, I was told, oh, you'll never see a double-blind study. It's just too expensive. Well, I have great news for you. There is a company in Canada, and they have published double-blind studies demonstrated that children with ADHD did phenomenally well with high quality nutrition, high quality nutrients that are able to get into the brain. There's a lot of science, a lot of detail of this involved, but it gives us clues. That's helping children with ADHD. What else is helping? I think we need to really refocus our lens and delve into more depth with this type of research. Now, to give you another example, there is a not-for-profit. This not-for-profit actually was instrumental in donating the supplements for us years ago. This not-for-profit donated quality nutrients to children around the world in orphanage. And this started years ago in the late 90s when a couple decided that they really wanted to support an orphanage in Romania. So they provide really high quality nutrients. And these high quality nutrients literally save children's lives. But please, can we brainstorm? Can we get more of these nutrients available to children? Because we're losing children every year. These winters are brutal. They get sick, they're cold, their immune systems cannot handle it. With the nutrients, they survive. I remember back then, I've seen pictures of children in Africa born 2 months with it. The mom had AIDS, and they were giving birth to premature babies. Now you would think, oh, well, what hope is there for that? Well, this was absolutely shocking. These children, it was received the nutrients right, tiny little babies, and they were given little. That was the other thing that really fascinated me. It's like, well, here in the U.S., these kids need a lot of nutrients. But these children were born fighting. They were born. Their immune systems were crying. And you gave them a little bit of these high quality nutrients and they would flourish. So when you see pictures of children graduating high school, wearing uniforms, with goals for their lives, and you say, wait a minute, these nutrients made the world different. I really believe it's time that we, as professionals, we first educate ourselves, empower ourselves, and help facilitate a widespread distribution of these high quality nutrients to vulnerable children around the world. I will give you a link below of the nonprofit. You'll see why we're so excited, because it's just, it's very moving to feel like there are literally strategies that we can employ. They cost, they don't cost, but in the scope of the big picture, when you think about the cost of technology and the cost of a learn, these are very reasonable. So, top quality nutrition. The other thing is free of pesticides. We need to be more aware. Think about this. When your patients are going to the local store, what are they buying? What is on their kitchen table every day? These are the things we need to be looking at and helping them literally one bite at a time. And we will do so much for our patients. And it does not minimize anything else that's been done. But when the Lancet wrote that article and said, basically, I'm paraphrasing, but it's COVID blindsided the globe. It's blindsided. Well, we were set up because our defenses were down. 30 years of processed food. Think about everything that's added to these processed foods. All the chemicals, the additives. It's not your nutrition. The other thing I just want to mention briefly is the use of toxic chemicals in our home. The truth is, these chemicals are everywhere. They're introducing 2,000 new chemicals every year. What is that doing? Again, we need to get more educated. We can help steer our clients, our patients, in the right direction. The great news is we live in a world with a lot more choices. And there are, they call it DIY, do it yourself. You can make inexpensive cleaning products for the home. You can use essential oil, use basic ingredients. And these are things that we can teach people we work with, and it will be extremely empowering for them. I'm going to be releasing a book very soon on healthy habits, and I get into this. It'll be a very inexpensive download and on Amazon. And I think for the special, it's going to be 99 cents, and then maybe several dollars. But I want people to have this information at their fingertips when they go to the store. I want them to see, wow, what is a processed food? What is high fructose corn syrup? Okay, this is an era where we can help shift. We have to raise the awareness. It's, you know, COVID decimated the world, and we still haven't fully picked up the pieces. We need to. I believe every one of us can do more to raise the awareness. The other thing is, all these chemicals operate at a very low frequency. The vibrational level is very low. And as we clean our diet, as we clean our environments, we operate at a higher frequency level. And what is the highest frequency organ in the body? It's the heart. So, as we make these changes, we are operating at a higher vibrational level. And we care more about ourselves. We care more about one another. And we care more about the globe. So to close, I want to thank each of you for your time and investment in empowering yourself to really improve the health status around the world and right at home. I thank you so much.
Really, it was an interesting topic and an interesting also a great speaker. Is there is any comments or questions? You are more than welcome to type it in the chat box. If not, let's move quickly to our next speaker is Dr. Lisa Nicholson from the USA. I'm passing her the stage to deliver the speech on practice facilitation and innovative approach to build organizational capacity and advance health equity to improve the quality of community-based primary care. Dr. Lisa, the stage is yours.
Thank you so much. I appreciate you, and I appreciate being a part of this conference or summit. Would you like me to share my screen, or am I okay with it?
Yes, please.
Okay.
Lovely.
Let's put it on a slideshow here.
You can press the slideshow icon. This one, yes, in near to the Zoom icon, in the right side at the bottom of the screen.
Are you able to see that full view?
Yes.
Great. Let me go back here. So again, good afternoon. My name is Dr. Liza Nicholson. I am the owner and CEO of Avail Management Services. I will be presenting today on an innovative approach of practice facilitation to building organizational capacity to advance health equity and improving quality and community-based care. The agenda for today, I'll speak a little bit about Avail Management Services and what we do. We'll go over the objectives, a common understanding of terminology, practice facilitation, primary care, organizational capacity, advancing health equity, and strategies and resources. A brief moment about Abell Management Services. We are an independent organization founded in 2019, based in Alabama, USA. Our mission is to improve the health of those we serve. We promote health and wellness by supporting healthcare organizations in providing accessible, equitable, and efficient quality care. Our core expertise spans around healthcare consulting and program implementation initiatives across the continuum of care. We are funded by local, state, and federal grants, government contracts, and also private funding. Health equity and efficiency are long-standing organizational priorities for us. We were also recognized by Wealth and Finance International recently for the best healthcare management consultancy in the USA for 2022. We are certainly proud of that honor. Some of the primary services that we do offer include administrative support, healthcare consulting, of course, facilitation, DEI services, diversity, equity, and inclusion training, project management, and also notary services. We service organizations such as hospitals, healthcare entities, community-based organizations, and also individuals and families. We provide services all across the US, the UK, and across the entire globe. Some services are in person, some services are offered virtually, but we do have a full continuum of care. The objectives for today, all participants at the end of this presentation should be able to define practice facilitation and its benefits, describe how primary care can advance health equity, identify strategies used by effective practice facilitators. A brief introduction tells us that evidence has shown that some primary care practices often lack the resources to implement system changes such as quality improvement projects that build organizational capacity and advance health equity. Community-based practices can easily overlook or dismiss small gains or changes they make in the midst of overwhelming patient needs and competing demands. Here on the screen, you will see a map of the state of Alabama where Abell Management Services is home-based. An assessment of the need shows that almost 1/3, which is 33.2%, of the state of Alabama identifies as a minority race. This is something that we looked at when determining should practice facilitation be a part of our service portfolio. The image here shows chronic diseases that are primarily linked in the state of Alabama. The orange color shows in 2014 what those numbers looked like, as well as in the purple, you'll see 2019. In almost every category, you're able to see there's an increase in every chronic disease area over the span of 5 years. So that helped us to determine the specific need that we wanted to go in the area we wanted to go in when we talk about advancing health equity, increasing and improving the quality of healthcare. We utilize this data along with the number of minorities that are listed in the state of Alabama. We've been able to effectively replicate our services across the US and across the globe. Here we'll talk about the 3 main topics: primary care, which is the provision of integrated, accessible healthcare services by physicians and their healthcare teams; health equity, which is achieved when every person has the opportunity to attain his or her full health potential; and then lastly here, healthcare quality, the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes. So we ask, what is practice facilitation? Practice facilitation is an approach to supporting improvement in primary care practices that focuses on building organizational capacity for continuous improvement. Practice facilitators, or sometimes they're called practice coaches, are specifically trained individuals who work with primary care practices to make meaningful changes designed specifically to improve patients' outcomes. How is practice facilitation implemented? Facilitators work with clinicians and clinic staff to redesign clinical practices, such as workflows and looking at top of licenses. They organize quality improvement efforts. They are able to help staff understand and use data to drive QI, which is quality improvement. They use team building exercises to improve communication, share best practices, and explain how other organizations have improved care, and also help motivate interest in change and help practices choose goals, adopt new work processes, interactively solve process problems, and incorporate health information technology. Some of the benefits of practice facilitation: it increases practice efficiency and patient-centeredness, improves continuity of care, improves preventive and chronic care, improves overall health outcomes, advances health equity, and enhances organizational capacity. Primary care is rooted in a commitment to social justice, equity, solidarity, and participation. It is based on the recognition that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction. According to the World Health Organization, primary care is the most inclusive, cost-efficient and efficient approach to enhance people's physical, mental, as well as social well-being. Evidence of wide-ranging impact of investment in primary care continues to grow around the world, particularly in times of crisis, such as the COVID-19 pandemic. Scaling up primary care interventions across low and middle income countries could save 60 million lives and increase average life expectancy by 3.7 years by 2030. Primary healthcare is a whole of society approach to effectively organize and strengthen national health systems to bring services for health and well-being close to communities, encompassing 3 primary components: integrated health services to meet people's health needs throughout their lives, addressing the broader determinants of health through multi-sectoral policy and action, and empowering individuals and families, as well as communities, to take charge of their own health. Advancing health equity. We certainly have the capability to do more to leverage primary care to advance health equity. We can do this by connecting patients to available sources of health insurance, using telehealth and other digital interventions to enhance access to care, provide culturally and linguistically appropriate care and education, utilize an expanded and diverse care team, address health literacy and social determinants of health to engage the community in practice and system-level decision-making. Visualizing health equity. Here is an image that shows a good difference in equality and equity. So across the nation, gaps in health are large, persistent, and increasing. Many of them caused by barriers set up at all levels of society. After all, it's hard to be healthy without access to good jobs and schools, safe and affordable homes. Health equity means increasing opportunities for everyone to live the healthiest life possible, no matter who we are, where we live, or how much money we make. Here in this image, you will see 3 people of varying heights that have equal access to seeing over the fence, but only the tallest person can actually see what is on the other side. In the effort to make it equitable, although ideally we would remove the fence, we can give the shortest person a step stool in order for them to have the same view as the tallest person here. So when we look at the difference between equality, which actually means sameness, we are leaning more towards equity in the current trends of healthcare, which means fairness. Health trends may need to be customized for each individual person and not a standard for everyone across the board. Some of the noted findings is that practice facilitation is an important resource for connecting primary care practices to external healthcare environments and resources. An excellent resource for assisting practices to build quality improvement capacity through teaching, hands-on support, and EHR-driven solutions. We found that independently owned practices were more likely to accept our offer of support from a practice facilitator. And these practices were not only more willing to sign up, but their level of engagement was also increasingly higher than other primary care clinics when working with practice facilitators. Some strategies used by effective practice facilitators and what we have certainly noted as best practices is that they cultivate motivation by asking open-ended questions to clarify practice goals and challenges, remaining flexible about what practices choose to focus on. We always allow them to lead that discussion. And then also being able to tailor quality improvement activities to primary care practices' needs, goals, and current preferences. Number 2, we guide primary care practices through the change process by assessing their readiness. That is an initial step that we take as an organization. We also help the practices and their teams think critically to identify pain points and brainstorm solutions. We do this as a group. We don't ever guide them as far as we're taking over or telling them what they're going to focus on. We always meet with the entire team and we allow them to identify their pain points in their practice. And then share experiences from other practices to cross-pollinate ideas and stimulate thinking. We utilize this as a customizable tool where we're able to empower them by bringing in certain projects that may have worked for other practices of similar size in similar areas or states, and give them the ability to choose if they want to do some similar work. Also, we address resistance to change by addressing the concerns directly and encouraging practices to pinpoint things to minimize barriers. And lastly, providing accountability and project management support. We do this by holding regular meetings with clear agendas, summarizing action items, assigning tasks to specific practice staff, and establishing target deadlines. We track the progress and we provide reminders. In conclusion, primary care does play a critical position in ensuring population health and equity by providing person-centered care to address social determinants of health. Primary care can ensure that capacity building and practice facilitation are using an equity lens, which can enhance the quality of care and provide equitable access to needed services like chronic disease management, preventive services, and screenings to improve health outcomes. So again, practice facilitation alone cannot provide the end-all solution to conquering barriers that prevent healthy outcomes. However, we have provided some really great resources that we have utilized in working with primary care practices across the US and across the globe. A really great one here that we would like to note from the California Improvement Network. This acts as a roadmap in describing 7 opportunities supported by tactics and practical resources. It also has case studies that provide insight into how organizations have been able to implement improvement. There are also a few links here. These are great resource sites from the Agency for Healthcare Research and Quality and also the Institute for Healthcare Improvement. I will certainly share these with the conference leaders so they're able to share these with the group. Again, my name is Dr. Liza Nicholson. I'm the owner and CEO of Avail Management Services. We have our website listed here as well as our contact information. If you would like more information about anything that I've been able to speak about today, please feel free to reach out to me. I am happy to share this information. I am happy to work with other healthcare organizations in advancing health equity and also improving the quality of healthcare in community-based practices. Thank you so much for having me a part of this. Thank you.
So thank you, Dr. Lisa, for your great speech. If there is any questions or comments for Dr. Lisa, please type it in the chat box or raise your hand. Okay, Dr. Lisa, I have a quick 2 small questions. The first one is, how do you ensure equity in healthcare?
Thank you for that question.
You're welcome.
So a big part of what we do, and when you say ensure, is you have to look at equity as a journey and not necessarily a destination. It is always ever changing, and depending on the practice that you're in, equity can look different. But what we also want to always ensure is that every patient that comes in there receives individualized whole person care. So our goal is to always make sure that every practice is continuing that journey of health equity.
Great. And the second question is, how healthcare organization can create equity in community? And is there a difference while the organization is a primary healthcare or it's a hospital?
Yes, I do think the tactics can vary depending on if it's going to be community equity or primary care or hospital. I think we look at things such as readiness. So we always assess the organization specifically, whether they're a hospital-based organization or whether they're a community-based practice, to see what their current level as far as advancing health equity is, and then see how we can help them approach that and move forward. But it does look different based on the organization. The approach has to be different.
Okay, thank you, Dr. Lisa, for your time, and I would like to ask you to stay with us. There is a great another lady will speak with a few minutes. Let's continue with our next speaker, Miss Carol Newsom from the USA. I'm passing her the stage to deliver the speech on postpartum hemorrhage. Miss Carol, the stage is yours.
Hi, and good afternoon. Thank
you
so much for having me. Can you hear me?
Yes, of course.
Okay, just checking.
Okay.
So I'm going to throw a loop in there. I have changed my topic because as I was preparing this week and I just launched the opening of our new family birth suite at the Lancaster Medical Center with Penn State Health, I came across a subject very near and dear to my heart, and it's also a program I'm trying to implement here. So I just wanted to put the challenge out to everyone regarding the digital solutions to improve our maternal outcome. So that being said, I'm going to share with you my screen and also my presentation for today. So I wanted to speak with you today about the digital solutions to improve maternal care. And I am quite often or always speaking about how can we save lives and why do we have such a high maternal mortality rate, especially in the US, who's one of the biggest first world countries, and yet we have the highest and the worst outcomes. So what I wanted to do today is just bring it back to your attention that we have in the US approximately 4 million births a year, and 60% of those are delivered in hospitals with lower than 1,000 births a year. So then we want to look at resources and training. The most recent notable articles about increases in maternal morbidity called Deadly Deliveries in USA Today and Lost Mothers by ProPublica and NPR. Now, I know these are not clinical publications, but I want you to be aware this is what the patients that we have are viewing and seeing. So more than 80%, and this is just such a near and dear subject to my heart, is there are 80% of pregnancy-related deaths are preventable. That's global, whether it's here in the US or whether we're anywhere else in the world. So I just wanted to, and that's the information from data, who also labeled the 3 most common reasons for a postpartum death would be due to a PPH, pregnancy, postpartum hemorrhage, severe hypertensive crisis, or a venous thromboembolism. And all of those we have screening tools for that are available. I always talk about obstetric bundles because especially when I was living overseas, it's important that we learn to have safety measures in place for our facilities there. Here I'm back in the US and there's many ways we've identified what our gaps are in our healthcare and how can we move forward to close those gaps. So you can see that 22% of the deaths occur during pregnancy, 25% on day 7 of after delivery, and can be anywhere from 7 days to 1 year after pregnancy is 53%. So in the US, it's typical. We labor, we deliver them. They go home anywhere from 12 to 24, 48 hours after delivery, and then we don't see you. We don't speak to you again until 6 weeks checkup. I don't think that's fair. And we're going to talk about how the rest of the world manages their postpartum care. And then my whole speech today or talk with you today is about what we can do in the US to maybe match what's going on globally. So the CDC has identified the need for quality improvement initiatives. We are all fully aware that our numbers are high and they should not be that high. And the American Hospital Association, which I clicked on this link and it just thrilled my soul, released infographics on considerations of hospitals developing digital solutions to improve maternal care. I have been pushing so hard. We just opened a new hospital for Penn State Health and Lancaster Medical Center here in Lancaster, Pennsylvania. One of my big push and shoves is how can we get telehealth into our antenatal care, use telehealth for for consultations with our maternal fetal medicine if we need it, or with neonatologists, and also implementing telehealth in our postpartum care. We know that insurance payers are now implementing new programs to capitalize on telehealth. So this is a viewpoint that if insurance companies are starting to understand the importance of this and that it's very cost effective, that they're looking at maybe making this having better reimbursements. That way we can have a better engagement for our pregnant patients and improve our maternal health outcomes, which is the point of all of this. Digital health refers the use, as we already know, of information and communication technologies in medicine to manage illnesses and health risk and to promote wellness, which is exactly what we need to do to be able to provide better maternity care for our patients. In the digital health, it's a broad scope. It includes lots of wearable devices, telehealth. We have health information technology. There's lots, and so that the point is, when you come up to these devices, we're using them in our everyday lives. Why aren't we utilizing these to patch the gap on the healthcare that we're providing to our patients? So when it comes to the healthcare, then one of the questions we need to ask is, there are devices. You can go on Amazon and buy these in-home devices for blood pressure monitoring or even blood sugar monitoring. And then you can, send that data back to your provider. So one question is the patient going to buy these devices to be able to provide this in-home monitoring, or are the facilities going to do it? So I just challenged to the facilities that it's cheaper than a admission to the hospital, that I think it should be the facilities that provide this service to our patients. Even ACOG has understood and supports the use of telemedicine to assist communities and providers to make sure we're meeting our AIM goals and based for care in clinics within the community. So first, at the top of the benefits, improve access to healthcare. That's for our rural patients, community-based patients. Reduce inefficiency in healthcare. Well, I think we definitely need to utilize this to improve our postpartum care after delivery and to fill that gap between the discharge and then the follow-up 6 weeks later. Improve the quality of care. Well, the one thing that just stands out the most in my mind is the patient that comes to the ER after delivery with a headache. They check her blood pressures. Blood pressures are really high. They give her some medicine and send her back home on her way. No OB consult, just sent her home. Then she comes back in a few days later, severe headache, severe blood pressures, and then it turns out she ends up seizing. Then she's had a stroke and she's in ICU with the newborn that we're trying to bring in. Talk about how we're going to manage the newborn and also, her breastfeeding and needs to maintain for this baby. She did not walk out of that ICU. There's absolutely no reason for that death to occur. We now have a newborn baby with a family who's trying to manage with no mother. And this is the thing that drives me the most, is that we could do better management. If we knew she was PIH in the hospital, we could monitor her continuously. We know they still have a risk for stroke or even seizures, for 2 weeks minimum after delivery. So why aren't we watching these patients closely? And we could do that with telehealth, with the in-home devices, with them being able to transmit their blood pressures back to the office, to the physician to monitor. So we can prevent these kind of outcomes. Lower the cost of healthcare. And that will also decrease if we can manage them remotely and manage them. They won't end up coming into the hospital and having, more expenses from that. I also want to throw in just a tip. Remember, we can also, in these follow-ups, monitor the newborns, make sure they're making that newborn transition okay as well. Make sure that they're feeding well. Make sure they're peeing and pooping and gaining weight if we have people go in and do follow-up afterwards. So the challenges that I'm kind of facing, I think everyone faces with the telehealth, is most digital technologies have not been validated clinically. A lot of people want to see the research. Why is it? Prove to me it works. Well, it's still kind of new in the forefront and we haven't had any clinical trials. I think this is a great opportunity for us to be able to implement these programs and collect this data. Clinical trials may be necessary. Doctors don't have the information they need to prescribe or use digital technology. That's something we need to work on communication and education. And I've seen this one for myself. Most doctors don't get paid to use digital health technologies, so they feel the technologies disrupt their workflow. So when they're trying to see patients in the office, if you have booked in their schedule, a block for them to do a telehealth, I have worked with physicians and I do feel like it's an interruption. They're not getting anything extra, and yet they're taking up a time slot for a patient that could come in, and that would be revenue. There's barriers to adjusting to the new technologies in healthcare by both patients and their families and their doctors, because we're so used to having the face-to-face, the hands-on, that it is a little bit different having the more remote. As we're having this meeting today, this is a different format of communication. As we know, another way we can reach out and help is the people that are the ones that are in most need. So our overall maternal outcomes have worsened, and we've identified that it's the racial health disparities that continue to be the ones that have the issues. The American Health Insurance Plan encouraged payers to integrate the technologies and into our perinatal and maternal health to close the gaps in obstetrical care. So if the insurance companies are realizing it, why aren't we moving forward? If we're still going to get reimbursed, why don't we take the implementation, the time to learn the new technology and how we can make it work for our patients for better outcomes? So here we just have a short list of perinatal technology, interventions to improve outcomes for the conferences, the consultations. As we said, if we've got a patient in the hospital, if you're in a community-based hospital, then you can have a telehealth with one of the neonatologists at a regional medical center. Then you can get an up-to-date, you don't have to wait for delays, make referrals, make the phone calls. You can do the quick referral there. You can share the patient's information with the computer screen, share their file, and have a more collaborative and a more successful consult. In-home fetal monitoring, antenatally, we used to do that more than what I'm seeing these days. So for your preterm labor, any other concerns if you have on a patient, we can do in-home fetal monitoring and transmit those strips to the physician for review. In-home blood pressure monitoring, this simple step could help prevent those patients coming back in who've seized and stroke to the ED, who are postpartum and had a previous PIH or eclamptic episode in the hospital. In-home glucose monitoring, once again, that can be antenatal and even postnatal if required, as we want to monitor those sugars returning back to normal, or at least back to a new baseline. Postpartum telehealth and other tools can be implemented to drive earlier postpartum follow-up visits. That way, if we identify through these, the submission of the data, if you see that there's a problem, the pressures are creeping up, you can bring the patient into the office, you can address it, you can check it, you can do your assessments physically there, and hopefully prevent the ER problem that we discussed earlier. Provide access to lactation consultants. They can do that through telehealth. I believe in person's probably the best, but if not, you can at least have some discussions. They can do a feed. And then if they need to bring the baby in, then we can make the referrals from there. I just wanted to review this once again and just show that the maternal mortality ratio, and this is by WHO, and it just shows that the US, once again, is far more mortality rates than the rest of the world. So I think there's a lot of things we can learn from the other countries, for sure. My apologies, I went the wrong way. Timing of the US maternal and pregnancy-related deaths. So when are these deaths occurring? Well, we can see here that there's a big percentage that occurs during the pregnancy. 17% on the day of delivery. 19% occur in days 1 through 6 postpartum. 21% occur in days 7 through 42. And then there's a small percentage that occurs between day 43 and day 365. 52% of postpartum deaths occur after, in that postpartum period. Why are we losing these people if we know they're still at high risk after they've delivered? We sent them home. There's no follow-up with any care at all, unless they call for something, and then we'll book them. But we should be proactive in actually reaching out to our moms and our babies to see how they're doing and how they're making their adjustments. So how can we improve our prenatal and postnatal care? Well, one, it's best to keep the patients at home with the antenatal complications and out of the hospital. We know for a fact if you bring them into the hospital, they're at risk for nosocomial infections, and they will do better stress-wise, comfort-wise if they're at home. Monitoring contractions, monitor blood sugars that we've mentioned, and the blood sugars. Home visits, generally, if we look at how the UK postnatal care model looks, they have home visits that occur within 36 hours after discharge. Most patients have 3 appointments with the midwife or a maternity support person after birth, and the visits usually occur at the 36 hours, 3-day, and day 5. On these visits, what are they doing? They're providing newborn assessments, breastfeeding assessments. They're checking on the mom and checking her physical health. Make sure those stitches are healing. How's the postnatal bleeding? And just follow up once again with the blood pressures, diabetes, and overall adjustment and mental health. Are they eating? Are they sleeping? We know none of those things happen after you have a baby, but we still need to make sure she has the support she needs. How can we encourage her to be able to rest when the baby rests so she can recover as well? So here's a global outlook as by what is being done and covered. Well, insurance coverage is fine. Everybody covers it but the US, and we have the highest mortality rate. So maybe that's a wake-up call. We've just reviewed over how payers are looking more into this option. It's a cheaper option, but it's going to be a safer option for our patients in the long run. I'm trying to implement some programs here at Penn State. And I ran across this little dip, and this is what just sent me driving for the week. Digital solutions to improve maternal care, considerations for hospitals. Actually, this just validated what I've been trying to implement here at Lancaster. Emerging trends. Yes, we need to chat and have text-based integrations with our patients, so they can have open communication basically with us. Remote patient monitoring, as we've already reviewed, maternal risk management and education, and virtual and in-home for mental health and social support. It's nice that AHA is exploring emerging digital trends and maybe develop an effective partnership with the digital solution providers to make this and implement this as a norm of care. Just like we've gone from paper to the electronic medical records, I think we need to move forward the next step and implement our telehealth and other digital solutions that are available to improve our maternal outcomes that we have. The US can improve all their maternal outcomes by implementing the strategies, provide more enhanced surveillance of patients at higher risk during the ante and postpartum periods, provide better follow-up after delivery, as we've seen in most European countries. Insurance payers are starting to recognize these benefits to the digital healthcare, and AHA is exploring to making this into best practice for their healthcare. So we can improve the maternal outcomes by just implementing these normal modalities that we're using every day. And I just challenge you as well to look into this and just consider how can we, as healthcare providers, look at what options are available and how can we use this to improve our patient outcomes. Thank you very much. This is the references for the talk, and I'm open to any questions if anybody has anything.
Thank you, Ms. Carol, for your great topic. I will open the discussion and comments stage now. We will have first comments or question from Dr. Al-Mubarak. Dr. Al-Mubarak, you can speak.
Yes, hi, thank you for this very important and nice presentation, actually. It is very informative. I have a lot of questions, but let me start with the first question. Is this statistic, it is more among booked patient or the unbooked patient?
The statistics that I was referring to are patients that are inpatient. We do know it does improve. We can also utilize this for antenatal care with preterm labor, the monitoring, sending the strips in for evaluation, identifying, if there's a problem, if the patient has decreased fetal movement, they have the monitor at home, they can monitor, we can identify things and then send them into the hospital, or they can be coming to the office for evaluation. Same thing with the blood sugar monitoring. Sometimes instead of having coming you into the office frequently, they can do this and send in their data, and you can manage the sugars until they come back for their next visit. One, that increases your office flow so you can continue to see patients, but it also helps you to manage those at home that are at higher risk. But most of the numbers were for inpatients in the US.
Yes, I know in the inpatient, but these patients are booked patients or they're coming walk through?
They can be either. It's all patients grouped together. They weren't separated.
Okay, and this statistic about the United States, it is very high, but if we segregate that, is it it is postpartum or during delivery, or what is the most leading in the USA to compare it with other countries? Maybe there are other reasons in the USA.
The biggest gap that we have in the US is we don't have the same postpartum follow-up care after delivery. So most European countries will have some in-home visits by a midwife or some type of medical staff. They also, and they're followed up more closely. As I stated, we will have a delivery, send them home, and then there's no more communication unless she calls us. So the information that was provided, the highest risk or complications was for days 7 through 42. So they're a week home, working with their newborn, and the symptoms after delivery, there's no more monitoring of the blood pressures, then they're presenting that week after, before even the 6 weeks checkup, back in the ED with complications.
Can I ask more, Ms. Ahmed? Okay, and the category, the leading causes, cardiac and mental health, and I want to see among mental health, is the postpartum depression is included?
Yes.
Because
we are doing some screenings. We do generally the Edinburgh depression screening here in the US, upon discharge or during their stay even, but there's really no more follow-up. So if you look at the postpartum depression, a true, not just the baby blues, but the true depression, you're going to run into that week or two. They haven't had any sleep. The hormones are going absolutely crazy. And then they fall into that depressive mode. And there's no follow-up on this. Unless she calls to the doctor's office and has a complaint, no one's following her or monitoring her at all. And that's where I think we can use the digital solutions to be able to maintain some type of, if we know this is the highest risk, we know the patient was a high risk patient, we should be monitoring her for at least the first 2 weeks after delivery.
Okay. And the last one, do you have idea about the the postpartum hemorrhage, is it due to uterus atony or due to
Well, you know, postpartum
something?
you should be doing the screenings when they are admitted and throughout their labor during the interpartum period and even afterwards. So we should be proactive in monitoring and alerting that when they get so many risk factors, they then go to a high risk category or a moderate risk category. Are we following our obstetric bundle for safety for PPH? Do we have our postpartum hemorrhage card? Are we identifying she's at risk and are we ready with our medications? That's going to be our front line. You know, making sure if she starts to bleed a little bit, go ahead and get that Foley in. And remember the 4 T's when it comes to hemorrhage. So it is just tone. Is there a tear? We have to identify what the problem is. So it's just knowing what the risk factors are. We have screening tools, and a lot of those are built into the EMR. And then as she moves into a higher category, go ahead and draw that type and change that type and screen then to a type and cross. Just being prepared so you can address it quickly, and having these drills and protocols in place so that if as we go to monitor and we see the cascade of events happening, then we can address them more quickly and save lives and save uteruses as well.
Thank you very much. Thank you, Ms. Amal, that being with me this long time.
You are more than welcome, Dr. Al-Mubarak. Ms. Carol, I have a small question for you. Can you briefly, within 2 seconds, inform me about the telehealth role during the pandemic?
During the pandemic, there wasn't, we were inundated at the hospital I was working at, and I was in the United Arab Emirates during that time. And during the pandemic, you know, we were just trying to keep the staff afloat, trying to keep the beds and keep things going. I think the identification of the concerns that happened with the pandemic forced us into looking at other options instead of face-to-face care. And now we can take those technologies and things we've developed from that event into improving our healthcare moving forward.
So thank you, my dear, for answering all of our questions and for your great topics. I will announce now for 20 minutes for a coffee break, and we will continue our speaking time after 20 minutes. So welcome everyone from after the coffee break, and let's start with our next speaker is Dr. Kent Hythron from the USA. I'm passing him the stage to deliver the speech on using relational coordination and network analysis. Dr. Kent, the speech is yours.
Hi, good morning, everyone. Welcome from beautiful and sunny San Diego. My name is Kent Haythorne. I'm the Senior Director for Clinical Services. I oversee all of our cardiology and surgery care lines here. I'm also a student who graduated from the Emory School of Nursing in Atlanta with my PhD in nursing. And I wanted to tell you a little bit about some of what I studied and how this is in direct relation to the importance of this conference, which is patient safety. Mm-hmm. So I have a few slides here. I'm going to move through quickly in the early part because I want to get to the meat of the subject, which is really the two different and unique ways that we looked at this over the time period. I'm going to share my screen.
Yes, please.
All right, can we see me?
Yes.
All right, I'm going to go to slideshow format. Mm-hmm. A second. There we go. Okay. So this is what we're going to talk about. You know, I wanted to understand, we've been years in the procedural areas in the operating rooms, as well as other places in the surgical arena and procedural arena have often used the universal protocol, yet we continue to have all of these errors that are occurring. We haven't solved the problem yet. And I was very interested in as to why, because I've worked in this area for over 25 years. So I think it centers around the role of the circulating registered nurse in the operating room. They are the hub of communication, and they are the ones that establish these relationships that exist within the surgical theater. So the role of that nurse is really to try to eliminate these surgical errors and oversee what goes on, everything that throughout the entire operating room. Unfortunately, like I said, we continue to have surgical errors. They happen every day in the United States, and we want to examine deeply the role of the surgical registered nurse to see how they could better and improve some of this. The surgical nurse and the circulating registered nurses has a long history. They have emerged through the periods as nursing has over the years. And they manage most of the communication that goes on in the operating room. Early on, nurses were not regarded in such high regard. They were focused on domestic duties in the OR, washing and preparing sponges, and most importantly, staying quiet. As time has progressed, it's really surgical nursing is has developed in historical and both social context. The idea of antisepsis, as well as the advances that have taken place in surgical nursing have led us to where we are today. And many of you are aware of AORN, which is now an international organization that represents operating room nurses. In 1949, that was established to sort of begin the idea of creating the role of the circulating registered nurse. So over the last several years, I've been involved in the patient safety movement. That's really started with the landmark book, The Error, or landmark document, The Error is Human, that came out of AHRQ, which was now known as AHRQ. Communication is the key to all of this. But even though we had a universal protocol, we had a lot of old habits that continue to persist in the operating room that led to errors and inefficiencies. From that, we developed safe surgery checklists and a lot of focus on the team. So I use a conceptual framework. You probably most are familiar with this Donabedian structure of structure, process, and outcome. And I adopted it to my thinking of how we might look at this a little bit differently, with communication, relationships, and staffing all impacting the time that we spend in the operating room. So the aims of the study were really, what are the relationships in the operating room? Who is part of the operating room team? What are the types and amounts of communication that occur in the operating room? And how that circulating nurse would fit into the social network of the operating room and the relationship to overall case length duration. It was a two-part study that I did. It was an exploratory study. From this, we're actually are beginning some other research that I'll talk about at the end. But we looked at how staff, using a staff survey to look at communication patterns and how they related to surgical case length. And then I did a direct observation of selected surgeries to really describe the social networks. That's where the real fun of this study occurred. Relational coordination is something that came out recently, as recently as 1994, from Jody Cattell at Brandeis University. It's really about a mutually reinforcing process of interaction between communication relationships carried out for the purpose of task integration. 120 operating room personnel were contacted who performed general surgery cases. Unfortunately, I only got about 34 responses. Survey was open for almost a year. So here's the questions that are involved with the relational coordination survey. I won't read these each of you, but they're really broken into two parts, which is the first part, which is focusing around communication, and the second parts, which are the cornerstones of relational coordination, which is shared goals, shared knowledge, and mutual respect. For social network analysis, it was the second that I used in this study, and it really talks about the formal and informal social interactions that characterize relationships for the networks that have specific linkages in an operating room. Data collection, I recorded over 1,100 communications during only 10 general surgery cases. I used this really cool tapping app called Quick Tap app. It allowed me to really look at the two roles in communications, a source, a target, and how those relationships were communicated to each other throughout the surgery. I also used a tool called Gephi to actually do the social network analysis, and I'll show that to you in just a moment, what it produces. So here's just a sample of how I did the collection for the specific observations in the operating room. The demographics for this group were the different roles that exist in the operating room, the surgeon, the nurse, the anesthesiologist. And as you can see from this, the highest frequency was in the anesthesiologist and CRNA categories. That will be important in a moment. For relational coordination, I showed these on the survey, all of these particular aspects, and where this showed where they lied is the most frequently indicated on the survey results. So frequent communication is an area that we learned very early on was something that didn't happen as much as it should in the operating room, as did shared knowledge and mutual respect. Those showed up the most from the surveys that we collected. So the results part is the part that I want to spend the most time in, and I know I'm limited on time, so I will do my best to be as quick and thorough as possible. The analysis of these social networks, it brings this really fantastic distinctive lens into things. You get to see things both at the macro and the micro level, and that micro level is really around the teams, the power, the trust, the conflict, and the organizational citizenship behavior, all things that are very prevalent in the literature right now around trying to improve safety in the operating room. So this is just a summary of the surgeries that I looked at with each type, the start and end time, duration time, and the number of communications observed in each study. And unfortunately, I don't have time to show you each of the diagrams that came from this, but when we get to them, I'll show you how elegant and beautiful they are and how they really show these communication links and the role identification within the operating room. So the folks that showed up the most in the most of my studies of the 10 done were the surgical tech, surgical assistant, surgeon, circulating nurse, and anesthesiologist. And that is your core team for just about any case that you would do in the OR. So it's as we expected. So one of the things we looked at were how these relationships existed and how they had communications between, and the number of those communications. The top 10 outgoing communications were from role 15, which is the surgeon, and then role 4, which is the circulating registered nurse. That was something that these communication pairs were very important to me because I was so focused on how the circulating nurse might have an impact on the overall time or what their role, how their role might exist within here. So this comes from Gephi. These are the definitions of the social networks. This was the most interesting and for me and exciting part of what the work we did. If you notice, this is our shortest surgery with laparoscopic cholecystectomy. There's a very tight group around the surgeon, which what this is telling you is that there's a lot of outgoing communication coming from the surgeon they're called what's a hub, the center of, and the person that is receiving and sending the most communication to the group. This is kind of what you'd like to see in an operating room. It's representative, you know, of what we would predict. A lot of communication from that circulating nurse going back to the surgeon. A lot of communication from the anesthesiologist going to the CRNA or anesthesia assistant. The thickness of the lines indicates the frequency of how much the communication is taking place. So there's, as you can see, less communication from the surgeon going out to the patient and family. The second diagram that we did, this one is really demonstrative of the communication value and the most communication coming from the surgeon. And truly this is the true explanation of what social network analysis defines as a hub. And it has a hub has a very high density. It also is the primary source of most of the communication that takes place. This is a little bit what I'd hoped to see was a little bit more in most of the cases of the circulating nurse being prevalent and driving some of that communication. They still have some coming from them, but as you'll notice, more is coming from the surgeon actually to the circulating nurse, and more coming from the tech to the circulating nurse. This will come out in some correlation coefficients I share with you shortly. So this was our longest laparoscopic cholecystectomy. As you might have noticed in the previous surgeries, we had a lot of going back and forth that was between the particular individuals. This was very particular in the first diagram that I showed. But in this one, we have a lot more of crosstalk going on. So it's directed talk. Again, that thick line between the surgeon, surgical assistant, and surgical tech. What's interesting about this even more is there's more incoming communication driving towards that circulating nurse. People are asking that person questions, and they are having to figure out how to answer in a very high complex environment and make quick and fast decisions. Higher closeness is also what you see in this role. They're closer to the surgeon, they're closer to the anesthesiologist. And like I said, this was the longest lap chole that I observed at about an hour and a half. So being that this was an exploratory study, we wanted to see what would happen if we did some clustering coefficients where a 0 indicates a very sparse, non-dense cross communication, and the surgery with higher clustering coefficients were longer. So you can see, we talked about that surgery 4 being a little bit longer, being outside of the scope of the, so this guy here was a Whipple. That was our longest procedure that we had. It kind of did not correlate well with any of these because of its case length duration and because of its absolute complexity. The closeness centrality metric is where higher values indicate nodes interconnected within the graft, which means a lot of energy flows through the nodes. With respect to the longer surgeries, the centrality metric was close to or at 1. So the long surgeries, number 5, number 4, land closer to number 1. I'm sorry, excuse me, I misstated that. Number 1, number 2, number 10, number 9, and 4 were our longest surgeries. And finally, we looked at this idea of that I talked about of hub centrality, and this particular ranges from 0 to 10, the most outcoming coming from those associated with the shorter surgeries. So you can see here that there was more hub communication. I kind of shared that with you in one of the graphs that I showed you previously. But this is where you see the surgeon or an individual being the focus of all of the communication taking place in the operating room. They are sending out the data, they are sending out that information to the rest of the team. So for AIM-1, the relationships in the operating room, I just review these. What part of the operating room team does the circulating nurse fit within? And then what are the patterns that exist within that operating room? So, and the section was to describe the circulating registered nurse role within the social network. So there were a lot of limitations to the study. We had a singular hospital, a small sample size. The effect of the CRNAs, who had a very high, they were the most people who responded to the relational coordination survey, and some of the analytic limitations based upon our learning and knowledge as we went through the social networks. The implications for practice and research, these are very unique methods to assess communication and relationship patterns in the operating room. It explicates the circulating registered role, brings it out of the dark and into the forefront. It improves surgical case duration. There are opportunities to improve communication, relationships, and mutual respect. This has been well documented in the literature. And there seems to be a relationship between the amount of communication and time spent in the operating room. So I will open it up if anyone has any questions. Otherwise,
thank you, Dr. Kent, for this great topic. If there is any questions for Dr. Kent or comments, just raise your hand or type it in the chat box. It seems like there is no questions. I would like to thank you, Dr. Kent, for your
sure, thank you.
presentation, because you are in a hurry. So I will not asking you any questions. Wish you a wonderful day and wish you a great and lovely day, and see you soon, inshallah, in our next conference.
Thank you for the opportunity. Have a great day.
You are more than welcome. You too. So let's in a hurry move to our next Russian speaker. He's an editor independent research from Russia, Moscow, and his speech will be about predicting of enrollment as a part of risk-based management of clinical trials. Doctor, sorry, I can't see, I can't read your name, so you have to introduce yourself.
No problem.
Yes.
Now we have already around midnight anyway, so thank you for invitation me, and I would like to present my short or not presentation. So I will now launch it. Okay, and I will switch off video if you do not mind. So do you see my presentation?
Yes.
Okay, good. So let me introduce my investigation, because I think it is important that predicting of enrollment as a part of risk-based management of clinical trial. Why I chose this topic? Because the actuality of our studies, risk-based management for clinical trials is a tool which has been developed to address the many threats to clinical trials. The most actions in any risk-based management plan is applying the efficacy of investigation medicinal product and safety and well-being of patients when enrollment start being based on the convinced that feasibility done on high quality level and selected sites will give enough enrollment. Unfortunately, not always the enrollment would be as it is promised by the site. The failure in recruitment is also the risk which must be avoided and addressed in case of appearing. An obligatory stage before starting a clinical trial is to conduct a study of capabilities of clinical centers to implement their protocol feasibility, according to the authors showed here, Kibi. And the same author talks about the flexibility of the concept of feasibility from sponsor to sponsor. Poorly conducted feasibility study is a barrier to patient recruitment and undergoes the study to risk to be failed. Risks which might be raised during the clinical trial is accepted by clinical trial stakeholders and graduated accordingly. And the number of failed studies due to insufficient enrollment of patients reached 80%. So what we've done the observational review from the 4 studies which are presented here. This was mostly oncology studies, but also there is a rare disease like idiopathic purpura. So we investigated data observed by 70 clinical centers participating in second and third phases trials in 3 CIS countries, Russia, Ukraine, and Belarus, for the period for more than around 10 years, in order to determine the parameters and values which could be useful for prediction of recruitment. The collection of data was done out from questionnaires in the stage of searching for centers, and after the recruitment were completed. We also developed our classification of sites based on recruitment and speed of recruitment. It is silent sites, rate of recruitment 0 patients per month, low recruitment, rate of recruitment by up to 0.19 patients per month, middle recruiting by the 0.2 to 0.89 per month, and high recruiting over 0.9 patients per month. So parameters we took to investigate the recruitment is following like this. So type of sites, also time from first contact of site to first reply in days, duration of recruitment, speed of recruitment, target speed of recruitment, percentage of performance of target recruitment, experience of investigators. In some others, which I do not put here because it is much expanded, the panel of parameters. Anyway, also we took a ratios of parameters, and this is target recruitment to study population, time of first reply to target recruitment ratio, of course, 1 to time of reply, one to target of recruitment, and ratio of 1, or 1 to time of reply to ratio 1 to target of recruitment. So this is, I understand that it is some complicated. Anyway, I'm ready to reply to any questions about these ratios if it will be raised. Then we investigated the sites which proposed the recruitment on the study of feasibility, and then afterward, after completion of the enrollment, did not enroll any patients. And you see that there is, before the start of enrollment, there is no any type 1 or type 2 sites, is non-recruited or low recruiting patient sites, and means recruiting patients. And you see that there is only middle recruiting and high recruiting sites. Of course, this was the promises. And then after completion of enrollment, we'll see that there is already more than 30%, 37% of sites which do not recruit patients at all. Then with regard to exactly the patients, so it was estimated patients which sites showed could be recruited. It is a figure 729 patients, and after completion of recruitment, it was only 622 patients, and it was only patients which come out from the sites came from the 44 sites out of 70 sites planned for that studies, for these studies. And also you see there is a number of centers which were activated and did not enroll the patients at all. It was also about for example, for one of the study reached up to 33%. Time spent of recruitment was also increased dramatically. For example, for rare disease, it was I again should mention that all of that studies was successful in recruitment. That's why we expect that so all of that parameters is quite good with regard to that studies was successful. Anyway, so time spent of the recruitment was also increased compared to the target time up to 300%. Also, rate of recruitment also was decreased up to 12 even percent compared to the target estimated by protocol recruitment. And also there is some difference or discrepancies on the start of recruitment on the stage of feasibility. Site showed that they as the sites estimated a rate of recruitment on one figures, and but the estimated targeted patient recruitment was the other one. So short discussion. Feasibility study is a prediction of future research. And one of the main objectives of the feasibility study is to show that the study clinical centers or sites have a pool of patients required by the protocol. And the recruitment of patients and the success of the entire study depends on the quality of the feasibility. And to date, the number of successful studies is much less than successful ones. And our study shows that only 56% of sites is recruiting the patients out of all selected sites in the study, which were successful in recruitment at the end. And 37% of sites do not recruit any patients, though they show that they have the patients on the feasibility stage. The determination of the rate of recruitment of patients by clinical centers is also fixed by international rules and should be determined at the beginning of the study. However, there is no generally accepted classification of centers according to recruitment speed. We propose the 4 types of the sites based on speed of recruitment, which could be used in future to evaluate the sites, and recruitment of patients in clinical trials according to protocol requirements is an important component to the successful clinical trial. And also, our analysis revealed that increasing of recruitment time raised up to 4 times compared to the target time, and speed of recruitment appeared slowed down more than 100%. It means that neither of 3 parameters of recruitment, time, speed, and number of did not comply with the protocol requirements. And risk-based management rules, according to risk classification guide of this year, is evaluating the non-compliance recruitment as a minor or major risk for the study. In order to predict the enrollment on particular site and to decrease the risk of non-compliance, there is a simple calculation. This is one of, there is a few approaches, but they all are just calculation, simple calculation. I put here only a few authors. And we propose to use the model, this is developed by me, that's why I put here Dr. S. Melovanov. So I took the parameters and ratios. Based on that, I made a regression analysis, and using that model, this turned of formula. Then I checked this formula and you see that using the Rock-Auk approaches, and you see that there is a figure 0.647, which means that this model is works good. And this is a graphics shows which shows that model. And so definitely, so we developed a tool for objective decision whether the site would enroll the patient, and this could be included to the risk-based management plan of any clinical trials. Thank you very much. You can reach me if you would like. So any questions?
Thank you, Doctor, for your great topic. I will open the stage if there is any comments or any questions for our Russian doctor. He will answer all of your questions. It look like there is no questions. So I will start with my 2 brief questions. The first question is, what's the main purposes of risk clinical trials?
Well, you mean risk-based management?
Yes.
There is a lot of risks which could lead the clinical trials to the fails. So the recruitment, one of that risk, and the purpose of this is to mitigate, firstly, to mitigate the risk. And so the tool which could be developed depends on the study, and also there's a wide range of the tools. So, but none of them is applying for feasibility. They start only when enrollment is started, and during the enrollment and after completion of the enrollment, because there is a part of studies where the risk could be raised and risk-based management could be applied. So that's why. So the main is the purpose of the risk-based management is to mitigate and to manage clinical trials, to lead clinical trials to the success. So either it would be recruitment, it depends on the phases.
Okay, and the second question is there a relationship between clinical-based management and patient safety?
Of course, safety is efficacy and safety is why clinical trials is conducted. So that's why clinical trials and safety is absolutely has a direct relationship.
Thank you. Yes, I can hear you. Thank you, Doctor, for answering my quick questions. I will ask you to keep staying with us because our great speakers will continue their informative speech. Thank you, Doctor.
Bye.
Okay, let's move to our next speaker is Miss Plum Turner from UK. I'm passing her the stage to deliver her speech on research done in the conversation at the cutting edge of life sciences and healthcare. My dear, the stage is yours.
Thank you so much, and lovely to be here. It's very dark around me, I'm afraid, because it's quite late in the UK. So lovely to see you all in the afternoon, and also those that are in Europe. I hope you good evening. So if you just give me 2 seconds, I will just share my screen.
Sure.
It's always the way, isn't it, that the system preferences don't play ball when you want them to. Okay, I'll have to come back in. I'm so sorry. Sorry about that. Hopefully this is now going to work, but we will see.
Yes, now it's working.
Perfect. That's great to hear. That on full screen. Well, look, thank you. It's lovely to be here. And I think this will probably be slightly different in tone to the other talks that you've had this evening. And I know that you've had, well, I've been listening into some fascinating talks from professors and from people working at the, right at the front end of the medicinal research area. So what is researcher? Why are we in this space, and how are we crucially able to help? So we started researcher in 2017 to help the life science and health community stay up to date with the latest research, insights, papers, all the latest kind of white papers and news and insights across company websites, across the research community, because we know that it's incredibly difficult actually to maintain and to stay on top of all that research. There's thousands of pieces of research coming out every month, and we know that if you want to be at the cutting edge of your domain, you need to be consuming that. And I heard a stat the other day in terms of someone who's working in oncology, the number of papers they need to be reading on a monthly basis is astounding. And frankly, they would never actually get to treating patients because they would be reading the research they need to be reading. So Researcher is a content discovery and discussion platform. What that means in practice is we have an app, and the app is widely available on the App Store and also on Google Play Store. And it's free to download. So it's free for users to download and start to use. And it's also free for the publishers to have the content on the app. So on the left-hand side, what you're seeing is what it looks like when you log into the app. And what you can see is you can scroll through a bit like a newsfeed, all the latest research which is coming out. And that means that as a researcher, you can stay up to date on that research. In terms of numbers, we've got 2.4 million users globally, and they are combined making 12 million impressions a month. So crucially, they're an engaged audience. And then when you look at the split, and crucially for this audience, what is the split? So 38% are within medicine and healthcare, and then 36% are in the life sciences. And we also have an even geographical split, which I can go through. So the problem we're solving for people who are, I'm assuming are on this call, is helping you to stay up to date with that research, but also to discover research which might not necessarily be returned to you through other results, or might not be in the journals and papers and publications you're reading by default, but also to discuss those papers with your peers, with those people who may also be using the app, but also that you can share around and share with your colleagues. So that's a quick overview of who we are. And then in terms of audience, so over 1 million of the 2.4 million are specifically in the science, medicine and healthcare space. So over 42% of our user base overall. And as I mentioned earlier, it's a even geographical split. So we have a strong audience in China. We've also crucially got a strong audience in UK, Europe and Americas as well. So it's evenly spread geographically, and 60% of those users are interested in the sciences and also life science. And then in terms of seniority, it's mixed. So we have a high number of PhD students, obviously crucially important in terms of continuing to cut through and push research forward. Professors, PIs, we've got 5% of our audience, and commercial scientists as well. And then medical professional, gosh, I can't speak, sorry. Medical professionals, we've got 11%. So it's a high quality audience, and it's an audience which is working right at the forefront of this research in medicine. And so what does that mean in terms of actual numbers? It means we've got 91,000 people who are medical professionals or doctors. And then in terms of the areas they're covering, they are covering surgery, infectious diseases, oncology, immunology, and microbiology. And then the top 5 most engaged topics. So that's what are people consuming most in the app, which is interesting in terms of trends. We do lots of surveys, lots of research to understand, you know, what's the topic that everyone's searching for at the moment? What's the topic that everyone is interested in and engaging and staying on the page the longest for? And the results that are being returned right now are clinical medicine, epidemiology, psychology, organ systems, and cancer. So some of the big themes are kind of pushing through there. So how do we help you connect with the audience? So you may be joining this conference, and you may, for example, be wanting to reach people who work in medicine. You might want to reach PIs who are working in labs, or indeed commercial scientists. And we are able to help you do that primarily through 3 main channels. So we can do it through engagement and content marketing within the app. And what you see on the left is a standard kind of advert that we're able to play through the app, so that you can drive awareness, but also crucially engagement. So there's a call to action button and you can collect leads. Secondly is lead gen. So you may, and we work with a lot of life science companies that want to do this. So we work with the likes of Thermo Fisher, Cyno, Biotechne, who all want to collect leads. And we're able to do that natively in the app. So you're not having to send the users off to another third party. You can do that in the app. And then thirdly, and probably most interesting perhaps for this audience, is we also write and publish our own insights reports. Our most recent one was on the neuroscience of sleep, which generated over 2,500 leads. So that is something which we're able to do and to put together, and we can react and do custom reports as well, based on topics you may be interested in. We also have a discussion platform. So we have Researcher Live. This is our own tech. It's not a Zoom channel plugged in. And what it is that it's like a mixture, I guess, of a podcast come kind of almost radio show call-in. And so if you are on this call and you have a piece of research that you want to bring out, or you're working on at the moment, as indeed some of the talks that I've been listening to have been, you can bring that to us and you can conduct your own research live, and you can discuss that with other peers who work in the research community. So you're able to therefore, you can either have an open conversation, say, look, I just want some peer-to-peer feedback on this research, or you can actually have more of a presentation format where you are presenting your findings to an audience. So we are able to conduct these with you and for you, so that you don't have to do anything. You can literally turn up on the day like I have today, admittedly, so thank you so much, and present your findings, present your research, and engage with the community. And then we also, as I said, have the neuroscience of sleep report. Our next one is on the neuroscience and AI. So we are basically going to our audience, going to our community, asking what the topics are they want us to write about, and then we're able to respond to that, and we're able to generate reports based on exactly what we know our audience are interested in right now. And we're working with people who are in industry, who are working as doctors, but also people who are researchers, both on the commercial and the academic side, to put these reports together in order to help continue to generate and further science. And that is a whistle-stop tour on who we are and what we do. But I think it's important just to finish by saying that the life sciences and the health sector is obviously, it's crucially important that we can continue to learn from and draw upon research which is coming out and being able to piece those pieces of the puzzle together. And that's what we're doing at Researcher. We're able to help streamline, because I know there's so much research that's coming out, make it easier for you to find that research, discover that research, and therefore be able to progress your own academic or indeed practitioner studies forward. So thank you so much for your time today. Thank you for joining, and thank you for inviting us to come and speak to you. And any questions, please do let me know.
Thank you, Ms. Plum, for your lovely speech. If there is any question or comment, just raise your hand or type it in the chat box.
Sorry,
Yes,
Amal.
yes.
I just want to ask, is this a paid application or is it for free?
It's free. So it's free. If you'd like to download it today, you are able to do that. It's free to do. There's no wall, there's no kind of freemium service. It's because we really believe we want people to be able to use this app to generate science. So yeah, it's totally free to download.
You know, because all of us are using the newest research things to also do our research. So it's important. This is the first time I know about this application, and I'm going to use it. Thank you.
Oh, that's brilliant to hear. Which, out of interest, which platforms or,
I'm healthcare, but I'm more in the self-care, the mental things, and help, to make sure people are looking after themselves and are adhere to what the doctors prescribe and whatever.
Really interesting. Gosh, well, good luck and thank you.
Thank you.
So thank you very much for both ladies, and please, Ms. Anit, keep with us because you are the next speaker for today. I'm passing you the stage to deliver your speech on burnout and healthcare. So my dear, the stage is yours.
Thank you.
You are more than welcome.
Okay, you can see my presentation?
Yes.
Okay, I just no need to see where, what I want to say, this thing is now a slideshow. From the beginning. I said, it seems to me that it's very light, but all the lights in my lounge is on. And it's from all corners. So just bear with me. It looks like it's day. It's actually in the middle of the night. I want to speak about burnout in healthcare. I was very, very surprised. A lot of people are touching on this subject the whole time. And it is actually a big thing these days. Burnout is not new. Burnout is a long time, but normally before pandemic, nobody says that they are burnout because there is a stigma. How can you say you are burnout? And it's seen as not a good thing. But with can you see this? Are you screen sharing thing? Let me just put it up. Okay, halas, it's gone.
Yes,
so internationally, there's a huge shortage of healthcare workers, especially nurses. And then the burden is so big that nurses rather will be at home without the income or migrate to other countries. And this is what we see. All the well-equipped nursing staff, the staff in critical care, they go to other countries because they are tired. They really are exhausted. Not even enough nurses are trained, and if they complete their training, they resign because of the stress and pressure is too much. Also, they feel that they deserve a management post. So I am working with very young people, and a lot of them come out of the university, then they're 23 years old. And then they work maybe 6 months, and they're very adamant that they need to have a management post. And it's all about the office hours, because otherwise you work shifts, you work nights, you work days, no holidays. You cannot even take holiday when you want it. So the workforce are left with the very matured, tired nurses that are planning for the retirement. That is people like me. The healthcare facilities are under stress and they cannot increase their salaries. If you look what's happening in the UK, the nurses threaten to strike because the government are not able to increase their salaries. Remember, the COVID really hit the economy very badly. So what is burnout? Burnout is actually a syndrome, a result from chronic workplace stress that is not successfully managed and staff feeling constantly swamped. It's categorized by 3 dimensions. It's a feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to your job. It's a result of excessive and prolonged emotional, physical, and mental stress. Nobody wants to be unhappy in their work. Nobody wants to be seen as negative. But this is what burnout do. This is what you feel, even if you acknowledge it or not. Can you remember when it was looked like that? Everybody in the yellow outfits. This picture, at least they don't have the hazmat suits and everything. But imagine you are covered with this yellow thing. You've got gloves, you've got mask, you've got eye protection. And this is how you are the whole day. It's in and out the whole time. This only is very stressful. So healthcare workers at work, they are known to be at risk for anxiety, depression, burnout, insomnia, moral distress, and post-traumatic stress disorder. We heard earlier about these things. It's a reality. And because of COVID, it just gets more, people are more aware of this because this is where we are and it's hitting us in the face the whole time. Under usual working conditions, severe burnout syndrome affects as many as 33% of critical care nurses and 45% of critical care physicians. Eccentric organizational risk factors like the increased work demands and little control of the work environment. I know about there is people that are forced to work overtime and they sometimes not get paid. They say there is no money or you must take time back. How are you going to take time back if you are already so stretched? And in Saudi Arabia now, what we see is it's actually getting to be winter. And we can see the workload of the nurses are getting more. The children, I'm working pediatric ICU. So the children are getting sick. They're really getting sick. So there is not enough staff. So what's happening? You didn't sleep for the day and they say, please come and work. How can you say no, even if you need to? The trauma of caring of patients who are critical ill have been heightened by the COVID-19 pandemic. and represent important exacerbating factors for poor mental health among healthcare workers. How many healthcare workers commit suicide on substances? Just don't care anymore. They distance themselves and most of them resign. Burnout is an occupational health issue. Even if people want to know it or don't want to know it, it's an occupational health issue. It's acknowledging the commonality of psychological distress related to caring of patients with COVID or even sick patients and short-staffed. It is a reality. We need to acknowledge it. And with the COVID-19 pandemic, it prompted a redefinition of essential support workers, and they recognize the contribution of all healthcare workers and appropriate education, protection, and compensation. When the COVID era started, nobody of us know what's going to happen. We don't even know what this disease are. So that alone was stressful. You were scared about your family. You were scared about your patient also complicating and scared about yourself. I know about people that merely get rid of all their clothes before they enter their homes because they were so scared. And a lot of the healthcare workers also got children. They also got elderly people and family members that they need to protect. We don't feel protected because we're not even sure what's happening. And there was a stage that there was no PPEs available. And there's no compensation for this extra stress or time back or better hours or acknowledgement that we are in this difficult situation. Lack of support resources. So there is not institutional support. I was so happy when I learned yesterday about these people that had an app where people can attend some motivational things and they can have some lectures, how to cope with COVID, because this is also very, very frightening. There was not enough PPEs and your mental illness or mental distress was not acknowledged. And there was nobody that supports you, nobody that says, are you okay? Can I give you something? Can I do something for you? So the effect of work-related stress can also affect healthcare workers beyond the working environment. They have burnout syndromes. They are having fear of transmitted COVID. Also their families. Also, they don't want to talk to people and say, I don't cope. Because if you say that, you are getting penalized because you feel that you don't cope, and also you are fearing because of the stigma and you don't want to be rejected. And this is what really happens. It's easy to say that mental illness is a reality, but are we acknowledging our staff getting stressed and our staff are having a hard time before we put them down and victimize them? The reasons for burnout is unmanageable workloads, unfair treatment at work, confusing work responsibilities. We also heard it earlier. So you are employed to be a care worker, but at the end, you're doing work that is actually not your work because the nursing staff itself they can't get to things. So we must emphasize that people must know what their work are, what their responsibilities are in any situation. There's lack of communication and support from managers. There is deadline pressures. There's excessive work demands, limited job resources. Imagine you work and then you need to go into a patient room, but there's no masks for you, there's no gloves for you, there's no yellow gowns. Then you must phone this unit and that unit just to get some supplies. It is very stressful. workload, too much of all the wrong kind of work. People are put in posts because the shortage was there and the need was there, but they don't even feel that they are equipped to do that, but they are put in that environment. Control, no authority to do what is needed to reach work goals. There is not enough rewards in time of money, recognition, or job satisfaction. And you are very, very much isolated. And a lot of the staff get in conflict with their co-workers. Fairness, pay inequality, cheating, favoritism, or disrespect. Also, unethical work or conflict work goals. Look at that. Can you see how we started when we started with the COVID area?
Yes.
Look, we had all these things on our heads and it's heavy and you are so scared. What is the signs? The symptoms of exhaustion. You're just not motivated anymore. You're irritable. You are fatigued, insomnia. You cannot sleep. There's a word, they say you are tired but wired. So you are so exhausted, but your brain is going on and going on and going on. Memory issues, feeling hopeless, nervous, headaches, irritability, change in appetite, or you eat yourself to a standstill or you stop eating. Trouble concentrating, cynicism, depression, increase of illness, loss of energy. Then symptoms of cynicism and detachment, you isolate yourself. Nothing makes you happy anymore. Not even a joke. Nothing makes you happy. Apathy, impatient, being critical. You will find fault with everybody and anybody, and the work and the patients. Everything will be so bad the whole time. You will feel persecuted, hopeless, negative attitude, excessive use of sarcasm, disillusionment with work, loss of job satisfaction, self-medication. What I see about the self-medication is you drink something to sleep, like melatonin or sleeping tablets or alcohol or anything. Then you take some vitamins to get up and feel a little bit better. And then you have headaches, then you've got abdominal discomfort. So all these medication, you self-medicate yourself. But what you forget is that this is a lot of chemicals on your body. You put more stress on your body. You dread of work. Oh, must I really go back to work? You feel like you don't want to go. And before, you actually enjoyed your work. The work didn't change, it's your whole attitude changed because you are tired. You have symptoms of ineffectiveness, a lack of productivity, poor performance, missing deadlines, habitual complaining. That's all what you can do is complaining and missing the work goals. So there's more, you self-doubt. If you look at, you get physical, emotional, behavioral also. So physical, you've got low energy, you feel tired, you easy fatigue, you're getting ill a lot, frequent headaches, back pain, muscle aches and pains. So if you're my age, this is normal to have backache and hip pain and all the pains that is not having a place. But if you are young, 23 or 24 years old, and you have this, what is going to happen to these young people? They are resigning. We're already shortage of staff. But these young people, they say, I'm sorry, I cannot do it. I need to rest. I need time for myself. And the more mature people, they just carry on because you cannot stop. We have families. We have things to do. Emotionally, you self-doubt yourself. You know that you worked for so many years, but now you feel like I'm failing people. I don't know if I'm doing anything correct. They feel defeated and alone in the world. And this was a very isolated time in our life. but it's not over. Even if COVID is over, you know, it's not so bad anymore. That feeling of, it will take a long time. It will take years before we actually get back to where we were before. And then behavioral, substance abuse and dependencies, you're getting irritable, you isolate yourself, and then you don't want to do things. Okay, that I'm not going to talk about. Burnout. Do you think burnout can make you sick? Yes, it can, because it's all in your mind. And your mind and your body is working together. People say, Annette, but how can you say it's in your mind? Your exhaustion, if you are very tired, you cannot cope with nothing emotionally. And the problem is, if you are there, you start telling yourself, you are sick, you are useless, you are tired, you are not good enough, you don't sleep, and then you start taking medication, or you overeat, or you don't eat, or you start substance abuse or alcohol abuse, just to make the symptoms a little bit better. So it can be accompanied by physical symptoms, like headaches, nausea, and sleeping difficulties, and also other things. So a lot of people have stomach aches, intestinal issues. A lot of us are resilient. We jump back to what we was before. But there's other people who don't have that. They are so far that even after the pandemic, they're still in this way of thinking that everything is too much. Treatment. The best thing that you can do to yourself is acknowledge that you have a problem. It's useless to say, oh, you know what, I'm just tired, I'm okay, things are fine, and you jump up and you do things. It's not doing yourself a favor. Seek help and say, I don't know what's wrong with me. Please help me. You see, professional help, make the necessary changes to overcome burnout. Some people see it before the time, but they ignore it because the external pressures on you is too much. Develop strategies to avoid it in future. Prescription medication may be an option, but it must not be your alpha and omega. Counseling in dealing with difficulties associated with burnout. Too much stress can lead to burnout. Yeah, it's easy to say, you need to do time for yourself and do things. Remember when it was the pandemic, you couldn't even go out, you couldn't even walk, you couldn't even go to the movies, you can't even go and shop. And how many times can a person shop? Really? How to manage when you have burnout. Evaluate your options. You can go to your direct manager and say, I actually don't cope. I need to get rid of all these projects. I never saw so many projects in my life like I see now. Every single person has a project or 10. And you can go to your nurse manager or your direct manager and say, can we not divide the workload, divide the projects, see what projects are important, what projects are not important. But then you will say, oh, JCI and Sabahi comes and they are wanting this and they're wanting that and they want to see this project. Where do you get your data? But sometimes we also need to do a reality check. What is most important? We are here for the patients. And sometimes I think we forget why we are here. Seek support, like you can reach out to your co-workers, friends or loved ones, and collaboration might help you to cope. Try a relaxing activity, exercise, some sleep, mindfulness. What I want to say to you about exercise, if you are so far in your burnout journey, you cannot do exercise. You are too tired. You can rather walk around the block, walk and look where there's nature, where there's flowers and everything. Sleep, you cannot sleep. And there is ways to make sure that you can enhance sleeping patterns, but that's another day's topic. Recovering, track your stress levels, identify your stressors, say, this is stressing me out, and track what makes you more stressed and where are you in your journey. Create a habit of journaling and seek professional help from a coach or therapist, build a support network, exercise again, speak up for yourself. I am a person that before I opened my eyes, I already said yes. And I needed to go to this point to say, sorry, is there nobody else who can do this project? I have too much on my plate. But we are so scared, and certain cultures don't actually speak up. I work with a lot of Filipinos, they don't speak up. They won't say, sorry, I cannot. Where the new Saudi nurses, the new generation, they will tell you, sorry, I'm not going to do it. I don't have the time. Can you see where the difference comes? The new generation, they easily say no for a project because they don't need it. They're the instant people. They want everything instantly. But are they always wrong? They are actually looking after themselves. Reach out to your supervisor or human resources department about decreased hours or workload. Also, what about vacation? In the pandemic era, we didn't take vacation. I remember last year in December when the same symposium was in Dubai. I was so excited because in the 3 years, I only went once on vacation. My son was supposed to meet me in Dubai. And what happened? COVID strike. I took 10 days vacation to be with my son. And it was very traumatic for me. The conference was good, but then what about the other days that I was there? I was alone. I enjoyed my time, but then you start feeling isolated again. So yeah, you are allowed to take vacation, but in these circumstances, we were not allowed. I was very lucky that I got a little bit of days there. Do some self-reflection and notice what your own signs of burnout are. For me, it was very big because I don't want to say no to people. I don't want to disappoint them. And until I realized that I am tired but fired, and I cannot stop. And when I started to acknowledge that I've got burnout, it's much easier. I can say no now. I can do things, I'm happy, and I can say, it's now the end. I need some vacation. Sometimes you just need to stop and breathe, take inventory of your stressors, say no to new commitments, delegate where possible, unplug frequently and daily, set boundaries, engage in healthy activities, and like I said many times, seek support. Get up and go to bed at similar times every day. Keep up with personal hygiene, eat healthy meals at regular times. This is also a big thing. When are you going to eat? The unit is busy. Nobody's eating. When are you going to eat? And this is one thing about healthcare, especially in critical care. We don't take off. We don't take our lunch. We don't take rest in between. Nothing. Allocate time for working and time for resting, and make time for doing things that you enjoy. So make yourself a priority once in a while. It is not selfish, it's necessary. Thank you. Any questions?
Thank you, my dear, for this lovely and amazing speech. If there is any question, just raise your hand or type your questions in the chat box before I will start my questions. Okay, let's in a hurry in 2 seconds before we are leaving for the lunch. I have two quick questions. The first one is, what's the difference between burnout and turnover?
Well, burnout
Mhm.
is a physical symptoms.
Mhm.
Turnover is turnover. It goes faster. But with burnout, it actually stops your whole system.
Mhm.
You cannot think, you cannot sleep, you cannot eat. You don't have any reserves. And this is a problem because your whole body, everything is shut off. Where your turnover is, you can still go on, especially where you can see, like you're tired but wired. You still go on. But when are you in trouble? It's when
Sure.
you're on burnout.
Yes.
Hmm.
Okay. The second question regarding, is there any sample for motivation strategies overcome the burnout in your hospital?
No.
So you have to work in for that.
You know what? That is my focus for the new year. You know, the IDPs that we are doing. We need to do this. We need to look after our staff. They are so despondent. They are so isolated that even if you want to try to do something fun, you need money. You need to have time off. And it's not always happening because now it's so shortage of staff. And don't think it's only here, it's internationally.
Yes.
There's no staff. So you plan to go out. Like for us, I like to go to the desert. That's where I get my energy, especially in winter's time, because you just look at the stars and you just breathe everything in and hope there is not a sandstorm. So it's something to do. But you plan for it, but you cannot go because your work, you need to be at work. So people can't plan. But that is a big thing. We don't have anything in our hospital.
And you must just start to do it shortly. So
Yes.
thank you, my lovely, for your great speak. We will return back after 30 minutes after lunch.
Thanks
Stay
a
with us.
lot.
Thank you.
Thank you. Bye-bye.
Bye-bye. So good afternoon, everyone from the lounge. Let's start our speech for today. So our next speaker will be Miss Maria Jessica from KSA, as she was planning to present her speech about developing leadership skills for the clinical nurses at the bedside, but she had an emergency case, so I will present her speech on her behalf. Okay, Miss Maria Jessica Lauders is a clinical care coordinator, care coordination at King Faisal Specialist Hospital and Research Center in Riyadh. Her speech is about developing leadership skills of the clinical nurse at beside. Objectives of her speech about nursing leadership definition, what's PRISM, how units are exemplary for PRISM, what type of units qualify, background, objectives, F2 medical surgical unit at the hospital in Riyadh, data outcomes, results, and conclusions. So, King Faisal Specialist Center is known to be a magnet accreditation hospital with 1,589 bed capacity situation in Riyadh, Saudi Arabia, award-leading organization and Gulf region. What's leadership in nursing? Nurses leaders make up a majority of the healthcare workforce today. Exceptional nurse leaders motivate and inspire their current workforce every day and encourage them on their career paths. They are usually seasoned nurses or administrators who have refined their skills to advance them to the next leadership level. Experienced nurse leaders are essential as their team is only as successful as they prepare them to be. Many describe proper nurse leaders as encouraging, inspiring, and supportive, but adaptability is key to being an exceptional nurse leader. They must adapt to the ever-changing nursing industry and all the issues that affect it. Change such as the nursing shortage continue to affect hospitals across the country. Having good nurse leaders will establish a more cohesive staff, which will improve the overall patient experience and benefit the workforce together. Premium recognition in the specialty of medical surgical. What is this award means? This award is co-sponsored by the Academy of Medical Surgical Nurse, and the Medical Surgical Nursing Certification Board stands for premium recognition in the specialty of med-surgery. It was created at the request of the Academy of Medical Surgical Nurses members who wanted an award to recognize the exemplary practice of the medical surgeries. So these awards provide special recognition to the exemplary practice of medical surgical units. Is your unit exemplary? The professional nurse is responsible for the individual practice, but it takes a dynamic, energetic, and committed group of professionals working as a team to achieve and sustain outstanding patient outcomes and high staff satisfaction. Through this distinguished honor, the both boards identify and celebrate medical surgical units that achieve sustained excellence through exhibiting effective leadership, recruitment and retention of competent staff members, evidence-based practice, positive patient outcomes, healthy practice environment, lifelong learning of units members. What types of unit qualifies as a medical surgical unit? Patient care units eligible to apply for the award include any individual acute care unit with a primarily adult and or elderly patient population with medical surgical diagnosis. These units may admit and provide care of adolescent patients on a periodic basis on overflow capacity, be a combined adult pediatric unit that is classified by the facility as a medical surgical unit, utilize remote telemetry monitoring but may not be classified as step-down progressive care unit by their facilities, be from the same facility as long as each unit fits the description of a medical surgical unit and applies individually. It was created at the request of this board's member who want an award to recognize the exemplary practice of medical surgical units. Background: the care delivery system provides a framework for nursing practice which identifies roles of nurses and defines the delegation of authority and assignment of accountability, detects how the work is organized, how nursing staff is developed, and who does what in providing nursing care. The care delivery system is integrated within professional practice model. It identifies the individual needs of the patients as well as the healthcare workers and other resources necessary to achieve desired outcomes for patient care. The care delivery system involves the patient and family, nurse, primary physician, and other members of the multidisciplinary team who maintain collegial and collaborative relationships in order to meet the needs of the patients. Objectives: exemplifies the qualities that define excellence in the medical, surgical, nursing, and is a public symbol of the inpatient unit's journey to optimal outcomes and exceptional patient care. So here is a photo for F2 medical unit in King Faisal Specialist Hospital in Riyadh. And here is the data outcome from 2017 to 2021 prior and submitted to the document for this award. Here is also another data. Continuing, compared adult medical between any quarters of 2019 to 2021, quarter one and quarter two. Results. F2 at King Faisal Specialist Hospital in Riyadh unit scored advanced 5 out of 6 categories and high competent in 1 category with an overall score that exceed criteria to have this award. Premium recognition in the specialty of medical surgical. And here is the resources that she used it, or the hospital used it to award this recognition. She thanks all of us to listening to her speech. We wishing that she was here to present her presentation, and if there is any questions or comments, you can just write it in the chat box. We will send it to her. Is there any comments or questions? We will share it with her. It seems look like there is no more questions or comments. So within few minutes, our next speaker will be with us, but we would like first to thank Ms. Ghada An-Naimi from KSA, as she was planning to present her speech about innovation for nursing online in Saudi Arabia, but due to the last minute's emergency case, she will not presenting her speech, and we will pass to the next speaker is Dr. Salwa Sulaiman from Egypt, and her speech is about simulation-based learning. Dr. Salwa, the stage is yours.
Miss Amal, can you hear me?
Yes, I can hear you.
Hello, how are you?
I'm good.
This is Nofl Aklabi. I think you skipped my name. I'm after Ghada in the list.
Okay, one second. Okay, no. Dr. Salwa will speak at Miss Ghada's time. Then you will be the
Okay.
next speaker.
I'm sorry.
No,
I apologize.
Okay, so Dr. Salma will be with us after maybe a while. Miss Nof, if you are ready now, you can do your speech. Our next speaker is Miss Nof Al-Aklabi from KSA. I'm passing her the stage to deliver the speech on evaluation of public health education and the practice from the perspective of public health academicians, postgraduate students, and alumni in Saudi Arabia. The stage is yours.
Thank you, Miss Amal.
You are
Can you
welcome.
hear it all?
Yes, and you can share your screen, please.
Okay. Okay. Should I use the PDF or it's okay to use the PowerPoint?
The PowerPoint, my dear.
Yeah. Okay. This picture was taken by me back to 2013. It was my first time to be introduced to the public health concept. And since then, luckily, alhamdulillah, I got in the field and now I'm presenting the thesis of my master in public health. By the way, the book shows in the picture is the key concept in public health by Francis Wilson. So For my thesis, it was an evaluation of the public health education and practice from the perspectives of public health academicians, past graduate students, and alumni in Saudi Arabia. I know it's a huge target group for thesis purposes, but luckily, alhamdulillah, I finished this thesis and now I'm presenting it. So for the contents of my presentation, it will be, we will go through the rationale, the study aim, objectives, the methods, the study area, the study participants, and the study design and participants. And we will go through the findings, which is, I used qualitative study. The result we have is themes and sub-themes emerging after the interviews. And we will conclude our presentation with some recommendations. So for the rationale, as we all know, public health initiatives contributes in reducing the mortality and morbidity among all worldwide. So, and it's improved the quality of life. For Saudi Arabia, as the national 2030 vision aimed and strategized some of goals that intersect with the public health goals, such as increasing the life expectancy, improving the health determinants, and building healthy cities. So due to this important profession, my aim was to evaluate and evaluate the public health programs, the public health education programs regarding the practice from a perspective of public health leadership, academicians, and postgraduate students. So for the faculty and leadership, we aim to identify their perspective of meeting the components of the curriculum they are teaching. And for the current student, we want to assess their viewpoints of the programs they enrolled in. And for the alumni, we want to investigate the impact of the public health program on their career advancement. So for the next slide, we have the methods. As I mentioned before, we used a qualitative study design, which is an explanatory phenomenological qualitative study, which conducted in-depth one-to-one interviews. And for the sampling technique, we used a snowball sampling to track the participant and alumni, and we used social media platforms such as WhatsApp, LinkedIn, and email, and we conducted the interviews through online platforms such as Zoom and Microsoft Teams. So for the study design, we have three main universities that provide the public health master, and there are two of these universities are public, which is King Saud University and King Saud bin Abdulaziz for health science. And we have one university which is private, which is Al Faisal University. So we have here the data collection methods. We used a semi-structured open-ended questionnaire, and it was collected from the literature, and we adapted to the local contexts. And for the analysis, we develop analytical themes to interpreting the qualitative data by using the program DDoS, which is usually used for the qualitative data. So for the ethical concentration, we obtained the IRB approval, and also we ensure the anonymity of the participants. For the data management, Most of the interviews were conducted through Zoom due to the COVID-19 pandemic, and only few interviews were held in person, especially with the leadership in the universities. So for the sample size, as you can see here, the total grant of the participants were 39 participants. 20 of them were students, and 12 of them were alumni, and we have 3 of the faculty members, and we have 4 from the leaderships in the 3 universities. So for the results, here some of characteristics of the participants. The sub-majors that the students enrolled in or graduate from were this 4 disciplines. As you can see here, we have biostatistics and epidemiology, we have health system management, we have health promotion and education, and the least participants were graduates and enrolled in community and environmental health, followed by health policy. So here, the background of the students and alumni before seeking degree in public health. As you can see, the orange one is the MBH holders, the graduates who have MBH, and we have the blue lines, which is currently enrolled in MBH program. As you can see here, most of them were health educators or public health specialists, and the least of them were pharmacists and other health professions. So here, the participations organization, since my target group were the public health students and graduates, most of them were working already. So as you can see here, most of them were already working with the Ministry of Health. We have here the National Guard Hospital, we have King Abdullah Hospital, we have King Fahd Hospital, and the least of the participants were engaged with or working with the private sector. So we move on here for the faculty and leadership qualification. As you can see here, their experience in teaching public health in Saudi Arabia specifically verify from 2 years up to 15 years. And here are the education and background of the faculty members that are participated in my study. And luckily, alhamdulillah, I got a lot of information from the leaderships and the faculty members to improve the programs of public health. And by improving the public health programs, the quality of education and the outcome of the education will benefit the work, the public health practitioners in the future for the work advancement. So here the themes and sub-themes emerged after interviewing the students who already enrolled in the program. So we have 4 major themes. The first theme we want to investigate is their motivation of studying public health. The first sub-theme emerged is they seeking promotion from their job and job opportunities. Also, they motivated to work with the community and improve the health for the general public. And for the downside here, for their motivation, some of the students faced, because of the Saudi Commission for Health Specialties restrictions, limit the students' choices to seek their preferred majors. So the Saudi Commission for Health Specialties have these rules. Those who have public health background or health education background, they should follow the same field, and that lead some of the people to engage in this program. So for the availability of facilities and resources, the majority faced a shortage in technical support, especially the statistical software such as SPSS and EndNote. Some of them ask for access to this two types of statistical, and they don't have the access, so that limit their benefits from this program. For the positive side of, or the sub-theme that considered positively, most of them received a guidance and support, although the programs and this study were conducted through online, through virtually learning experience during the COVID-19. So for the third theme, which is the university regulations, one theme emerged in one of the universities, and they have a policy in conducting the program, which is segregation between females and males. And this happened in King Saud University. So the females were in other class and males in another class. So the segregation between them leads to some of the responses I have. There are a favoritism for males over females, and regarding their opportunities and instructions, and also the exams is different. So it's all considered as a negative experience for the students I interviewed. So for the fourth emerging theme, we have the contents of the curriculum. Here, some of the conflict between the students' responses. Students with other healthcare profession thought that the program is beneficial, and they added to their information. In contracts with the public health background students, they have a different experience. They claimed that it is repetitive and there is no upgrade for their information. So we move on for the alumni responses. Here are the sub-themes and themes regarding the careers advancement. So most of the graduates, luckily, get the promotion and job opportunities they looking forward after graduation, and they already enrolled and involved with the national strategies, which is aligned with the Saudi Vision 2030. For the knowledge applicability, most of them comment on the research skills. They obtained a lot of skills regarding the research, but in the work field, unfortunately, they can't apply it anywhere because their workplace didn't need any skills from the research. So it's a downside, and I don't know, it's depending on the work field. If it's needed a research, they can apply it, but if they're working at the hospital, they can't apply the research skills. And for the downside of the themes, we have lack of certificate classification from the Saudi Commission for Health Specialties. Some of the graduates who have different background, unfortunately, after they finish MBH, they didn't get the certificate classification. So that impact their career advancement, and they didn't use their certificate for their benefits. So we move on for the common themes emerged among students and alumni across all universities. There are common themes regarding the time management. Most of the students were working and studying at the same time, which is exhausting. And most of them lack the time management skills. So for the organizational approval, few of them lack the support from their employer, and that leads to challenge during their studies, and some of them drop out because they didn't have the approval from their employer. Also, for those who have different background than public health, they have challenges regarding the biostatistic and epidemiology courses. And for the research and accessing to national data, all of the participants agreed that they didn't have any access to national data. They should request, it's a long run to request a data from, to adapt a local national data. So, and for career counseling, a lot of the alumni agreed that they lack the career counseling, and after they graduate, they lost and they didn't know where's the strength in their certificate. So there's no career center in their college, so they didn't have any support regarding this issue. And for the lack of field experience, most of the participants suggested that they should add a practicum courses, except for Al Faisal University, they already have practicum courses. For the faculty and leadership responses, there are multiple themes emerged from the responses. We have the student commitment. As you can see here, some of the faculty members claimed that students were poorly committed because it's a full program, and the students they have is part-time students because they have another job to attend, and unfortunately it's affected their performance. And for the educational background for the students, some of the faculty claimed that the educational background affects and determines also the performance of the students. So those who have a public health background, they usually have higher scores than those who have another health profession. So we have here also the third theme was research budget and assistance. Unfortunately, there are a shortage for the research, financial, and support from the university itself or from the outside. Also, some of the faculty comment on the majors of public health. They think that there are a lack of diversity of public health programs that taught in Saudi Arabia. Also, for the last emerging theme, we have public health during COVID-19. Most of the programs were conducted online and virtually, and that affect the quality of education in general. So for conclusion, the participant in general acknowledged the importance of public health profession and agreed that it's aligned with the Saudi 2030 vision. But there were emerging themes that that is concerned the public health practitioners, which is lack of the field practice, the limited facilities and resources provide to the public health students, and also lack of recognition from the Saudi Commission for Health Specialties. And there are a shortage of research finance and assistance. For that, we recommend that increase the practicum courses and community involvement, also provide the opportunities for research and access to national databases, also engaging the community with the program through partnership. Some of the students also recommend open summer courses for the students because all these programs established in a timeline that don't provide any summer courses. Also, collaboration with the public health and the public and private sectors for research purposes, and allocation of large budget for public health practice. For that, I'm done. Any questions?
Thank you, my dear North, for this great, amazing topic. If there is any question for Ms. North, please raise your hand or write it in the chat box before I will start my question for her. Let me check the chat box.
Should I end my sharing? Sharing
Yes,
screen?
yes,
Yeah.
please.
Okay. Okay.
Okay. Okay, it seems there is no question, so let's start with my questions. In your opinion, what's the advantage and disadvantage for the public health studies in Saudi Arabia? This is the first question. And the second question is, what's the relation between public health and the Saudi 2030 vision? I know that there is a digitalization in the healthcare industry in Saudi Arabia. So what's the relationship between public health and the Saudi 2030 vision?
Okay, I will start with the second question.
Okay.
The Saudi 2030 vision, it's, I can say it's like the basic of the Saudi 2030 vision is the public health goals achievement. They want to increase the life expectancy. They want to increase the quality of life. They want to provide the people with a decent life standards.
Yes.
And we cannot do that unless public health involvement and public health practitioners contribute in these goals. So all of the goals, all of the 2030 vision's goals is related, and it's like we cannot take the public health from the goals and the aims that they want to achieve. So it's like the basic for our 2030 vision, and that's why they increase the college and universities in many disciplines of public health practitioners. They want more public health practitioners. So they invest in the public health education. So I hope this is answer your question.
Yes.
Can you repeat the first question, please?
The first question is, what's the advantage and disadvantage of this specialists, or what's the future for the public health category?
It's the future for every aspect of life. You need public health in any institution. You need public health concept and practitioner to establish any program. Any strategy should involve public health practitioners. We have here in Ministry of Health, they all need public health practitioners to take the lead and to invest and practice their knowledge and adapt it to the reality. So it is very important profession.
A very required specialty.
Yes. And we cannot imagine the future without a public health practitioners. It's the future for health. And we want to prevent diseases before it's happening. So we are preventative strategies. We don't want to wait until the disease happened to cure it and to have this burden on the health system. So we want to be healthy all and spread health and the concept of healthy lifestyle among all. So
thank you very much for answering my question, and thank you very much for this lovely and interesting topic. I would like to ask you to still keep with us because our next speaker, Dr. Salwa Sulaiman, have an interesting and informative topic about simulation-based learning. Dr. Salwa, the speech is yours.
thank you, dear.
You're welcome. Please unmute your mic because we can't hear your voice. Yes, now we
Hello.
Can. Hi, my dear. The speech is the stage is yours.
Yeah, I'm Dr. Salwa. I'm a lecturer and skill lab instructor and coordinator at GU University. I'm so proud to participate in this distinguished conference. But I'm so sad to not be with you in this conference exactly or physically. But I wish to be with you in the next conference.
Hope so, my dear.
Yeah. My topic is it's a very, very important topic. I think that for every student, especially a medical and nursing student, my topic is simulation-based learning. Let me share my screen.
Yes, please.
Yeah. Okay.
Yes, please.
Okay. Did you saw it?
Yes, we can see your screen.
Okay.
You can start.
Okay. I'm talking about simulation. You know, the simulation, it's a very, very important for training to the student. What is the goal for this presentation? Number one, to encourage participants to make a critical analysis of information and receive concerning the disaster. Number two, to provide any opportunity to make decision on most of the problem associated with the emergency. And what is the objective for this presentation? Number one, place the participant in the pressure situation, and number two, offer an opportunity to participate in the teaching and learning process based on self-teaching approach. Exactly, I would like to talk about this topic because this topic is very, very important. I think that to every student, without simulation and without training, the student cannot be more expert or more satisfied to practice well before to deal with the exact patient or real situation. Real patient. What is the clinical competences? Competency-based learning. Any medical training program should ensure that Number one, the student has a necessary learning opportunity. Was that what I talked about before? What is the appropriate method for the clinical skills competences? Number one, communication skills. It's very important to the student to communicate well with the simulation and learn how to deal with the simulation as a patient before the student contact with the real situation or the real patient. I think this will decrease the error and the risks that can do for the patient. And number two, awareness of ethical basis of healthcare. Physical examination and procedural skills. All of this will be more efficient when the student contact with the simulation and train well with it, and then train with the practice this with the patient. Clinical approaches skills and diagnostic skills and therapeutic skills, all of this, resuscitation skills, all of this. And problem solving, team working, organization, all of this. What about of tradition acquisition of clinical skills? It was relying on appropriate style methods. When you deal with this, when you deal with this simulation, what is the tradition way? See one and do one and teach one. This appropriate style, this style learning is not efficient for the patient, for the student. It's not good to make the student learn well and train well, and then practice this with the patient. What happened in our recent healthcare system? Pressure of managed care has changed the form and frequency of hospitalization. High percentage of acutely ill patients. This has results in a fewer opportunity for the medical learner to access a wide variety of disease and physical finding. So concern evoked about patient safety and fewer availability, patient for learning, and many other factors have led to the introduction of the simulation and development of simulation center and clinical skills laboratories in nursing and medical education. What are the main purpose of healthcare simulation? It's not open for me. The main purpose for this simulation, I think that it's number one, education. When I train the student well in this simulation, and give them all the knowledge regarding the case scenarios and open this case scenarios for the patient, for the student. For example, when the student learn in the series, you should integrate series with the practice. So if the student take the lecture about the cardiovascular system and give him the scenarios regarding this regarding this heart patient or the diseases of this patient, And you should make scenarios or train the student on the real scenarios about the cardiac patient, and then open these scenarios like that. When you write it, even if you write it on the board, and then practice the student in this simulation as a tradition about this, all of this, and how to take this interpretation, how to interpret this data that he take it already in the lecture, and apply this data in the real or in the simulation as a real scenarios. I think that it's very important for education and training and assessment, how to assess the patient. If the student assess the patient really with as a real situation with a simulation, and then apply this after that with the real patient, I think it's excellent for the patient to enhance his communication skills and self-esteem and satisfaction, and decrease errors for the patient. All of this, and it's important for researchers. I think that it's very, very important for researchers. Health system integration that I talked before. Why simulation is important in nursing, especially in nursing. With realistic clinical scenarios, simulation-based educational intervention in nursing can train novice as well as experienced nurses, helping them to develop effective non-technical skills, practice rare emergency situation, and providing a variety of authentic life threatening situation that I talked before. What is a nursing simulation? When I start to talk simulation, what is the nursing simulation? The nursing simulation has been defined as an activity or event replicating clinical practice using scenarios like high fidelity mannequin, medium fidelity mannequin, and low fidelity mannequin, standardized patient role playing, skills station, and computer-based critical thinking simulation. What is high fidelity simulation? High fidelity simulation, it's more efficient and has a lot of advantages than traditional simulation. Traditional simulation, it's just when the student doing like that, when doing CPG, for example, this procedure, he will do it or she will do it in the patient to extract sampling from the patient. But when the student deal with this procedure before with the simulation in the simulation, and knows how to apply this procedure step by step, and train well in the simulation before he contact with the real patient, he will not make any error. Or when the student deal with this patient, he will communicate with this patient very well, because he is more confident, and he has experience to do this procedure. All of this procedure, he can do it like that. High fidelity procedure is quickly becoming essential for all nursing and medical schools. What is the example for this high fidelity simulator? Like SimMan, everyone, I think SimMan. It's a high fidelity mannequin, 3G essential ALS, offer learners a risk-free way to build team performance and enhance individual skills in airway, breathing, cardiac, and circulation management. In my talk before, when I talk before about Alex, I think I talk about digitalization in the first conference that I present Alex. Alex is the first patient to communication mannequin can make all of this like Thin Man. And this picture about more or high fidelity mannequin. Second one, immersive simulation experience with virtual patient like body interact. I show you many picture. Number one, pre-hospitalized scenario like this. It's like a hospital that make a surrounding or he will build the surrounding area or the environment like the hospital before the ambulance come. When this I think this situation can happen in anywhere when someone make an accident or has any problem in the way or in the street and ask for helping like CPR, like accidents, like and so on. So this is the environment we can build this in the hospital, in the labs, to train the student how to deal with this situation in the real situation, to train the student how to deal with this. Number two, emergency room from basic to actual clinical condition. This room will train the student regarding a critically procedure like tracheostomy caring, tracheostomy insertion, like any invasive procedure, he can deal with this. Number three, the third picture, consultation, long-term patient care management or after an emergency. I think this picture will make the student more efficient and more expert regarding this advanced procedure. Virtual simulation. How to know what is the definition or what is the definition of virtual simulation? It's a category of a simulation that uses simulation equipment to create a simulated world for the user. Virtual simulation allows users to interact with a virtual world. Exactly, virtual world operate on a platform of integrated software and hardware component. This virtual simulation is very, very important. I think that, and the student learn how to deal with this simulation in the coronavirus. I think it's a solve many problem regarding this situation. What is the definition for this virtual simulation or virtual reality? Is a recreation of reality. This is a second definition. A reality depicted on a computer screen. When participating in virtual simulation, learner experiences simulated clinical scenarios from a computer screen while often using a mouse or keyboard or to interact with the environment. Like body interact, he will interact with this screen like he interacts with the reality. Even when the student, I will give the example for this. When the student want to check the vital signs for the patient or train regarding the procedure, specific procedure like blood pressure measurement. Just the pressure, the student, when I show you this picture, when the student, you see in this picture, the student interact with the environment, with the screen, like the reality. When the student want to check the blood pressure, just press or pulse, apical pulse, just press on in this site in the heart, and the screen will show him uh, how to measure it, or he will give they will give them it will give them the result. So the student will train regarding this way, a virtual simulation. Every procedure he can deal with like this. Even the radiologist, when he needs to show X-ray, or to see the X-ray for the patient, he will see it in this screen. So what is the difference between virtual reality and virtual simulation? Difference between a virtual reality and virtual simulation is a computer. I talk about this. Virtual reality is a computer simulation, means not to be interactive, just interact with the environment. Usually, virtual simulation will determine a number of parameters. When I asked before, when I discussed this before, number of parameters at the beginning of simulator, and then run and simulation without any intervention. What about virtual reality and education? Virtual reality will help and enhance learners by allowing students to interact with their lesson. So they will be more expert and satisfied enough, and has self-esteem, increased self-esteem for them. In different way, instead of just reading about a subject, students are able to see the things they are learned, and helping students understanding complex topic by example that I talked about before. These studies actually this studies the clinical virtual simulation in nursing education. This is the studies randomized controlled trial. This published 2019 in March. This study aimed to evaluate effect of clinical virtual simulation with regard to knowledge retention and clinical reasoning and self-efficacy and satisfaction with the learning experience among nursing students. What is the method for these studies? Randomized that I took. Two post test was carried out with nursing student. It's around 42 nursing students. What is the result for these studies? These studies show us improve in knowledge and virtual simulation that improve in knowledge retention and clinical reasoning in an initial stage, and over time it increases the satisfaction with the learnings that I took it like that. satisfaction will increase with the learning experience among nursing students. So what is the question? So the question is, what is the impact of virtual reality simulation on patient safety? Number one, it will be more efficient to help the student to identify the correct patient. When I learn as a student how to deal with the simulation as a patient, from A to toy, head to toy, head to toe, sorry. So the student will know every step from 1 to 10. From one, how to identify a correct patient from name and the date of birth, like that. All of us, I think, know this. Number two, improving effective communication. When the student deal with this mannequin like a patient, and do this procedure according to the checklist, step by step, more efficient, and try many times regarding these issues or regarding these mistakes, and do it one and more, and correct. And I think this way will improve the communication skills for the student. Number three, improving the safety of high alert medication. I will not talk more regarding these issues because I know everyone knows this point enough. But I will highlight in one issue. Virtual reality simulation improve nursing student when IV drug infusion skills. It's very, very important to learn the student how to know how to make the steps for IV medication, all of this medication administration, how to deal with the patient regarding this issue. Number four, ensuring correct site, correct procedure, correct patient surgery. And number five, reducing the risk that I talk, risk for infection, risk for error, risk for infection are the most common cause of death in hospital. And hands and skin hygiene before each intervention break the chain of infection. That everyone knows this. Virtual reality simulation can be used to help nurses develop positive attitude toward hygiene, and this result in a reduction rate of infection and hand washing, and how to deal with the patient before doing hand washing and after doing hand washing, and how to do this procedure more efficient and train well regarding this issue also to prevent the spread of infection. And last one, reducing the risk of patient harm resulting from fall. Nurses are responsible for providing safe care, and which is an indicator of the quality of care. Making sure the paid breaks are logged when the student train in this issue, regarding this issue, how to log this, how to deal with the patient, what is the preparation for the patient before any procedure, and what is the preparation for himself, and what is the preparation for the medication, and knows everyone and train well in front of the instructor by this equipment was by simulation or virtual simulation anyway, and more and train more enough. I think he will not make this mistake in front of the real patient. That's it, and thank you. Any question?
Thank you very much, Dr. Silva, for your great and informative topic. Really, I like your presentation. If there is any question or comment, just raise your hand or write it in the chat box. So let's start with my two quick questions. The first question is, in your opinion, what's the benefits of the simulation training in healthcare? And the second question, what is the purpose for simulation in healthcare?
Thank you for your question. It's a very, very important question. Number one, the simulation, it's very, very important to the nurses and healthcare workers. I think that for not nursing student, but also all medical students. You know, in my center, clinical or training center, I train every student, even the student medical student or nursing student regarding this simulation. When the student learn how to deal with this simulation regarding every procedure, regarding the program that he should knows every point or procedure according to the checklist, and apply all this step in front of the instructor to correct every mistake before the student deal with the real patient. I think this is a very, very important and will enhance self-esteem for the student and satisfaction and good communication skills and decrease errors, all of this. What is the second question?
What's the purpose?
Purpose of simulation?
Yes.
I think it's the same. The purpose, it's
the benefits.
To enhance the student, to make the student more efficient and more expert regarding every procedure, regarding every technique, or to apply what he take it in the theory in the practice, to integrate theory with practice.
Thank you, my dear, for your great topics and for you answering my questions. I would like to ask you to keep staying with us because our great speakers will continuing their presentation. Thank you and have a wonderful night.
Arigatou gozaimasu.
Thank you. So let's move in a hurry to our next speaker is Dr. Mahdi Javanapaket. I think if I say it wrong, so I'm so sorry. From UK, I'm passing him the stage to deliver the speech on online platform for health economics evaluation, a way to provide a strong infrastructure to inform decision-making process in health sector. Dr. Mahdi, the stage is yours.
Thank you very much. Can you hear me okay?
Yes, we can hear you.
Okay, brilliant. All right, yes, thank you. It's a great pleasure to be here. And yeah, I enjoyed listening to some of the presentations. So today I will be talking about an online platform for health economics evaluation. So my name is Mehdi Javanbakht. I'm a health economist by training. I have done my bachelor degree in healthcare management and then master and PhD in health economics over about 10 years ago. And yeah, I have been working in the health technology assessment field here in the UK for about 10 years. I used to work as a senior research scientist at Newcastle University and University of Aberdeen. And also as a part of my role, I was collaborating and helping National Institute for Care and Health Excellence, or which is also called NICE, here in the UK, to evaluate different medical technologies. So today I will be talking kind of, how in the past years, how my experience led me to basically to develop this platform within our company and private research institute. So if we look at the current situation, the healthcare costs have been growing rapidly in the last, or in the, let's say, past 4 decades. And that has created a lots of concerns to the healthcare providers, to the healthcare insurance companies and governments. And at the same time, we have lots of technologies that being developed and introduced to the healthcare system, but their impact on the population health and the healthcare resource use is really unclear. So that is the challenge that we have. And at the same time, also, if we look at the burden of disease studies results, as you know, all probably know, we are moving from more communicable disease to non-communicable disease. So the burden or the proportion of burden of disease due to non-communicable disease has been growing in the last few decades, because we have been able to control some of the communicable disease, but non-communicable disease has become more and more popular and more prevalent due to lifestyle change, aging population, and many other reasons. And as you can see here, ischemic heart disease, for example, is one of the, and basically in general cardiovascular disease, imposing a great burden in terms of premature mortality and disability to the health of a population. And the share of non-communicable disease is going to be even more in lower and middle income countries. I just want to look at because that was a proportion. So proportion of basically cardiovascular disease out of all the other diseases in terms of the overall burden. But I just want to understand also whether the absolute burden of these diseases has also reduced or increased over time. So if you look at the cardiovascular disease, as you can see in the last 3 decades, the burden on per 100,000 population in terms of deaths or in terms of disability adjusted life years is almost constant. So that's kind of raised an alarm that, despite all many advancement in medical technologies and all the monies that we have been investing, we have not been able really to control the diseases for many reasons, including not using the effective intervention probably, or not cost-effective interventions. So that is something that needs to be addressed by using a proper kind of approach. Also, if we look at the healthcare finance data, as you can see in most of the countries, especially in African, Asian, and South American countries, there is a limited and evidence about the healthcare finance or national health accounts reports, which is one of the other reasons that we are not documenting them properly, so that we can understand where the monies are spent, how we can reallocate them to be more efficient and to basically improve the population health by efficiently allocating them and increasing the life expectancy. And like we discussed, we are seeing lots of technologies. In the last 10 years, I have been working with over thousands of medical device companies that they are willing to come to the UK market. I speak to them, at least 5 of them each day, in different diseases area, and they produce different types of technologies. They have some claims about the benefits of their technologies and products to the patients and to the healthcare system, but most of the times they don't have the evidence to support their claims. And that's why we need to have a proper kind of system to filter and only adapt the technologies that we can ensure that they have a benefit to the patients and to the healthcare system. To solve this problem, there is a concept called health technology assessment. Probably most of you know, you're familiar with this concept. So the health technology assessment, or HTA, is a systematic approach to evaluate the different properties of new technologies, including medicine and medical technologies and digital solution, to understand their impact, or direct and indirect impact and consequences to the patient's life and to the healthcare system. So it is a transparent and accountable process to help the decision maker to only adapt the most effective and cost effectiveness technologies. However, this HTA kind of process are being used in many developed countries, including UK, US, Canada, Australia, and several other Asian countries as well. But in other countries, it is still growing, and there are some challenges, mainly due to limited health resource or health economics, let's say, capacity in those countries, because health economics is already a new field of study, not relatively new because it's about 40 years old kind of field of study, let's say. And also there are other challenges as well, including, for example, even in some countries, for example, in the Middle East, we have, let's say, a problem, let's say cardiovascular, with different people or from universities, from other sectors. They develop different models, which they use different methodology and the different data, and that create inconsistency in terms of the overall conclusions that need to be made in terms of policy making for management of different diseases. And not having a proper, let's say, HTA structure or HTA tool could basically lead to neglecting and basically losing the opportunity of some relatively inexpensive intervention that could have a huge potential impact on the population health, and also saving the expenditure on the healthcare, or basically improving the efficient resource allocation in health sector. And also without having a proper comprehensive tool, it may lead to inconsistency in assessing the new technologies for adaptation. So this is the situation. And within the Optimex access, we have developed a comprehensive tool for health economic evaluation. This is the unique tool in the world, in a sense that it enables the users to basically have a platform, an online tool that can basically build all the health economics model for different diseases and or group of diseases, and use them to evaluate the effectiveness and cost effectiveness of different interventions. Our approach, mainly, especially for the countries with limited, let's say, HTA structure or capacity, is to start with evaluating the current burden of disease based on the global burden of disease study, but at the same time looking at the local data to understand to refine the estimates from the global studies, like global burden of disease study, and to ensure that we can basically use all the available data, including death registry and all the rest, to identify the diseases or group of diseases with the highest burden on the society, so that we can start with those diseases, because the aim is how we can identify the really key diseases that are imposing the highest burden and reducing the life expectancy in the countries. And if we look at the as you saw in the first one of the first pictures, cardiovascular disease is one of the leading kind of group of disease with the highest burden. So that's why I have brought it here as an example that, imagine we develop a cardiovascular disease policy model, which is a health economics model that simulate the natural progression of the disease, but at the same time, the care pathway as well, using national level data. It is based on simulation, very well accepted methodology around the world to understand the effectiveness of the different diseases, using data from the literature, and also synthesizing the evidence, including clinical and non-clinical data. So this is a kind of, a kind of model. Imagine, for example, for cardiovascular. Different organizations, including WHO, they are proposing different interventions that are deemed to be the most cost-effective or effective interventions. However, they may not be as effective as they were or WHO is expecting in certain countries because of the difference in culture and the context. That's why all countries, they need to have a proper model to investigate the effectiveness of different interventions before investing lots of money and implementing them. Otherwise, we will end up with the situation as we saw in one of the pictures, that the burden of the cardiovascular disease has not reduced per 100,000 patients in the last 3 decades, which is a very sad news. So within the model development, this is something that we have been doing in the last 2 decades, and with over 150 health economics model that we have developed. So the model's development has a process. It has to be validated by clinical people, and it has to be as user-friendly as possible. It has to also follow all the good practice within the health technology assessment and health economic evaluation models, with all the user friendliness and self-explanatory features, which is all we have considered in our platform, and which is also able to quantify the uncertainty, and internally and externally is validated. Once the models are developed for different diseases, we can always add new interventions or new technologies to the same model, which has lots of benefits, because all the new technologies will be assessed by one single model, which will increase the coherency and the consistency of evaluation. And this is how we can ensure that we can optimize the management of different diseases. So it has an architecture, the model. There is a core part which is related to the actual modeling, and then there are some codings related to the web interface with a very user-friendly dashboards, where the user can easily explore different scenarios, play with the input parameters. The model will be also linked to the national and local databases, and each time when, for example, the cost data or drug tariff data or procedure tariff data is get updated, the model will be also updated as well. This is just to ensure that this is a long-term plan to have these kind of models that are being used for, or to be used for any policy making in for any diseases. So the platform is look like this. We are going to see the platform live in a second, but the platform can, in the platform you will have the for different diseases, diabetes, obesity, cardiovascular, different types of cancers. The idea, like I said, is to ensure that all diseases, there would be a model for them, and any interventions or any new technologies will be assessed first before implementing. So I'm going to just go, we are going to, let me just, I think I need to reshare because I didn't share my entire screen. Okay, can you see my screen again?
Yes, we can see it.
Okay, brilliant. All right, so yes, if you go to our website and then on our product side, you will see the platform or the tool, which is you can log in as a guest, and you can basically enjoy the kind of all the features in the tool. This is like a demo. I'm just now waiting for the website to load, but once it is loaded, it will take you, by clicking on here, it will take you to the actual tool kind of portal. Yes, like this. And then you can easily log in as a guest and see how you can use it in your healthcare system. As a researcher and as a scientist in the healthcare sector, this kind of tools could be used, and this kind of models could be developed for any types of interventions or even for educational purposes, because the idea is how we can synthesize the evidence to identify the most effective approach in any situation. So this is the actual platform or the online tool, let's say. This is just a demo for trastuzumab for breast cancer. There is a section for kind of explaining the purpose of the model and also the result part where you can, as a user, this is the, as a person that I've been working here for over 2 decades now, it is unique kind of tool because it will give the users complete flexibility in terms of playing with all the input parameters that are being used or are used in the model. And you can play with all the inputs here. You can change them, do some exploratory analysis and see the outcomes. For example, if we are talking about breast cancer, what would be the outcome for different strategies? And what if, for example, you change the overall survival or progression-free survival and all the different clinical and non-clinical inputs that we have basically used within this model. And this would be the case for other diseases, of course, as well. So going back to my presentation, because this is we believe this is the way forward. In the near future, all countries will have to have such a system, like I said, because of the high pressure of the healthcare cost and the need for having a tool that can be used to identify the most effective interventions. But at the same time, we have anticipated lots of training workshops and short courses related to this topic to enhance and to improve the capacity and human resource capacity in different countries to use the platform once it is installed in each country, and to ensure that researcher and experts and policymakers will be able to effectively interact with the tool and use it for policy making. So Optimax, in terms of our credibility, Optimax is part of Aegis Life Science Group, which is a over 40 years old private research institute based in Berlin. With over 200 scientists, we have done over 2,000 research projects, and we are one of the largest government partner in Berlin. And Optimax is the kind of health economics engine for the entire Aegis Life Science Group. We have offices in multiple countries, including UK, and have an experience of working with the health technology assessment bodies in the UK, in Germany, in France, and in Switzerland and the Netherlands as well. So we can basically offer our support to entire world. And like I said, within the Optimax, we have over 150 economic models that we have developed, and we have published over 130 papers in peer-reviewed journals, which is something that we are quite used to developing this kind of models and doing this kind of scientific researchers to help the policymakers. Thank you very much.
Thank you, Dr. Mehdi, for this great and amazing speech. If there is any question or comments for Dr. Mehdi, the stage is yours. Just raise your hand or write your comments in the chat box. Okay, it seems there is no question. I have one quick question for you. Dr. Mehdi, what was the purpose for running this kind of platforms as a business?
I mean, like I said, I used to be a kind of, research scientist at Newcastle University and other universities as well. And I was kind of seeing that people develop different types of health economics model, and they use different methodology, they use different data sources, and they come to the different conclusions, right? Yes. That's why I thought, okay, that will create lots of inconsistency in terms of adapting new interventions and new medical technologies. That's why we need a comprehensive tool that is based on the national level data, which will create lots of consistency and coherency when you are evaluating different interventions, and it can be updated over time, and all the people will get access to 24/7 to the most latest up-to-date version of health economic tool that can be used by different parties within a country to evaluate different interventions.
Thank you, Doctor, for this great, amazing speech, and for this platform. Wish you all the best. I would like to ask you to keep with us, because our last three speakers have a great, amazing topics. So before we will move to our next speaker, let me introduce her. Our next speaker will be Dr. Irena Mekronik from Ukraine, but regarding they are facing war and the problems in Ukraine, we will present instead of her. But let me briefly introduce Dr. Irena. She is a PA holding a PhD, member of the board of the European Gravier Association, president of the Flexible Packaging Association of Ukraine, and representative of the Save Food Initiative UN in Ukraine, member of the supervisory board of the Jewish Confederation of Ukraine, board member of Kyiv City Federation of Employers of Ukraine, board member of the Ukraine League of Industrial and Entrepreneur Advisory Board member, White Ribbon Ukraine, include in the list of 100 business ambassadors of the Ukraine, 100 most influential women of Ukraine, and it is in the top 100 most of successful women of Ukraine. We wish her a safe trip, and give me 1 second. I will present her speech. So Dr. Irena presentation is about Ukraine women in business, and let's start her presentation. Next, please. Okay, resilience and bravery agenda, Russian military aggression and humanitarian problems, women in business at in February 24, 2022, the day of that changed our world map of the war. So don't forget this day. And economic change after start of Russian aggression, women and their role in the war, the future of Ukraine, Russia is a terrorist state or not, what can we do? Next, please. Russian military aggression and humanitarian problems. Ukrainian women in business. In 2021, Control conducted a study according to which an Ukrainian woman owned 3% of companies with the highest income. Out of 330 companies, only 111 are owned by women. In 24 companies, women are co-owners, and the biggest problems are the double burden and gender stereotype. So in the same day, February 24, 2022, the beginning of the war in Ukraine, Russia is a terrorist state. And this number is exploring the starting of the war. Next, please. So, Children of the World, government portal of children search data from children victims as of 17 November 2022 till the beginning of this week. 431 died and 835 is injured. And 130 is found. Russian nuclear tourism in Ukraine, 2 out of 4 operating nuclear power plants and 1 shutdown plant become victims of the Russian invasion. And this graph is showing what is mentioned in the title. Oncologist Oksana died due to rocket fire on the capital of Ukraine in the October 10, 2022, in the midst of the crowded Kiev during a massive Russian attack. Oksana died, a loving mother who that day took her 5-year-old son to the garden and hurried to work to save the lives of the children. She worked as an oncologist in the Department of Bone Marrow Transplantation. 6 months ago, the boy's father died. Russia took away everything from little Grisha: childhood, maternal affection, loving family. Now his grandparents will take care of him. How many more doctors, teachers, civilians, and the children's our warriors must die for the whole world to rise up and be able to defend itself from this invasion of Putin? Next, please. How many medical workers dies of 1st of August? So this data is dated, updated till August 2022. So since the beginning of Russia's full-scale invasion of Ukraine, 18 doctors have died and about 60 more have been injured. 884 health facilities were damaged. 123 were completely destroyed. In addition, the Russian military destroyed 87 ambulance and seized 241. Access to healthcare in Ukraine after 8 months of the war. The healthcare system remains stable, but key health services and medicines are becoming less accessible. Every third adult Ukrainian interviewed needed primary medical care help. 1 of 2 respondents reported at least 1 barrier to accessing any level of healthcare, with cost being the most common reason. Every 5th Ukraine couldn't get the necessary medicines. Cost, lack of necessary medicines, and long queues at local pharmacies are the 3 main reasons. So cost, lack of necessary medicine, and long queues at local pharmacists are the 3 main reasons. Those living in temporarily occupied terrorist area of active hostilities tend to seek health services less often than residents of other regions, while internally displaced persons seek service significantly more than the general population. So, Lviv surgeons perform heart surgery without atrial hemorrhage. Mental health needs of Ukraine refugees. An estimated 1 in 5 people will have a mental health condition in the next 10 years. 1 in 10 will have a severe condition like post-traumatic stress disorder or physio choices. Now, the focus needed to be on addressing mental health, particularly for the young mothers and the children who have to flee knowing that their household and husbands and fathers are still in Ukraine fighting. Refugees fleeing Ukraine. Over 7 million refugees have fled to neighboring countries and beyond. Millions more are displaced within the country's border. 1 in 10 will have a severe condition like post-traumatic stress disorders or physio choices. Now the focus needed to be on addressing mental health, particularly for the young mothers and the children who have to flee knowing that their husbands and fathers are still in Ukraine fighting. 268 days of war in Ukraine from February 24 till November 18. And here is the updated data till November 17 at 11 p.m. Next, please. Sure. Poverty in Ukraine will increase. Every fifth Ukraine will live on the verge of poverty. Unemployment reached a third of the population according to positive scenarios. The World Bank says that 40% of people lost their jobs after February 24, and half of those with jobs experience a reduction in income as of August, as for the source. So 817,000 residential buildings were damaged or destroyed. 44 million square meters of housing were destroyed. 38% of housing cannot be restored, and $69 million is needed to restore the housing stock. 1 to 4 of Ukrainians were forced to leave their place of residence. $73 billion diminuting, $73 billion restoration of transport infrastructure, $18.7 billion restoration of the agriculture sector, 37% fall in GDP, and $349 billion is needed to restore Ukraine. 87,000 people killed only in Marpel, 2 populations of Monaco, 2 population of Liechtenstein, demolishing away the entire population of the Isle of Man. It's impossible to think that war is a purely male-affected. Women throughout the history of mankind bear the burden of military conflicts more than men. In 2000, the UN adopted resolution 1325 on the disappropriateness impact of military conflict on girls and women, while recognizing their huge role in building peace. Women practice in military conflicts on both sides of the front line, only they feel the war itself and its consequences differently from men because of gender issues. So Alexandra, Director General of the Medical Service Directorate of the Ministry of Health of Ukraine, said that according to the calculation of the Ministry of Health in the post-war period, more than 15.7 million Ukrainians will have psychological problems and 3.5 million people will need therapy and support from medical specialties, psychiatrists, and about 800,000 Ukrainians will need medication support. So prisons in Ukraine, 4.7 million prisoners received pensions of less than 3,000. It's with the Ukrainian currency, it's around $82. In the first half of 2022, the average pension increased by 17% in the local currency and by 10% in dollar terms. 4,437 the Ukrainian currency, it seems, or $152 compared to the corresponding period last year. However, after the change in the national currency rate in July 2022, the average pension is $121. Number of prisoners receiving payment of less than $82 decreased from 54% in 2021 to 43% in 2022. Instead, the percentage of prisoners who receive more than $273 has increased up to 6.5% in 2022. So 18.5% of prisoners receive from $137 to $273 compared to 13.5% in the first half of the last year. The number of prisoners decreased by almost 200,000 over the course of the year. The pace of reduction has slowed somewhat if the number of prisoners decreased by 1.5% in the first half of 2021, then by 0.6% in the corresponding period of 2022. In total, as of July, 10.78 million prisoners were registered in Ukraine. Today's situation, unfortunately, Russia continues to launch missile strikes against the civilian critical infrastructure of Ukraine, fighting against the civilian population and depriving them of light, water, heat, and communications during the winter, the Prime Minister said. According to the head of the government, only on November 15, Russia fired about 100 missiles at Ukraine's city. Almost half of our energy system is out of order. The Prime Minister of Ukraine noted that Russia disabled almost 50% of Ukraine's energy system with missile strike. So Russia invaded in Ukraine. Why this matter is important to the world? According to the official website, 268 days, 8 years long Russian occupation of Crimea and parts of Donbass. Next, please. Yes. Must see all of these 8 documentary about the full-scale invasion. If anyone wants to know more about this topic, just click in any of these 8 documentary, Lost House, Next, Unlost Hope, and etc. Next, please. So, results of the National Survey on Vulnerable Population Needs. So, this research agency commissioned by the USAID Economic Resilience Activity conducted a telephone survey in different regions of Ukraine in August 2022. A total of 1,000 women and men aged between 16 to 60 were asked. So these are the targeted area and the targeted group age from 16 to 60 were asked about access to the internet, jobs, gender-based violence, and business prospects during the war. Almost half to 45% of people responded that they don't have access to the internet or a computer and can't study or work online. 1 in 5 respondents is forced to save on gorgeous or borrow to buy something other than food, telephone, or furniture. A total of 39% of people belong to at least one vulnerable group: internally displaced persons, people with disabilities, single parents, veterans, and those who have lost their job since February 24. The share of people for whom work is the main source of income decreased from 60% to 48%. So every third respondent wants to start a career in another sector, IT or marketing. Almost half would like to start a business but have not taken any steps to do so. So these data will explaining more about what was mentioned in the previous slides. 45% of the population of Ukraine don't have access to a computer or the internet to work or study. 39% of the population belong to at least one vulnerable group. 36% want to start a career in another sector. IT and marketing are among the leaders. 46% would like to have their own business, but most of them have not yet taken any action. and 13% of the population have experienced or witnessed gender-based or domestic in the last 5 months, and almost half of them didn't appeal to state authorities for protection and support. The protection of people for women as the main sources of the income was decreased. Next, please. So, change of the Ukraine's economy after the start of the war. This data shows the export structure 90 to 95% during 2021, between 2021 to 2022. Next, please. Here, import structure by goods types in 2021, 2022, consumer goods, energy resource, raw materials, and equipment. And there is a difference between all of these sources. Real and potential GDP at 2026 constant prices, potential GDP and real GDP, and there is a difference between both of the concepts. Business expectations trend according to Adventure Group. So 39.9% approximately 40% entities stopped fully or partially their production. 11.5 approximately 12% haven't changed production volume or increased them since February 23. Okay, average salary in Ukraine trend in 2022 in accordance to the USD dollar average annual growth plus 30% in the local currency and in dollar equivalent to 19.5%, less than this number. So the best inventions of 2022, the bionic arm. It's noted that the development of Esper Bionics is the first prosthetic robot based on artificial intelligence. 24 wearable sensors detect and process muscles activity and brain impulses. In the process of machine learning, the hand will and begin to act more individually. The first similar bionic prosthesis was installed to the Ukraine Defender in March near Rizim in the Kravik region. He blew himself up on a mine when he tried to get his brothers out of a freight armed personal carriers. So body is not a limit, the first prosthesis that improves and gains abilities over time. Women and their role in the war. So Ukrainian women from the first day of the war stood up to defend their children and their homeland. Therefore, there are now more than 50,000 female servicemen in the ranks of the armed force of Ukraine, of which about 5,000 are serving on the front line. Wow, huge number. All women's human rights organizations work as volunteers. So here is their projects for support, social advocacy, and gender education seminar, training involving men, representative of government agencies, public organization, and the media, informational events aimed at raising awareness and increasing understanding of all forms of violence among the cities of our country to overcome domestic violence, gender education through animated video educational cartoons on gender topics. For the social, creating a mobile app and online platform for emergency care in case of domestic violence, creating an interactive map of specialized shelters for the victims of domestic violence, conducting state advocacy and other events in the period from November 25 to December 10 during the global initiative 16 Days Against Violence. For the advocacy action, advocacy through art events, shooting social videos, and short motivational videos about the issue of domestic violence in Ukraine, development of the 2013 new equality policy of Ukraine, Ukraine's accession to the reform of the huge Convention on Domestic Violence, introducing at the state level in Ukraine on November 25 as the day for the elimination of violence against women and girls. For the expert advice, participation in interdepartmental groups, promoting gender education at all levels, cooperation with all gender policy stakeholders in Ukraine. Assisting Ukraine during the war, advocating for sanitation against pro-Russian celebration opinion leaders, athletes, etc., psychosocial rehabilitation, adoption, suicide prevention, NGOs list for women, refugees support in the world, children's camp for migrant children, setting up assistance, fundraising, work and recognition and psychological rehabilitation program, social media project of Ukraine, and the blood donation service in Ukraine. Next, please. So, investigation process against a human trafficking group, joint project with NGO assisting refugee from Ukraine, organization of financial assistance of evacuation from Moperian, I think, the safety drape window technology for regional parental center, media collaboration with Ukrainian online news, assisting communication group for networking between the world community and Ukrainian governors, volunteers, NGO hospital for urgent needs. Next. The future of Ukraine after the war. Next slide. So here is the graph shows the new age Ukraine agriculture in accordance to the recovery plan for core national principle, institutional effects, national security, role of law, public governance, digitalization for society, education, cultural and support, healthcare, social protection for the infrastructure, business infrastructure, living infrastructure, transport and logistic, social infrastructure for the Europe integration commitment, Copenhagen criteria fulfillment, European market expansion, Green Deal. Also, for the economy, macro financial stability, value-adding sectors, economic freedom, access to finance markets. For the environment, green energy and economy, sustainability, waste management, and biodiversity. These are the attractive business environments in accordance to the recovery and plan. First, active governmental support, then strong international cooperation, then stable access to finance. So, in the economy concept, the vision for that, Ukraine will be a developed digital economy oriented on high value added sectors with effective infrastructure, efficient finance and banking sector, and an attractive business climate. For the concept of society, economy, and environment, they will updated to be a digital transformation, equal and inclusive society, European integration, sustainable and resilient economy, green transition, clean and safe environment. This will lead to new age of Ukraine. Next, please. So what can we do? Next. So Putin can't and is not ready to retreat from Ukraine. This will be the most shameful thing for Russia. He is not ready to give up the idea of occupying Ukraine. For this, he is ready to kill hundreds of thousands of Russian men and the front. As part of the mobilization, it's planned to call up 300,000 people. He's ready to call on Russians by the millions. Partial mobilization in the Russian Federation is a sign of Putin's weakness and inability to change the situation at the front in favor of Russia. So this is a signal to Western countries about a permanent Russian threat that needs to be stopped and destroyed in Ukraine. This war touched upon the question of existential existence of the civilians world. If Putin wins, it will mean the essential disappearance of the West and vice versa. So thank you for attention and wish them all the best and all the luck. And we wish you have a safe trip and have safe stay, Dr. Irena. So let's move quickly to our next speaker will be Dr. Nuha Filfan from KSA. I'm passing her the stage to deliver her speech on virtual reality and patient safety, application in public health, and literature review. Dr. Nuha, the stage is yours.
Hello.
Hello, Dr. Nuha.
Yes, I don't see myself. I'm not sure why.
It's look like it's a black screen.
Yeah, I don't know what's the problem with my video, but
you can already share your screen if you want.
Yeah, how can I share?
Okay, you can press the green icon.
Okay, I can see share my screen. Okay.
Yes, perfect.
All right. Hello, everyone. Thank you very much for inviting me to this lovely conference, and I'm glad to be part of the esteemed cohort of presenters. I wish that I could be there in person, but at least I can present for now. Probably next year I'll be there physically. My topic will be about the use of virtual reality, application of virtual reality as a patient safety measure in public health. And this is a literature review that I did this year. A little bit about me. I'm a graduate of the College of Medicine at Al Qura University in Saudi Arabia. I did my public health and preventive medicine training at the University of Calgary in Canada. I'm currently in Saudi Arabia. I'm a faculty and I'm a head of preventive medicine and infection prevention control departments. What led me to think about this was a personal experience, actually, as a trainee, resident, I mean. I didn't have that much exposure in my field of training because in public health, it's very diverse and we don't see a lot of the situations that we're supposed to know how to handle because such as, for example, COVID. COVID doesn't happen commonly, and we know about it in theory, but in practice, we do not practice a lot in that situation a lot because it's not available. So I felt like I need to have something as a simulation. And because virtual reality is very popular nowadays and it seems promising, that's why I thought about this. And so I did my literature review to see if it's feasible to do it or not. So in this presentation, I'm going to talk about the relationship or the relationship between simulation and patient safety. Also, how do we apply simulation in healthcare, and how virtual reality can be useful for patient safety, and also the gap in virtual reality application in healthcare. Also, later on, I'm going to talk about the applications of virtual reality in public health, some examples of those, and a couple of take-home messages. I'm sure that most of you know these definitions. Just to review them. So simulation is to substitute or enhance real experiences with guided ones, with guided experiences that mimic the substantial aspects of real world in an immersive and interactive way. And also the definition of patient safety is an emerging healthcare discipline that aims to prevent and reduce risks, errors, and harm that occur to patients during the provision of healthcare. So how are these two definitions or concepts related to each other? So the vision of future healthcare revolution is to have systems of healthcare that are optimized for safety, quality, and efficiency. But how do we achieve that? Unfortunately, healthcare systems worldwide, they have concerns about how personnel in general are educated, trained, and sustained for providing safe clinical care. These concerns are a few. One of them is that the personnel have basic science education, right? And then they do have that, and in the end, that leaves most clinical training to a relatively unsystematic apprenticeship process. So it's a little bit unorganized after they graduate. And also there's an emphasis on individual knowledge and skills rather than honing their performance of the clinical teams. Another problem is once a clinician has completed their training, the required level of continuing education and training is often minimal, or if it's available, it's unstructured. So how do we ensure that medical professionals have those skills maintained, or first of all, established, and then later on maintained well to ensure the safety of patients in the healthcare system? Here comes the simulation. So because of that, because we want to assure the patient safety in the healthcare system, there should be a continual systematic training, rehearsal, performance assessment, and refinement in the healthcare practice. Something similar to what aviation professionals go through. So they do not graduate until they pass the simulation exam. And also, even after they graduate, even though they fly their planes regularly, they still go through reassessment periods that they have to go to do these simulation practices just to ensure that they are managing their skills well. So evidence, there's a good evidence that first simulation improves the provider and team self-efficacy and competence when we practice on mannequins. Another evidence is about procedural simulation that improves actual operational performance in clinical settings. Okay. For applications, this article or this study have categorized the simulation in healthcare into multiple dimensions. There are many of them, but what I'm concerned about is like one of them is aims and purposes of the simulation activity. The other one is healthcare domain. So simulation in different healthcare domains have different uses, different applicabilities, and different purposes. These are the healthcare system. It also depends on the type of knowledge, because like training students is not the same as training well-established clinicians or nurses. The type of simulation will be different. Also, when we use it on patients for treatment, also the simulation depends on the age. If they're kids, it's going to be different. If they're in the geriatric population, it's going to be different. So these are all consideration to what simulation could be used for. Also, the site of simulation, is it virtual? Is it physical? And the method and feedback used as well. Okay. So back to the topic that I'm interested in is virtual reality. Just to go through the basic definition, it's defined in in multiple ways. The ones that I feel are close to what I'm looking for are virtual reality is a computer-generated world in a three-dimension that can be explored interactively through a variety of computer peripheral devices. Another definition is the use of headsets displaying a particular environment to simulate a user's physical existence in a virtual or imaginary setting. So what are the applications and how are they relevant to patient safety? So virtual reality is used in both multimedia. They vary, like according to multimedia sophistication, it could be like purely virtual reality, it could be a mix. Even the content of the virtual reality program could be different, and also varies depending on the types of skills educated. So it could be surgical skills, could be behavioral, strategic thinking. So depends on multiple factors. The applications are ranging from telesurgical applications, interactive simulations of human body and brain. For example, for students, we can have, instead of having like an anatomy lab, we can have a virtual anatomy of the human body. Also, virtual worlds for emergency medicine training and cognitive behavioral therapy for mental disorders treatment, such as anxiety and PTSD. Other applications, medical therapy, preventive medicine, visualization of databases, etc. So this actually was last week. It was I attended a Saudi health simulation conference, and this was one of the booths where I tried their mixed reality device. So as you can see here, I'm wearing the goggles, but I still can see the environment. I'm not totally isolated. I can see what's around me because not only from the camera, also the device is not totally isolated. It just looks like a regular goggle. So I can see here, as you can see here, not this screen, the other screen, I am looking at a COVID patient. So this helps the physician, and for the patient safety and also physician safety, or not just physicians, also nurses and other healthcare professionals, you can simulate the situation where you examine a COVID patient without being exposed to COVID. So now I'm actually looking, I can see the signs of COVID, and I'm also looking at his vitals at the same time. I can read, I can see his oxygen saturation, his heart level, heart rate level, and all of that. So this is very useful. This is one of the cool applications of this technology. Another example is this study. They did an experiment on training medical professions in communication skills regarding antimicrobial stewardship. So it was about prescribing antibiotics to people. These communication skills were unsuccessful with other methods, but this method using VR was successful. What they did, they took a group of people and showed them through this virtual reality technique how the physician is exposed to multiple situations where they are forced to prescribe antibiotics even though they do not have to. And then at the end, they were asked to reflect on their most recent experience of visiting a doctor, or also their experience of being a doctor prescribing the medication for others. And they concluded that they have noticed that there was greater self-awareness. The trainees modified their future reactions in a better therapeutic way. So it was a success for the authors, from the author's perspective. Another study was about, it was a systematic review of how immersive virtual reality was used for acute treatments of health conditions. And they concluded that immersive virtual reality has a promising future in healthcare, in both research and commercial realms, which leads to the next, this study was done last year. What they did was identify and analyze the scientific literature on virtual reality and augmented reality research in medicine. The objective of that study was to capture and describe common themes and medical conditions. What they found was that the major research themes were diagnostic and surgical procedures, as well as rehabilitation in both neuro and degenerative and mental health disorders. The benefits they have found in those studies, some of them were improving novice hospital residents' laparoscopic skills in terms of error and procedure time reduction, and assessing suturing skills. So most of the studies they found were about physical skills, like individual physical skills. As a surgeon, I am improving my techniques in surgery. I am improving my technique in laparoscopy, etc. But then also with the competency-based cognitive behavioral therapy, it's also an individual-based approach. Like I am a practitioner, and then I am treating this patient. So what do I do? Or even if the virtual reality was provided for the patients, it's also individual. Like, I am a patient, I have pain, so I need to have this virtual reality method to be distracted from my pain. So it's also, yeah, I see it as an individual thing. So what's the gap? In public health, I'm talking about. In public health, it's rarely an individual thing. We need to deal with multiple teams. We need to deal with multiple stakeholders that are not even in the same place. Like, we need to be contacting a lot of individuals in different places at different times. So how does virtual reality capture this for professionals to have their training? This is an example where those researchers, they have, it's a qualitative evaluation study. So they took a few students, 6 students, actually a few students from 6 disciplines: medicine, nursing, pharmacy, physiotherapy, occupational therapy, and social work. So they taught them or trained them how to use virtual reality as an interprofessional team. It was an interprofessional educational experience. So this is what I'm talking about. This is the situation that we usually face in public health. What they came up at the end, they came up with 3 themes. The themes of benefits the students gained from this. They gained insights into mutual rules. So each student better understood the different interprofessional roles of other team members. So as, let's say, for example, the disciplines here, as a pharmacist, I know now what a nurse should do in her role in this situation. Let's say I have an outbreak. What does the nurse do? What does the physician or clinician do? What does a physiotherapist do? So when I do this interactive, interprofessional team virtual reality, it gives me a better understanding of what other team members do. So I can help them with their role and provide them with the information they need and the support they need as well. And also it gives me a clearer picture on what my role in a team is. Another benefit or theme they have come up is seeing the patient as a whole. So instead of focusing on the situation, I am focusing on the patient. What is the best of what is the best for the patient? What is the best for the in public health, our patient is the community, not a single patient. So what is the best for the community? How do we come up with a better plan or the best plan as a team for this community? The last theme was gaps in real-world application. So due to system and structural constraints. So it mimics, when it mimics the real environment, we come up with possible difficulties or constraints that we can train ourselves or come up with solutions on how to overcome these shortcomings. So in summary, how is, what's the gap of virtual reality application in public health? From my review, I have noticed that most of virtual reality experiences are individualistic. So I did not see a lot of articles about simultaneous virtual reality experience for multiple users in different areas, different places. There are some challenges to that, but there are few articles like the previous one that I mentioned that are exploring this, which is promising. Another problem with that virtual reality is injury. So one of the functions of public health is injury prevention. However, using virtual reality devices could cause injuries because of the individual's isolation from their environment. They're only focused in the virtual reality that they cannot see what's around them. So people fall, they hit the wall or hit other people because of that. So is it safe to use? Probably not 100%. So we need to come up with other ways or solutions to overcome those side effects. Also, one of the challenges of applying virtual reality in public health is that areas of public health are very diverse and very challenging. Like we have different themes, we have different personalities, we have different populations. So a single program in virtual reality might not mimic the reality, but yeah, it could be a little bit challenging as well. Okay, so this is a video, but due to lack of time, I think you can see it later. I can provide you with the presentation. So it shows how we can use this virtual reality in a community and public health session or interaction. So this guy is one of the team members. So me, as the person wearing the goggles, I am looking at this person and asking him some questions. And then at the other end of the room, there's another person that I can contact or talk to for more questions. So it shows you with the interactive virtual reality, each person, like every person could present, like for example, this guy could be another person wearing another goggle, and we could interact with each other. This is also another video of the injuries caused by using virtual reality devices. Okay, so what are the areas of public health that virtual reality could be applied in? There's emergency preparedness, and I just spoke about that example of that. There's health protection, disease and injury prevention. Although virtual reality could cause injuries, we can use other advanced techniques like mixed reality, the one that I tried last week, or we can use like augmented reality. All of these could minimize injuries. Also health promotion, where we can practice or mimic how programs are established, campaigns that are established, and also for health assessment and surveillance, we can simulate the data processing and extraction part of those two areas. This is a study that was done last year. It is a design of a virtual reality interactive training system for public health emergency preparedness. They named this experiment as People's War Against Pandemic. What they did when they designed this, they focused on 5 elements of educational content. The first one is they wanted to teach the trainees how to cooperate with prevention control work, how to improve emergency responsibility, how to guarantee the presence of supplies and equipment, how to prepare for economic resources, and also how to maintain physical and mental health during the emergency. So as a conclusion, simulation, especially virtual reality, are excellent solutions. They're very excellent to simulate the situation, yet they're still developing, but they can help to improve the practice in the area of public health, the concerned area. Also, another take-home message is new emerging technologies such as virtual reality, interactive training system, and mixed reality systems could provide us with what traditional virtual reality systems could not. So it's probably for myself, I would like to explore more about these newer technologies. Like virtual reality is still considered new, but I would like to look at the advanced techniques like the mixed reality system and the interactive system, and see how I can use that for simulating situations or experiences in the field of public health. Yeah, and also it would be nice if we could do an exploration of the areas that these new technologies could be useful in the areas of public health that I mentioned before. And that concludes my talk, and these are my references. Thank you very much, and if you have any questions, please let me know.
So thank you, Dr. Noha, for your great and informative topic. If there is any question or comments for Dr. Noha, just raise your hand or type it in the chat box before I will start my questions for her. So, Dr. Noha, I have 4 quick questions for you. The first question is, what's the positive effects for the virtual reality and patient safety?
So one of the things that I noticed about the relation of virtual reality to patient safety,
yes,
is you practice being in the medical setting, let it say surgery or any procedure, any kind of procedure that could harm the patient. if I did some errors. So practicing that will make me better trained. So the side effects of the procedures will be less and more controlled. And the other one, let's say, for example, in public health, if I was trained to deal with emergency situations, it's going to come up to me very easily when I have an emergency situation, because I did it multiple times already. So I can easily interact, and it becomes as a second nature to me, because yeah, I am well practiced in that area.
Sure. And in your opinion, do you believe that virtual reality is the future of healthcare? If yes or not, with why?
I think I do believe that. It's not the whole future, but it could be a useful tool in our toolbox, because of course it's not going to be a total replacement to other techniques, but I see it as a supportive tool, because sometimes, as I said before, in public health, we do not get exposed to these situations. So I need at least something to get prepared with. If I didn't have that, or even let's say for surgeries, sometimes you tend to perform very rare surgeries that you are not exposed to regularly. So at least you can practice it before you do it in real life.
Great. And my final question is what about the Saudi Vision 2030, is there a part for the virtual reality and patient safety?
Yes, it is, because it's not specifically stated, but it's one of the what can I say? Like the key performance indicators are to decrease the harms caused via healthcare professionals. And so the focus in health education is now directed towards simulation in general, and virtual reality is part of that. We're still exploring that, but we don't have, we are still not experienced in that field. That's what I noticed from last week's conference, but I see a lot of interested stakeholders, let's say, for example, in the Minister of Health, people and Minister of Education. They all want to incorporate that training modality into their schools, into their work environments. So I see a strong direction towards that area, which is part of our country's vision. Yeah.
Thank you, Dr. Nuha, for your great, informative, and excited topics. I would like to ask you to stay with us to meet our last speaker for the day and our last speaker at our conference. Let's all of us welcome Dr.
Thank you very much.
You are more than welcome. Let's all of us welcome our last speaker, Dr. Mahmoud Radwan from KSA. I'm passing him the stage to deliver his speech on the COVID-19 pandemic and primary healthcare. What did we learn from the crisis? Dr. Mahmoud, the stage is yours.
Thank you very much. Thank you for having the opportunity to participate. Like Dr. Noha, this time we are participating online. We hope next time to be there physically attending the conference and
Inshallah, hope so.
Okay, so let us
share your screen.
Sharing my screen now. Can you see it?
Yes.
Okay. So in this presentation, we are going rapidly to try to explore what are the main rules done by primary healthcare sector during the pandemic and what we learned as lessons for the future from this pandemic. So I am going to start by one of the best quotes describing what we passed through during the last 3 years, that we are in this together and we will get through this together. It is one of the best quotes mentioned by the United Nations Secretary General Antonio Guterres in the conference done in the start of the crisis of the pandemic COVID-19. So rapidly, if we can go through the past, the start was in March 2020 by the first case, and then declaring it as a global pandemic, and then passing through the lockdown and all the effects affecting the whole world. If we are going to the statistics of COVID-19 dashboard till yesterday, we are speaking about a pandemic with cumulative cases exceeding 600 million cases all over the world, and the mortalities exceeded 6.5 million deaths during the whole 2 years. Of course, the distribution of the impacts are not equal. Some countries faced more tough and challenging situations compared to other countries, but the whole world at the end was affected by the situation. If we are coming to the other perspective related to the COVID pandemic, which is the vaccination efforts, we are speaking now about more than 12 billion doses of the different kinds of vaccines available administered all over the world. We are speaking about 5.4 billion persons received at least one dose of the vaccine, and 4.9 billion persons fully vaccinated according to the protocol of different kinds of vaccine, either to have the 2 doses or a single dose. So now we are coming to discuss the issue from the perspective of primary health care. So for primary health care, as we know, it is the whole of society approach to health that aims to ensure the highest possible level of health and well-being and their equitable distribution by focusing on people's needs and as early as possible along the continuum of healthcare promotion and disease prevention to treatment, rehabilitation, and palliative care, and as close as feasible to people everyday environment. This is the main description according to WHO and UNICEF in the document A Vision for Primary Health Care in the 21st Century. And as all of us are aware, primary health care is one of the main issues coming in the universal health coverage and sustainable development goal adopted by the United Nations. Primary health care approach is based mainly on 3 main components: meeting the people's health needs through their lives. So the focus is much more perspective than fighting disease or preventing disease. And the other issue, it is addressing the broader determinants of health through multi-sectoral policy and action. So now we are speaking about that the whole community or the whole society with all stakeholders should be involved. It is not only the role of the healthcare system or the healthcare professionals only alone. And this is why the third component is based on empowering individuals and families and communities to take charge of their own health. By providing care in the community as well as care through the community, primary health care addresses not only the individual and the family healthcare needs, but also the broader issues related to the public health and the needs of the whole population. We are speaking about a long journey for more than 40 years. We are speaking about the real start of this sector in the Alma-Ata Declaration in 1978. It was the first international conference focusing on primary health care and asking for urgent actions by all governments to develop and to improve this sector and to promote the health for all. And in this conference, we started to focus on certain concepts which are now very familiar to everyone in the healthcare system: health for all, primary health care, health as a fundamental human right, equity, and health inequities, addressing them, the intra-sectoral development, the community participation, and starting to adopt the appropriate technology. Then after 40 years, we have the Asitana Declaration in 2018, after 40 years from the first one, and it is also focusing on the primary health care and how we can improve it globally. This is why in the Sustainable Development Goals adopted by the United Nations, which we have in which we have almost 17 goals addressing all aspects of life, economy, education, healthcare. Healthcare is coming as the third goal in the set in the Sustainable Development Goals, and one of these initiatives or goals under this main goal related to healthcare is universal health coverage and improving the public health and addressing the issues related to access to care, quality of care, and even the financial problems impeding such progress. This is the Sustainable Development Goal number 3, and it is the initiative number 8 in this goal. So if we are going to look deeper in this area, we have here the integrated healthcare services with an emphasis of focus on primary care and essential public health functions, and empowering people and the communities, and the multi-sectoral policy and action from all stakeholders. Then we have different levers, some levers at the strategic level and some levers at the operational level. At the strategic level, we have political commitment and leadership, governance and policy framework, funding and allocation resources, engagement of communities in and other stakeholders. Operational levels, we are addressing here the issues like model of care, primary healthcare workforce, physical infrastructure, medications, engagement of private sector, because in most countries, in almost all countries, public healthcare is the main responsibility done by governmental sector. Private sector is not well entrenched in this area compared to, for example, acute care. Digital technologies, all these issues will help in the operational aspects. And the results should be improving access and utilization and the quality of care provided by this sector, improving participation and enhancing the health literacy and care seeking, and improving the determinants of health so we can address the health inequities. So at the end, we are able to achieve the universal health coverage, which is a main pillar for achieving the third sustainable development goal, aiming to improve health and well-being. And according to the facts published by WHO about primary healthcare sectors, we are speaking about 930 million people worldwide at risk of falling into poverty due to out-of-pocket health spending, more than 10% of their budget for healthcare. Also, scaling up primary healthcare interventions across low and middle income countries could save 60 million lives and increase average life expectancy by 3.7 years by 2030. Achieving the targets of primary healthcare requires an additional investment of around $200 to $370 billion for a more comprehensive package of healthcare services. And at the United Nations high-level universal health coverage meeting in 2019, countries committed to strengthening primary health care, and the WHO is recommending that every country allocate or reallocate an additional 1% of the gross domestic income to primary health care from governmental and external funding sources. So these are the facts even before the COVID-19 pandemic. So we can see that primary health care is facing tough situation and a very challenging situation to achieve even the sustainable development goals. But during the pandemic, it became more worse because primary health care was involved in providing more rules related to the pandemic, and there were a lot of challenges preventing the primary health care from functioning in the appropriate way to provide even the basic services. So during the COVID-19 pandemic, and according to the WHO studies, the primary healthcare sector was responsible to provide timely and effective and safe supportive management of patients with suspected and confirmed COVID-19 at the primary care level. This was an additional and very challenging task and role thrown to the primary healthcare sector. In the same time, primary healthcare sector was responsible to support and to maintain delivering the essential healthcare services at the primary care level during the lockdown and during the outbreak. And also it was another big responsibility was how to facilitate and how to lead all the COVID-19 vaccination programs and efforts all over the world. So during this time, it was very, very difficult. And according to several studies from different countries, we have a lot of challenges preventing primary healthcare sector from maintaining the delivery of the essential healthcare services, like, for example, the vaccination of children in different countries. Also, identifying and managing potential cases properly and in a rapid way also, and timely response was also another challenge. Avert the risk of transmission of infection to contacts and tracing this and protecting the healthcare workers was another issue addressed by the primary healthcare sector. Maintaining or enhancing the existing surveillance systems, such as for influenza-like illness and severe acute respiratory infection, and how we can improve such systems to respond to the challenging situation was another important task for the primary health care. Strengthening the risk communication and the community engagement and support the provision of vaccination programs against different diseases and of course against COVID-19. So for this to be able to provide all these rules and to carry out all these rules in an effective way, the primary healthcare sector should focus on 3 areas: planning, resource allocation, and regulations. So according to the guideline or the framework published by the WHO about the role of primary healthcare in COVID-19 response, there are 4 main areas: identification of context-specific services, provision of context-specific services, using innovations, and communication with the community. These are 4 levers we should always utilize to be able to provide all the rules assigned to the primary healthcare sector. First area, provision of resources to deal with COVID-19 pandemic. Here we are speaking about the infrastructure. We are speaking about the healthcare workers, the medications, the supplies, and here we will face also another new challenge related to all the supplies related to the personal protective equipment and detergent and alcohol and all these N95 masks, all these supplies. I think for some time, all healthcare organizations and all healthcare workers faced tough challenge to have an access to such supplies. This is why we had in this time new guidelines allowing, for example, the reuse and the reutilization and the disinfection or even sterilization of some of these supplies to be reutilized again, not compare the situation before the COVID-19, and also the risk communication and the community engagement, because this was also a very important task. Then we are coming to the second area or the second rule, which is managing identified and suspected COVID-19 cases. In this area, primary healthcare sector was aiming to identify and do the proper triage and do the proper isolation of suspected COVID-19 cases, and to manage suspected or confirmed cases according to the status, either through home isolation or referring to healthcare organization in the right way, transportation to hospital for indicated cases, the environmental cleaning and tracking of follow-up contacts and notifications, and building the database and the statistics required to take proper decisions by the decision makers, and other considerations related to digital health like e-health or telemedicine, or using all these innovative techniques to provide healthcare services was widely accepted during the COVID-19 pandemic. For example, if we are taking the surveillance systems applied during this crisis, and we are taking Europe as an example for somehow we can speak about a well-developed, well-established healthcare systems. They created two levels, at the European level and at the national level. At the national level, the objective was to identify and control outbreaks in the healthcare settings and to identify and control outbreaks in the long-term care facilities and closed communities. And the actions was aiming to protect healthcare professionals and patients and protect the high-risk groups or the high-risk populations who are more vulnerable or liable to the severe disease and poor outcomes after getting the infection. At the European level, we have 4 objectives: mainly monitor the intensity and geographic spread and severity of COVID-19 in the population. And the action was to estimate the impact of the disease on the population, identifying the appropriate preventive measures, identify the new variants of the virus to improve the research, facilitating drug and the vaccine development, evaluate the impact on healthcare systems to improve resource allocation and to mobilize some resources, manpower, or supplies to the more affected areas, and evaluate the impact on mitigation measures to help authorities to identify and assess the timing and the intensity of all the preventive measures applied, like applying the total lockdown or partial lockdown or all the other restrictions adopted during the COVID-19 pandemic. So for these surveillance strategies, as we said, there are certain actions like comprehensive surveillance, sentinel syndrome surveillance, helpline surveys, hospital-based surveillance, mortality surveillance, qualitative indicators. Of course, in all these kinds, primary healthcare was involved and was a main player. Also the data base utilized to manage the healthcare system in general, also it was mainly based on the data collected at the primary healthcare level related to the incidence, related to the infection rate, the contacts, the geographic spread, and also the routine surveillance to trace or to track outbreaks either in healthcare organizations or outside healthcare organization. And also another main area was the escalation or de-escalation and maintenance of mitigation measures and restrictions in the community. It was also depending on the information coming from the primary healthcare sector and the expert opinion coming from public health service leaders. So during this, we discovered that we have a lot of challenges and a lot of limitations. These challenges can be attributed to many factors, especially in developing countries, like lack of financial resources, lack of adequate training, lack of technology, sustainability issues, standardizing the data collection method and indicators and the operational definitions across different countries so we can compare the data coming from different countries in the right way. Limitations, also we have some limitations like the underreporting of COVID-19 cases, the mild and asymptomatic cases, which usually were not going to seek any medical advice, the lack of any longitudinal studies or clinical trials due to the short duration of the disease, also limited testing capacity and the under detection of imported cases and the poor quality of the data collected. The third area also, which was very important for primary healthcare sector, and we can speak that primary healthcare sector was a main player in this area, was leading and managing the COVID-19 vaccination programs and efforts in all countries. So here we have very, very challenging areas like facility and infrastructure, health training, healthcare workforce, also the service delivery adaptations, the vaccine and commodity supply and storage, especially that we know that some of these vaccines, or almost most of them, they require specific storage conditions under certain temperatures. Communication and community engagement to make the vaccination programs successful was very important, because as we know, the COVID-19 vaccine hesitancy and resistance also was very high, and this can be attributed mainly to the miscommunication or lack of effective communication and the misinformation in all communities, which happens in all communities. So from this crisis, we can take 3 main lessons all of them are aiming to strengthen primary healthcare services in the future. So here, the first one was to have more established, more developed primary healthcare services. And from one of the most fascinating studies, which was published in Italy, they were speaking that after the crisis, when they did an intensive analysis or in-depth analysis for the situation, they discovered that they focused more and more on the acute healthcare system, big hospitals providing acute care to patients, comparing their primary healthcare sector to their acute healthcare system. Primary healthcare sector was not taking the main focus. This is why in the crisis, it was also a big challenge for them how to go and move during the crisis. And all of us know, Italy was one of the most affected countries during the crisis in Europe. The other area, also the other lesson, is to improve the data quality. During the crisis, we can admit that as a healthcare sector, we are not benefiting from the big data collected or available to us during our work. Although we have very, very huge amounts of data coming from every single step or action we are doing during provision of services, during assessing patients, during every step in our system, but we are unable to benefit from most of this information or data. We are unable to convert these data to useful information to take informed decisions. So we need to improve the data quality, which means that we need a lot of efforts and working on all several aspects of data management system: data collection, operational definitions, analysis, completeness of data, timely collection of data, integrity, consistency, accuracy, and of course, utilizing the advanced technology and the smart solutions will be essential if we need to go forward in this area. The third important also lesson we need to admit that we discovered that it was very important during the crisis is to admit the effective impact or the clear impact of the health inequalities in our populations and addressing such health inequities by working in awareness and measurement and action to improve the health equity and provide accessible and good high quality services for everyone in the community. This will create too much difference, because at the end in this crisis we discovered that even if some populations are deprived from good access or free access to healthcare systems or from good quality healthcare services, and they are affected and they are infected, the whole community during the crisis will be affected at the end. So you cannot achieve the benefit for the whole community without providing this access to everyone and these services to everyone. So I will just close the session by the main also quote from Joseph Borrell in the European Union, that COVID-19 will reshape our world. We don't yet know when the crisis will end, but we can be sure that by the time it does, our world will look very different from the past. Thank you. And any questions are welcome, of course.
Thank you, Dr. Mahmoud, for this great topic and this great explanation. If there is any question, just raise your hand or write your question in the chat box before we will continue with Dr. Mahmoud for his poster. But I have a small question. You have spoken about COVID-19 pandemic and the primary health care, what we did learn from the crisis. Okay, in your opinion, what will be the next step after the COVID will end? will end?
I think from several studies coming from many countries that they discovered the importance of the primary healthcare sector.
Mm-hmm.
Past before the COVID-19 pandemic, the focus, the attention, the resources,
mm-hmm.
the best resources are going to the acute care healthcare system. The best physicians, the best nurses, the more resources are going to the hospitals, to the big hospitals. While on the other side, the primary healthcare centers are deprived from many important resources and are running or operated in poor conditions.
Mm-hmm.
Now, in this crisis, we discovered that this is the front line and we need the front line to be always ready.
Yes, thanks for your great topic and a great explanation. Let's move now for your electronic poster about COVID-19 vaccine hesitancy in the Eastern Mediterranean region, a scoping review for the available literature.
Okay, so
The speech
can I
is
share my screen?
Actually, not yet.
Okay, 1 second.
Yes, now we can.
Is it?
Yes,
Okay.
yeah, it's clear.
Okay, so in this poster, rapidly, we are continuing with COVID-19. So we are selecting one topic, which is COVID-19 vaccine hesitancy, and we are focusing on the Eastern Mediterranean region. It was a scoping review by doing literature review for the available published studies about this subject for this region. So as we said, we are speaking important issue, same data we spoke about. Then we have, if we are going to focus on the COVID-19 vaccine, we are speaking about a vaccination effort or programs started in December 2020, and now after almost 2 years, we exceeded 12 billion doses of vaccinations administered all over the world. Of course, the distribution is totally unequal. If we are going deeper to see the distribution of the vaccination programs or efforts all over the world, we can see that the high income or the upper middle income countries or parts of the world, we can see very effective vaccination programs, and we have the doses administered per 100 people in the group is very high. Then we can see the lower and middle income countries are coming after this, and then the low income countries, and we can see the big variation between the three groups, which can reflect the impact of the socio-economic factors on the health outcome and on the effectiveness of healthcare services. Again, we can see here, if we are going by country, for to see the number of doses administered per 100 people in the population. Overall, for the whole world, it is 162, and we have a lot of countries exceeding this rate. We have countries like United States, like China, Brazil, even some European countries, very high rates compared even to the global rate. But on the other side, we can see many countries below the global rate. We are selecting some examples like India, like Pakistan, like Russia. But if we are going to African countries or poor countries like in Asia, like Yemen, like Syria, some countries like this, we are speaking about very low rates. Yeah, we are comparing, for example, between 162 globally, and in Nigeria, for example, it is only 40. We are speaking about very big variation. So if we are going to analyze our data based on the WHO regions, we have almost 6 regions in the WHO geographical regions. And if we are going to see the total vaccine doses administered per 100 population, we can see that the African group and the Eastern Mediterranean region, which is mainly representing the Middle East between Asia and Africa, North Africa, we can see that both of them are showing the lowest performance, very low compared to the other regions in North and South America, in Europe, in even the Western Pacific region. So if we can compare, we can see that the performance of these two areas is very low. Then if we are coming to the percentage of people who are fully vaccinated, the rate of people fully vaccinated per 100 population, also we can see here the gap between high income, upper middle income, lower middle income, and lower income groups. If we are speaking about the same rate by the regions, also we can see Eastern Mediterranean region and African region are coming at the end of the distribution compared to the other 4 regions. So COVID-19 vaccine hesitancy is a complex and a dynamic phenomena affected by a wide variety of factors, and the severity of the phenomena and the impact of such factors vary across different regions, countries, and populations, even in each country. And so each country has its own unique and different journey compared to the other country, and the factors can be attributed to population, to demographic factors, healthcare system, socioeconomic conditions, education, and culture, and religious beliefs even playing an important role in this one. Vaccine hesitancy, which is described as a behavior or an attitude, or both a behavior and an attitude perceived on a continuum ranging from refusal, total refusal, to acceptance, is one of the top 10 threats affecting global health by the WHO in 2019. This was even before COVID-19, which is aggravated and became more important by the immense threat of COVID-19 pandemic. Vaccine hesitancy is defined as a delay in acceptance or refusal of vaccines, although of their availability, which is a highly complex problem influenced by many factors related to complacency, confidence, and convenience. Vaccine hesitancy is an important challenge impeding the achievement of higher rates of vaccine coverage. And despite the marked rise in public awareness and knowledge regarding health issues in the modern era, modern vaccine hesitation still persistent, still a challenge, and it can be attributed to several factors, including mainly the layperson heuristic thinking in assessing the risk-benefit balance. Here is the Eastern Mediterranean region, and we can see it includes countries from North Africa, except Algeria, Morocco, Libya, Tunisia, Egypt, Sudan, Somalia, Djibouti. And then we are going to Asia, so we are taking the Gulf region, and we are taking Jordan, Syria, Palestine, Yemen, Oman, and even we are going to some other non-Arabic Asian countries like Afghanistan, like Pakistan, like Iran. So it is almost the Middle East. And as we can see here, even which will appear is the data, even these countries are not homogeneous. We have very rich countries with good income, and we have also on the other side very poor countries with very difficult socioeconomic conditions, and this can be seen even in the study. So if we are going to check and compare the countries of the same region, here we can see that the recovery rate and the vaccine uptake rate, and we can see very, very, very outstanding performance in some high income countries like Saudi Arabia, like United Arab Emirates, and compared to other countries like Afghanistan, like Yemen, like Iraq, like Sudan, like Syria. Here we have very, very, very low vaccine uptake. This is another evidence how much the impact of the socioeconomic conditions on the health outcome at the end, because in the same region, but the main difference is coming in this area, socioeconomic conditions, and the difference or the gap in the health outcome is very evident. There are two initial observations after completing the scoping review process, which is a literature review for the all literature published about COVID-19 vaccine hesitancy in this region. The first observation is the relatively low number of research studies conducted about COVID-19 vaccine hesitancy in the Eastern Mediterranean region compared to other similar studies conducted in other regions, except the African region. The African region is much more lower even compared to this region. But for the other 4 regions by WHO, we can see very, very huge number of studies published about this topic. The other issue that most of the studies we found about COVID-19 vaccine hesitancy in the Eastern Mediterranean region was depending on quantitative methodology in the form of surveys or questionnaires to get numerical data. There is no available researches, too many researchers trying to utilize different kinds of research methodologies to enrich the literature. The total research studies identified and included in this scoping review was 137 research studies, and the scoping review was used based on clear objective data. So it was selecting articles published in English language till the middle of 2022, discussing any country from the Eastern Mediterranean region, and the main focus is COVID-19 vaccine itself. For the research methodology, from these 137, we can find 116 totally depending on quantitative methodologies, as we said, in the form of a survey or a questionnaire, and collecting data, numerical data to be analyzed. 7 studies only depending on qualitative studies, and 5 studies were mixed, and we have also 9 coming under other types of methodologies, like article review, like case review, something like this. If we are comparing to the countries, this is another example that we can see here. Most of the available studies were conducted or were done in Saudi Arabia. Then we have coming after Saudi Arabia, we have countries like Pakistan, like Jordan, like even Jordan and Egypt. Then we have other countries with almost no studies or very, very, very rare studies, like Syria, like Sudan, like Oman, like Syria, Sudan, Djibouti, Libya. What we noticed also for Morocco and Tunisia, that very low number of studies, but this can be attributed that the study, the scoping review was selecting articles published in English language. And as we know, this part from the Arab world, Tunisia, Algeria, Morocco, the main language utilized there is the French language. So we are assuming that maybe other studies or articles may be available, but in French language, so they are not coming in our study. This is one of the limitations even in our study. For the target population, 91 of these studies were focusing on general population. 17 studies tried to focus on healthcare workers. 12 studies focused on special populations like refugees, like parents, like certain group of populations. 9 only high-risk patients. 4 students of medical college, and 4 studies comparing medical and non-medical people. The hesitancy in medical people, workers or students, compared to the general population. For the research focus, we can speak that most of them, 88 of these studies were focusing on factors affecting the COVID-19 vaccine hesitancy. Then 20 studies are focusing on estimating and measuring the COVID-19 vaccine hesitancy. 9 on the impact of social media or misinformation. 9 studies strategies used to address COVID-19 vaccine hesitancy. 5 studying the impacts of a particular set of factors. 4 comparing medical and non-medical people attitudes toward the vaccine, and 2 studies using conceptual frameworks to understand the phenomena. The big similarity in the factors affecting COVID-19 vaccine hesitancy across the world, where high vaccine hesitancy is usually linked with low-level education and awareness, lack of effective governmental efforts, poor history for taking influenza vaccines. There was a very good relationship between both, and believing in conspiracy theories and misinformation about COVID-19 vaccines disseminated across social media. Vaccine hesitancy is associated also with middle age groups, 20 to 40 years old, due to what? Because this age group, they have low perception of the disease threat and risk. They are mainly not afraid from the disease. They feel that it will be safe for them, the outcome will be good for them, so they may not be careful about taking the vaccine. Among all these factors, there is a significant harmful impact of the infodemic accompanying COVID-19 pandemic. Infodemic is a term even used by the WHO to describe the wrong information coming about the COVID-19 vaccination. And this was a main challenge facing the vaccination programs. And this infodemic can be divided into 2 main areas. Disinformation, which refers to wrong information associated with malignant intentions to do this, and the misinformation referring to spreading wrong information without these malignant or bad intentions. So strategies which you can be used to address the COVID-19 vaccine hesitancy here, according to the WHO even guidelines, we can work, especially in low and middle income countries, on main 4 areas: increasing the cooperation between the WHO and its regional offices with relevant authorities at the country level to enhance community engagement, build a strong collaboration with all stakeholders in the community, the civil organizations, the non-profit organizations, the manufacturing companies, all the stakeholders who can push for this programs, sharing knowledge and experience and lessons learned from previous similar situations and across different countries, and providing more resources, including vaccines, infrastructure, training staff, and cold supply chain and financial resources from national or international funders. Also for the strategies, we highlight some important facts. First one, involving physicians in the targeted vaccination campaigns by counseling their patients on the vaccine hesitancy to provide accurate information is very important. In all studies, whenever we have committed physicians or committed healthcare workers who are believing in the vaccine and who are enthusiastic to push the vaccination program forward, we have good impacts can be seen for the population. The second area that customized vaccination programs or campaigns can be initiated to address the concerns and the requirements of each population. For example, the concerns of parents about the impact of the vaccine for their children is different from the concerns of certain high-risk patients who are suffering from certain conditions and they are afraid from the vaccine, different from the old age groups. So each age group or each population, they need somehow to customize the message disseminated to them and to customize the vaccination campaign addressing them. Also disseminating public service messages to focusing on the fear appraisal through traditional and social media to encourage people to get the vaccine before being infected is the most effective communication strategy. And it was noted that public confidence in the COVID-19 vaccine and the healthcare system is a key success factor for any mass vaccination program. In all countries where the general population have good confidence in the national healthcare system, we can see higher rates of COVID-19 vaccine acceptance. And when we have less confidence in the healthcare system, we can see higher rates of COVID-19 vaccine hesitancy. Thank you. And any questions also are welcomed.
Thank you, Dr. Mahmoud, for this great poster and a great explanation. Is there any question for Dr. Mahmoud, sorry, before closing the conference? So it seems there is no any more questions. Thank you, Dr. Mahmoud, for everything. And thank you for your speech and for your time with us. I would like to announce that certification will be provided on November 20 for the online attendee, and UCG is organizing the 12th International Nursing, Healthcare Management and Patient Safety on July 25 to 27, 2023 in Dubai, the UAE, and the 13th American Healthcare and Hospital Management Summit on November from 15 to 18 November 2023 in Los Angeles, the USA. So I hope we will meet again with new research and innovation in the field of healthcare. It's been an honor to be among such accomplished individuals and to be able to present my perspective before you all. Thank you and good evening and good day for you all. See you in Dubai soon.